Good morning to all the distinguished delegates, respected faculty, honored guests and dear colleagues. I am Dr. Malempati Saigitika from Department of General Medicine and this is Dr. Tathagat from Department of General Medicine. It's an absolute pleasure to welcome you all to the Telangana Emergency and Critical Care Toxicology Conference 2025 hosted by Mamata Medical College, Khammam. This conference is being conducted under the aegis of Association of Emergency Medicine Educators and organized by Department of Emergency Medicine. Today's gathering brings together brilliant minds who navigate the razor-thin margins between crisis and cure. The physicians who transfer chaos into clarity and emergencies into survival stories. Emergency medicine is a field where every second carries weight and toxicology is where knowledge translates directly into survival. It is truly inspiring to see so many brilliant minds gather here to sharpen the tools and shape real world outcomes. Over the course of this event, we will dive deep into cutting edge toxicology, emergency protocols and critical care strategies and evolving sciences that define frontline medicine. Each session promises to be a treasure chest of insights, evidences and shared experiences. A heartfelt welcome to every expert, speaker, resident and student and clinicians who have joined us today. With your presence amplifies the spirit of learning, collaboration and innovation. We are truly honored to have all of you here.
For the first session, it's my honor to invite the chairpersons, Dr. K. Srikanth, Professor of General Medicine, Mamata Medical College, and Dr. P. Srikanth, Professor of General Medicine, Mamata Medical College. And to start the day, it is my pleasure to invite our esteemed speaker for the first talk, Dr. K. Shivaram Krishna sir, HOD and Professor, Department of General Medicine. Sir has over 30 years of experience, had completed his MBBS in Osmania Medical College and was also the organizing secretary for TS APCon 2024. I invite sir to provide his insights on management of snake bite in an Indian scenario.
Good morning everybody. Today my topic is snake bite and its management in Indian scenario. We will cover these topics under these headings. Snake bite is an acute medical emergency, life-threatening, and it's preventable public hazard. Around 300 species of snakes are present in India. Out of them, 52 are venomous. And India, we face around 50,000 deaths annually. That accounts for around 40% of the deaths globally. The global death rate is around 1,25,000, whereas in India itself, we are facing 50,000 deaths. We are losing especially young patients. So we are the global capital in snake bites and its mortality. So lot need to be improved in India. And basically we have three types of venomous snakes, Elapidae group, Viperidae and Hydrophinae. And the big four are cobra, krait and two types of vipers. These are the four pictures of the four dangerous snakes. And snake venom contains many proteins, enzymes, non-enzymes, and non-toxic proteins. And most important, among them, the most important are hyaluronidase. This is the cause for cellulitis. And zinc metalloproteinase hemorrhagens. This damages the vascular endothelium and causes systemic capillary leakage and coagulopathy. And procoagulant enzymes. These procoagulant initially they cause a thrombotic state, but on consumption coagulopathy they lead to bleeding diathesis. And phospholipase A2 lecithinase, they are neurotoxic. Sorry. Okay. Then Among the neurotoxins, we have basically two types of neurotoxins, postsynaptic and presynaptic. This point is very important in the management of kite and cobra bites. Cobra bites usually respond to neostigmine, whereas in kite it's presynaptic. So we have to keep this point in mind. So these are the pictures. Postsynaptic is cobra, presynaptic is kite. And symptoms: local, systemic, and effects of anxiety, and effects of first aid and other traditional methods. So local, it's cellulitis, swelling, gangrene, blistering, ulceration, compartment syndrome. And systemic, we get cardiovascular, hemotoxic, coagulopathy, AKI. And effects of anxiety. Initially, the patient may present with similar to sympathetic storm, and especially in India, the traditional methods are very famous. They delay the treatment and they are harmful. They do lot of electrocution, sucking, cutting. So all these may turn out to be hazardous also. They not only delay the treatment, but they turn out to be hazardous. So basically, local, vasculotoxic, neuro and myotoxic. And clinical presentation depends upon the age and size of the patient, species of the snake, number and location of the bites, and quantity and toxicity of the venom. And dry bites, they are not only non-poisonous snakes, even poisonous snakes, around 50% of the bites can be dry bites. So even when the patient was bitten by a poisonous snake, the bite may be dry. It may not have injected the toxin. So all poisonous snake bites are not venomatous. Around 50% of the poisonous snake bites are dry bites. But initially they can present with anxiety, palpitations, tremors, sweating, and may look like a venomous situation. And around 50%. And remember, even the bite by a small snake should be treated as a large snake bite. Chinna pamunaina pedda kadato kottali. And non-specific features: palpitations, sweating, tremors, tachycardia, tachypnea, dilated pupils, vasovagal shock. And local manifestations: redness, rise in temperature, swelling, tenderness, blistering, gangrene. And systemic neuroparalytic symptoms we can divide into 2 P's and 5 D's: ptosis and paralysis. And 5 D's: dyspnea, dysphonia, dysarthria, diplopia, and dysphagia. And usually the neuroparalysis symptoms starts within half an hour to 1 hour. But remember, in crate bite, the symptoms can start even after 36 hours. So just don't discharge a patient of crate bite after 24 hours if the patient is totally asymptomatic and normal. You have to wait for minimum 36 hours for crate. And ptosis is the first thing to develop. So whenever you are suspecting a neurotoxic snake bite, we should be observing for development of ptosis. Then it descends. Double vision, dysarthria, dysphonia, dyspnea. So this is a broken neck sign. And we can identify impending respiratory failure by these tests: single breath count, breath holding time, and ability to comply in one sentence in one breath. So if the patient can count 1 to 13 single breath, there is no respiratory distress. If he can complete one sentence, or if he can hold the breath for 45 seconds, so at that time we can say that he is not going to develop respiratory distress at that time. And remember, locked in syndrome. In neuroparalytic snakes, we can get locked in syndrome where all the reflexes are gone, power will be 0, pupils will be dilated and fixed. Only vertical movements of the eyeball will be retained. So we can, and there is a chance of declaring the patient as dead. So, these are the causes of locked-in syndrome, and Pons lesions, acute polyneuropathies, myasthenia gravis, toxins, snake bite. So, remember, bilateral, dilated, non-reacting pupils is not always a brain dead patient. We have to go for EEG and cerebral angiograms to confirm the death. So, this is most important. We should not miss a locked-in syndrome and declare the patient dead. And vascular toxins, basically they have local and systemic. Local is swelling, pain, bleeding, blistering, necrosis, and regional lymph node enlargement, compartment syndrome. And the compartment syndrome, the 5 P's: pain, pulselessness, paresthesia, pallor, paralysis. Bleeding can occur from anywhere: gingival, epistaxis, ecchymotic patches, hematemesis, hematuria, subconjunctival hemorrhage from the site of bite. And remember, they can present with IC bleed. The snake venom contains procoagulant. So, initially they can present with thrombotic stroke, initially, but later on they can present with hemorrhagic stroke also. So, snake bite is a differential diagnosis both for thrombotic as well as hemorrhagic strokes. So, they just can present similar picture like to CVA. And the lethal complications are acute kidney injury, systemic capillary syndrome, compartment syndrome. So, AKI is more common with viper bites and bilateral renal angle tenderness, albuminuria, hematuria, hemoglobinuria, myoglobinuria, oliguria, all features of AKI. Systemic capillary leak syndrome present with hypotension, hypoalbuminuria, anasarca, hemoconcentration, the more common with viper bites. So, you can have polyserositis picture, pleural effusions, ascites, puffiness of face. So, something picture similar to hypoalbuminuria and anasarca. And the rare complications, we can have infarction, hemorrhagic infarction of the anterior pituitary gland leading to acute Sheehan syndrome, later on pan pituitary, hypopituitary. So, initially they can present with shock, hypoglycemia. Later on they can present with weakness, loss of secondary sexual characters, testicular atrophy, amenorrhea, and hypothyroidism. And recently, just 3-4 months back, from Chennai, one case of Hirata syndrome was notified. The snake venom producing antitoxins, autoimmune, they bind to insulin, they cross-react with insulin, they bind to insulin, and due to erratic release of insulin, we can get hypoglycemia. So, autoimmune insulin antibodies leading to hypoglycemia. The treatment for, they have treated this case with plasmapheresis. I think this is the first case of Hirata syndrome secondary to snake bite. This is reported from South India, from Chennai. And steroids, immunosuppression may have a role in the management of this autoimmune syndrome. Myotoxic snake bites, they present with rhabdomyolysis, dark brown urine, then myoglobinuria, hemoglobinuria, and secondary hyperkalemia. This hyperkalemia can lead to cardiac arrhythmias and sudden death. And one more thing to be remembered is occult snake bite. Especially in our endemic zones, the patient can present with just acute abdomen. There is no history of snake bite, no fang marks. This is more common with crate. So, remember, any child presenting with early morning acute abdomen and landing in respiratory distress, snake bite is one of the priority to be thought. Then differentiate between GBS and neuropathies of snake bite. Snake bite is descending, it starts with ptosis, then descends. Whereas GBS, it ascends. And neurotoxic, basically cobra and crate. Cobra, you have local swelling, whereas in crate, you may not see any fang marks or local swelling. And all vipers are usually hemotoxic and can lead to shock and AKI. And non-venomous snakes also can lead to local swelling. So just a local swelling is not an indication for ASV treatment. So we will come to the management of snake bite. So check the history, look for fang marks, any bleeding, any swelling, and remember crate bite may not have any local marks. 70% of the snake bites are from non-venomous or dry bites of venomous snakes. So reassurance is the most important thing. Reassurance itself can calm down and is treatment for 70% of the snake bites. And remember, the most 75% of the deaths are occurring in the first hour. So rapid transport to the public health PSCs, prompt treatment with anti-snake venom, discouraging the traditional methods, propagating against traditional methods, and strengthening our PSCs are most important to prevent a death in snake bites. And the part should be immobilized like a broken bone. Whichever part the snake bites, we should not, if the snake bites on leg, we should not allow the person to walk. So absolute rest, splinting should be done. In case of neurotoxic snake bites, if the PSC doesn't have ventilatory support, you should secure narrow pharyngeal tube before shifting the patient to a tertiary care center. Securing a narrow pharyngeal tube where intubation is not available is most important to prevent respiratory arrest. And in our Indian national guidelines doesn't advocate tourniquet. In some Australian neurotoxic snake bites, they advocate tourniquet, application of tourniquet, but in our Indian national guidelines are against the application of tourniquet. So we should not block the blood supply, should not apply pressure. It should be just splinted with a available wood piece, a spade, tree branch, or what newspaper also. And if you are suspecting a neurotoxic snake bite at PSC level, before referring the patient, if you don't have ASV and ventilatory facility, you should give a dose of atropine and neostigmine before shifting the patient to the higher level. So one dose of atropine and neostigmine is the initial management where the facilities are not available. Where the ASV is not available, ventilatory support is not available. And if the patient, most of the patients come to us with a tourniquet. We don't advocate tourniquet, but most of them come with tourniquet. So if they come with a tourniquet, don't remove tourniquet immediately. First start ASV, keep atropine and neostigmine handy, then only we should remove the tourniquet. And if the patient comes with multiple tourniquet, we should remove all tourniquet but for the most proximal one. So tourniquet should be kept till we start the anti-snake venom. And remember, don't try to kill and catch the snake. It's just your treatment. And remember, the dead snake retains the reflex bite. It can bite once again. So don't try to catch and kill the snake. Just a digital photograph is enough. And remember, in India we have only polyvalent anti-snake venom. Monovalent is not available. So just to whether it's poisonous or non-poisonous, that's enough for us. We don't need to know the species of the snake. So immediately once the patient comes to us, we do local examination, bite, swelling, painful, tender lymph nodes, any bleeding from the wound bite, and general examination we monitor his hemodynamics, pulse, blood pressure, any bleeding from any site, level of consciousness, and drooping eyelids. The first thing to be observed and examined is ptosis in the neurotoxic patients. And we go for 20-minute whole blood clotting test. Glasgow Coma Scale should not be used to assess the consciousness in paralyzed patients with neurotoxic snake bites. So lab test, we take 2 ml of blood, keep it aside for 20 minutes, and if the blood doesn't coagulate, doesn't clot, it's almost specific for snake bite. But remember, this test is only 40% sensitive. So a negative test doesn't rule out snake bite. And we should always use clean, new, dry glass test tube, not the old used ones. Old used ones, they cleaned with detergent, they can give false positive tests. So this is the test showing 20-minute whole blood clotting test. And if the test is positive, start anti-snake venom immediately. Then we should repeat the test every 6 hours. If the test is positive, no need of repeating it hourly. So liver takes at least 6 hours to synthesize and correct the coagulopathy. So if the test is positive, we give him anti-snake venom and repeat the test after 6 hours. And if the coagulopathy is persisting, we will repeat the dose. So we will repeat the dose until the coagulopathy becomes normal. If the test is negative and showing neurotoxic symptoms, we should give anti-snake venom immediately. And we should not wait for 6 hours. If the neuropathy is not improving, we should repeat the second dose within 1 to 2 hours. If the test is negative, there are no neuroparalytic or bleeding symptoms, we should repeat the test every hour for 3 hours. Remember this, if the test is positive, we are going to repeat the test only after 6 hours by giving ASV. But if the test is negative, we should monitor the test every hourly for the next 3 hours. Once it becomes positive, then we should attack the patient, toxin. And then every 6 hours for 24 hours. నిమిషాలు స్టార్ట్ అయింది 22 minutes ఎట్లా ఇది So this is the protocol we should use for 20-minute clotting test. If it is negative, we should repeat every hour. If it is positive, only after 6 hours. వెయిట్ చేయాలా? అది పోతుందేమో చూద్దాం. So, we should counsel the patient that we may need repeated testing, multiple blood samples, and the first sample should be taken for blood grouping and cross matching. That's one of the practical point. And other tests, LFT, RFT, PT, APTT, monitoring cardiac ECG, blood sugars, echo, and ABG we should not do regularly because arterial puncture is contraindicated in coagulopathy patient, and pulmonary function test we don't do regularly. So, all coagulation profile and urine for myoglobin and hemoglobin, renal failure, CAS, RBC, RFT, and LFT, and cardiotoxic, echo, CPKMB, ProBNP. Then myotoxic, we look for CPK, SGOT, urine myoglobin, compartment pressure. And infections, we go for serum procalcitonin and cultures. So, coming to the anti-snake venom. In India, only polyvalent anti-snake venom is available. Monovalent is not yet available. And it should be given as soon as possible. It neutralizes only the circulating toxin. Once it is bound to the tissue or nerve endings, the anti-snake venom is not going to neutralize the toxin. And anti-snake venom can reverse systemic indentation abnormality even after several days or 1 or 2 weeks if the hemostatic abnormalities are persisting. So, persisting coagulopathy is an indication for late administration of anti-snake venom, and dosage depending upon the type of the snake, size of the snake, and symptoms. So, it's given only in IV form, no other route. It should be administered as soon as possible and should be given in full dose. We should not wait for 20-minute whole blood clotting test if the patient is already bleeding, is showing hypotension, cardiotoxicity, or neuroparalysis. And just local swelling is not an indication for ASV administration. And coming to contraindications, there's no absolute contraindication. That's the only drug available so far for snake bite management. There's no absolute contraindication. Every poisonous snake bite should receive anti-snake venom irrespective of anaphylaxis or reaction. So, even for high-risk patients, we should give anti-snake venom. So, who are the high-risk patients? The people who already received tetanus immunoglobulin or rabies immunoglobulin, strong history of atopy, these patients should be treated with epinephrine, H1 blockers, antihistaminics, H2 blockers, ranitidine, steroids, and beta-2 agonists before starting ASV. So in high-risk patients, we give so many pre-medications: epinephrine, H1 blockers, H2 blockers, beta-2 agonists, and steroids. And there are two types of anti-snake venom available in India: polyvalent powder form, liquid form. And powder form doesn't need cold chain. So we most of them use this powder form. Each ml can neutralize, each vial can neutralize 5 to 6 mg of the toxin. And usually the average dry weight of venom is around 70 mg. So 10 to 20 vials will be sufficient most of the times. So first neuroparalytic, we give 10 vials, start, and reassess the patient after 1 hour. If the neuroparalysis is still persisting, we will give another dose of 20 vials. And usually for neurotoxic, the maximum dose is 20 vials. Whereas in vasculotoxic, we give 10 vials, reassess the patient every 6 hours till the clotting time normalizes to normalizes. So every 6 hours we go on repeating 6 vials, and usually they require up to 30 vials. There is no ASV available in sea snake bite, green pit snake bite, but luckily in our region we don't see these bites. Administration, it should be started by IV route. The physician should be at bedside. Initially we should monitor the patient every 5 minutes for first 30 minutes, then every 15 minutes for the next 2 hours. And at the earliest sign of adverse reaction, the infusion should be stopped only temporarily, suspended temporarily, should not be stopped permanently. So there is some trouble with slides, and the infusion should be gradually increased. First we should start slowly, should be increased gradually, and we advocate only epinephrine pre-medication. And pregnant women, children should be treated with similar dose. No special guidelines for pregnants and children. Even children should get full dose of anti-snake venom. But to reduce fluid overload, we mix the anti-snake venom 200 ml of saline instead of 500 ml in kids. And if the patient doesn't improve even after 30 vials, we have to reconsider whether to continue or not. And the second episode can occur after treating the patients. They can suddenly deteriorate because continuing absorption from the depot and redistribution of venom from tissues to the vascular space. Here also we need to repeat the anti-snake venom. So persisting coagulopathy, we go for fresh frozen plasma, cryoprecipitate, whole blood, depending upon whether it is bleeding or not. And victims who arrive late, 1 week after snake bite or 10 days after snake bite, we do coagulopathy investigation, 20 minutes whole blood clotting time. If the coagulopathy is persisting, we give anti-snake venom even on late presentation. But in neuroparalysis, AKI, compartmental syndrome, gangrene, we don't treat with anti-snake venom. Late presentation, coagulopathy is the only indication for administration of anti-snake venom. And no test dose. Test dose, we don't go for any test dose. So we have 3 types of reactions: anaphylaxis, pyrogenic, serum sickness. Anaphylaxis is the most important adverse effect where the patient can land in hypotension, bronchospasm, angioedema, respiratory distress. So, prophylactic we give epinephrine before starting ASV, but this should be avoided in hypertensive and cardiac patients. Remember, cardiac patients, hypertensive patients should not get epinephrine pre-medication. And in case of adverse reaction, start him on oxygen, start him fluids, then give him epinephrine, antihistaminics, steroids, then wait for 10 to 15 minutes and again restart the anti-snake venom. In serum sickness, we go for antihistaminics and steroids. And desensitization. If the patient develops anaphylaxis, we stop anti-snake venom, then we should go for dilute 1 ml of anti-snake venom, add 9 ml, that makes solution A. Then again redilute it 1 ml of solution A with 9 ml B. So, you repeatedly take 1 ml and repeatedly dilute it, so it make it 1:10,000. Then we start with solution E, watching for enough, slowly increase the dose. Then solution D, C, B, and finally we come to solution A. So, first we start with 1:10,000 diluted anti-snake venom. Then we gradually increase the concentration and rapidity. Then coming to the neostigmine atropine. Atropine 0.6 mg, neostigmine 1.5 mg should be given stat, and every 30 minutes for the first 5 doses. So, first 2.5 hours the patient should get 5 doses of atropine, neostigmine. Later on we should start tapering, next dose after 1 hour, next 2 hours, 6 hours and 12 hours. And majority of the patient usually respond within 5 doses. So, if there is an improvement of more than 50% in ptosis, it indicates the improvement with the atropine and neostigmine. And when should we start atropine, neostigmine? Complete recovery from neuroparalysis. So, we are going to stop. Or side effects, fasciculations, bradycardia, and there is no improvement even after 3 doses. So, there is no point in continuing atropine and neostigmine. And atropine neostigmine is useful only in cobra bite, postsynaptic, where in crate it is not useful. So, crate is basically presynaptic. So, in presynaptic crate bite, we should go for calcium gluconate 10 ml every 6th hourly. This has to be continued for almost 1 week till the patient recovers. So, indications for dialysis like in an AKI, refractory pulmonary edema, refractory hyperkalemia, rising creatinine, urea, so pericarditis, GI bleed, and compartment syndrome. This is a situation where we have to refer the patient to surgeon, but we should not go for any surgical intervention as long as the hemostatic abnormalities have been corrected and this intracompartmental pressure more than 40. Otherwise, we should not touch the patient surgically. So, these are the asymptomatic, dry bite, symptomatic crate. You can take a photo of this slide, and these are the various manifestations. So, key points: no role for prophylactic antibiotics, and we should not administer NSAIDs for pain. That may increase the risk of coagulopathy. We should not use narcotics. It should be treated as fresh bite. And nowadays 2-3 molecules are coming: phospholipase A2 inhibitors, zinc metalloproteinase inhibitors. They are under trials, but not yet approved by any authority so far, and our national guidelines are not advanced. Some trials are showing some, so metalloprotein is for neurotoxicity, then phospholipase for local, and they are trying even local laser therapy, low dose laser therapy, but all these no new methods are so far advocated by anybody. Thank you.
Thank you for bringing your valuable insights for us, sir, today. Now
Oh, sorry.
I would request Dr. Venkat Kotamraju, sir, to present the moment.
Thank you, sir. It's the first time I'm talking. Actually,
First time, yes.
yeah. Thank you, sir.
Good morning to everyone. I am Dr. Shirisha, Assistant Professor, Department of Emergency Medicine. I would like to thank our HOD sir and our department and management for giving me a chance to present here. So today I am going to talk about organophosphate poison. So as you all know, it is commonly used as a pesticide in agricultural sector and a household chemical, and it's a commonest poisoning found in India. So OPCs are actually potent cholinesterase inhibitors. They are capable of causing severe cholinergic toxicity. As depicted in this graph, you can see organophosphates form a large number of poisoning cases in India. And most common, it is actually suicidal type of ingestion. And this is the general classification of compounds which we have, that is nerve agents, sarin, tabun, soman, and insecticides as dimethyl and diethyl compounds, malathion, parathion, diazinon, and monocrotophos. You have a long list over there. So the commonest routes of absorption are ingestion, accidental or suicidal, cutaneous, and inhalational. So first let's talk about the pharmacokinetics. It is highly lipid soluble and it easily crosses blood-brain barrier. It's well absorbed from skin, mucous membrane, conjunctiva, GIT, and respiratory tract. So redistribution is common and metabolized mainly by oxidation in liver and esterase hydrolysis. So how does it act actually? It is very simple. It is acetylcholinesterase deficiency leads to the accumulation of acetylcholine in the body. Since these are potent cholinesterase inhibitors, so they cause this. And it is acetylcholinesterase is critical for nerve function. So the irreversible blockage of this enzyme causes acetylcholine accumulation, resulting in muscle overstimulation. So this causes cholinergic crisis. So here there is it is the same mechanism is depicted in the picture. And as OPC inactivates acetylcholinesterases by phosphorylation in synapses on RBC membrane and butyrylcholinesterase in plasma. Over time, there is this, depending on the OPC agent, a bond is formed between acetylcholinesterase and the compound. So as the duration prolongs, aging occurs, that is conformational change occurs, and it becomes to irreversible resistant bond is formed, which can't be broken. So sequelae of acetylcholinesterase is either it is spontaneous reactivation or reactivation by PAM can be done, or irreversible binding by permanent enzyme inactivation. Aging is dimethyl compounds. In dimethyl compounds, 50% aging occurs by 3 hours. So PAM should be given earlier since it's useful only for a short time. And diethyl compounds, 50% occurs by 33 hours. So PAM can be given up to 5 days. So what are the physical features, clinical features? So we have muscarinic features and nicotinic features. Muscarinic features are bronchospasm, diarrhea, vomiting, abdominal cramps, bradycardia, hypotension. excessive secretions and urinary incontinence, and the antidote is atropine. Nicotinic features are found in the NMJ, both NM and NN receptors, and the side effects are respiratory failure, muscle weakness, paralysis, where oximes play a major role as an antidote. And we have CNS features also, which can cause restlessness, seizures, coma, respiratory and circulatory depression. The same thing is depicted here in a figure. There are many for new PGs, there are many mnemonics which you can use, like dumbbells or sludge, diarrhea, urination, meiosis, bronchospasm, bronchoria, emesis, lacrimation and salivation. The same things is depicted here in a figure. So main is there is CNS symptoms. We have three types of paralysis. First one is acute paralysis during the initial cholinergic phase. It is due to large number of acetylcholine at muscarinic and nicotinic receptors. So the patient will have fasciculation, twitching, neuromuscular weakness and cardiac arrhythmias and respiratory failure. So they may need initially early ventilatory support. Type 2 paralysis is otherwise known as intermediate syndrome. It may be due to inadequate oxime treatment and or due to downregulation of presynaptic and postsynaptic receptors. In 40% of patients, 10 to 40% may have this develop intermediate syndrome. It is usually seen only after 24 to 96 hours after ingestion. So usually there will be a proximal muscle weakness, that is progressively from ocular, neck, proximal limb, respiratory muscle, diaphragm and intercostal muscle. The treatment is usually supportive 3 to 4 weeks ventilatory care. There is something called type 3 paralysis, that is OPC induced delayed polyneuropathy, which is usually seen after 2 to 4 weeks. Here more commonly distal limb weakness is prominent, but in severe neurotoxicity even proximal can occur, and sensory loss can occur, and flaccid, it is characterized by flaccid weakness and spastic ataxia. Recovery takes usually 1 to 2 years. There is a new term which was described in 2008 known as CNS intermediate or delayed OPC encephalopathy. So here the patient will actually be normal sensorium, and they will develop coma over time. They can also have extrapyramidal side effects, and they are clinically brain dead, but actually they will have neuroimaging and CSF normal. But in EEG, they'll be having bihemispheric slow waves, which is consistent with encephalopathy. It has a good prognosis in spite of all this with adequate supportive care. OPC poisoning diagnosis is mainly only clinical diagnosis. First, we need to have a history of ingestion of the poisoning, and as you all know that clinical symptoms, and we do this lab test of serum cholinesterase. So we usually do plasma butyryl cholinesterase, so this is the difference between both. So plasma butyryl cholinesterase is easily accessible, and it is used to detect only the exposure to OP and OPC, and the rising trend suggests that OPC is eliminated. So what's new in management of OPC poisoning? Our goals of treatment, as it is seen in any other poisoning, is first we have to reduce the absorption of the toxin, then enhance elimination and neutralize toxin. So resuscitation part. So first we have to take care of the ABCD, airway. So early intubation is of large importance in OPC poisoning, and breathing and circulation. We have to have a IV access, and D is decontamination. So how do we reduce absorption? We have to remove the toxin from skin, eyes and hairs by using normal saline and gastric lavage will be done. If presented within 1 hour, activated charcoal can be used, and whole bowel irrigation is of debate. Sorry, there's some technical problem. Yeah, so atropine, it is the most important treatment in OPC poisoning. Atropine actually blocks muscarinic receptors, but we have to be careful because there is a risk of atropine toxicity also, which is characterized by fever, delirium, urinary retention and tachycardia. So once we suspect this toxicity, we have to discontinue the treatment immediately and restart with 70 to 80% of the previous dose. So atropine overdose, this picture depicts the symptoms which you can get: confusion, delirium, increased temperature, flushed face, tachycardia and dry secretions. So atropine dose is actually 2 to 5 mg of atropine first you have to give initially 2 to 3 mg IV bolus, and you consistently check the patient for every 5 minutes and double the dose until atropinization occurs. Once atropinization is occurring, you have to give 10 to 20% of the total dose which is required for atropinization as hourly IV infusion. So what are the signs of atropinization? The mandatory targets which we have to check is systolic BP should be greater than 90, heart rate should be greater than 110 and clear lung fluids. Actually among the three, the end point for atropinization is resolving bronchoria. And then other targets are pupils should be mid dilated and bowel sounds just present. Role of glycopyrrolate alone or in combination is not yet clear. So next important treatment is pralidoxin. It's a nucleophilic agent. It reactivates the bound acetylcholinesterase. There are 3 types of oximes, but pralidoxin is the most commonly used. WHO recommended dosage is 30 mg per kg IV bolus followed by 8 mg per kg hour infusion IV. So how does this pralidoxim act is, it binds to OPC, causing the compound to break its bond with acetylcholinesterase. It mainly affects PNS only, CNS penetration is limited. Pralidoxim is most useful for all the nicotinic symptoms, and the endpoint is clinical recovery or 12 to 24 hours after atropine is stopped. And you have to give early PAM also. So there is toxicity involved with this also. Oximes when given rapidly can cause muscle weakness, dizziness, flushing, numbness, tachycardia and laryngospasm. The inference, but there are a lot of trials which have done that it is debated as of now whether it is harmful or beneficial. But clinically in our daily practice we see that giving oximes is actually beneficial. But there are 2 RCTs from Vellore which recently told that it is causing harm. And there are a few other RCTs which actually support PAM. So the other modes of treatment is FFP. So what is FFP actually has cholinesterase. So the so that may be useful in the treatment of OPC poisoning is one suggestion, which ongoing research is going on in that. So that is also inconclusive. And role of clonidine in OPC poisoning is, it is actually a centrally acting alpha-2 receptor agonist. So it inhibits presynaptic release of acetylcholine, decreases the cholinergic symptoms caused by organophosphate poisoning. So that is the logic behind it, and it is usually given in synergistic action with atropine. But we have to be careful about the side effects of clonidine, such as sedation, hypotension, bradycardia, and rebound hypertension. Bolus injection of 0.1 to 0.3 mg followed by an infusion at rate of 0.5 mg for 24 hours. Activated charcoal only if given within first hour, but there is no benefit observed. Gastric lavage also, if it decreases absorption only within first hour. Alkalinization has shown some benefits, and it is controversial in few RCTs. Magnesium sulfate, intravenous magnesium sulfate given on the first day after admission has shown to decrease hospitalization period and improve outcomes in patients with OPC poisoning. So magnesium sulfate, it blocks calcium channels and reduces acetylcholine release. So it also reduces CNS overstimulation resulting from NMDAR activation. Forced emesis is not useful. So summarizing, we have to always remember the three types of paralysis: acute cholinergic, intermediate, and OP-DIP. And there is something called delayed OPC encephalopathy DO. And remember the signs and symptoms, and the management always give incremental atropine along with immediately pralidoxim, ideally within 24 hours. Magnesium sulfate and newer treatment like clonidine and fresh fluorescent plasma, they require more research. Thank you.
I thank ma'am for the valuable insight, and I also request retired Lieutenant Colonel Dr. Y. Ashok to come out to the dais and present a memento to ma'am. I'd like to take break for the first session for the day, and I'd like to start the inauguration within 5 minutes. So we'd like to break for 5 minutes before the inauguration. I'd like to give you a message to continue after the inauguration, after the talk has clear process.
Department of General and Emergency Medicine has practice program that deep commitment to medical excellence. We are honored to have some exceptional dignitaries with us today for this inaugural function. Now I would like to invite them onto the dais. May I kindly Medical Superintendent, Mamata Medical College. From Department of General Medicine, I would request Dr. D.V.C. Shobhan sir, Professor, Department of General Medicine, Mamata Medical College. Now I would request Dr. Co-Organizing Secretary and Associate Professor, Department of General Medicine College. Emergency Medicine, Dr. Mahendra Kumar sir, Professor and HOD, Department of Emergency Medicine, Mamata Medical College, onto the dais. Now I will request Chair, Department of Emergency and Professor, Department of Emergency Medicine, Mamata College, onto the dais. Now I would request in associate scientific advisors. So I would like to call upon Dr. Ashima Sharma ma'am, Professor, Department of Emergency Medicine, NIMS, Hyderabad. Senior Professor, Now I would request MD General Medicine, Superintendent GMC Munugur, onto the dais. Consultant in Emergency Department and Clinical Toxicologist from Royal Deputy Hospitals. Perform the life of a lamp, a symbol of knowledge, clarity and healing. Now I request our honored dignitaries to join us. Any occasion starts with a a prayer song. So now I would request juniors to sing a prayer song.
అక్కడ పెట్టండి అక్కడ పెట్టండి
शुभ गुणलोल निरत जया प्रदशील वरदा प्रिय रंगनायकी वांछित फलदायकी सरसीजा सनुजननी जय 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 वाणी.
Thank you for singing such a beautiful song. Now I would request Dr. Anuradha ma'am to give her valuable insights on this conference.
Dignitaries on the dais, off the dais, invited delegates, faculty members and PG students. Very good morning to all of you. I welcome you to our prestigious institute, Mamata Medical College, for this CPD program on emergency medicine and toxicology. And I also congratulate the Department of Emergency Medicine and General Medicine for coming forward to organize this CME program in a short notice. And I came to know that more than 350 registrations occurred, and it's a very good response. All the topics are very good. That is why, and all the topics are also the need of the hour. That's why I think that is the reason many registrations have occurred. And but still, I think many delegates have yet to come. And all my special thanks to our resource faculty who have come from different places of the country and also from abroad. Especially Dr. Venkat Kotamiraju has come all the way from UK, and other senior faculty as resource persons. And our Department of Emergency Medicine is organizing continuously various workshops in our college, like they are conducting simulation workshops for the faculty and postgraduates and also for the interns. Regularly we are organizing such programs with the help of our faculty. And I am also thankful to the Association of Emergency Medicine Medical Educationalists for giving an opportunity to organize this conference at our institute. Thank you, Dr. Rashma and Dr. Chandrasekhar. And we also wish such programs should be conducted in future in our institute. We request you to give more opportunities. Just now I am talking to Dr. Venkat sir. He is also a very eminent person in medical education, where he is conducting various workshops. And we are also planning to have an international medical education workshop. We will conduct in our institute with your cooperation and support. And I wish all of you will have a very good scientific and academic feast by our eminent faculty, and also a delicious lunch given by our management. Thank you. I wish you all the best.
Thank you, ma'am. Now I invite Dr. Ramaswamy sir, Medical Superintendent, Mamata Medical College, to speak a few words.
Respected dignitaries of the dais, on the dais, and dear delegates and students, good morning everyone. It is a proud moment to Mamata to conduct state level emergency department conference. I think recently they have announced, but within short period they have conducted this conference. It is a proud moment for us and you. And I heard that NIMS in our state, Telangana state, it is a number 2 college for emergency department, including all the facilities. They have given second rank, and first rank in Telangana and second rank in national level, that is all India level. But we also want, by seeing like that professor like Khammam madam And so many our pillars are there here, Department of Emergency Medicines, like Mahendra Kumar sir, Hanumantrao sir, and Santosh, Dr. Santosh. They are working lot of effort they are putting to at least we can reach near to them, not the up to level, near to them, like Sama ma'am. So it is like a proud moment for us to support them and give all the facilities, requirement facilities for our management level.
Department of Emergency Medicine of Medical College, speak a few words. Department of Emergency Medicine of Medical College, speak a few words.
Good morning, everybody. Rises. What toxicology? Toxicology is a subject totally dependent on climate mitigation and climate change. A simple example being Syrian war. Syrian war is 7 years complete drought. Nobody talks on drought. Drought will cause all the things. So today toxicology is totally dependent on climate mitigation, because if there is less rainfall, more pesticides and more organophosphorus things are used, that will lead to all the side effects. So try to cover next time climate mitigation and climate change in taxonomy, sir, because these topics are the future, and the department is already in starting phase. So hope this will improve our academics, and thank you for allotting Khammam this time emergency toxicology conference, and thank you for Mamata Education Society and Principal Madam and Superintendent Madam for accepting immediately and conducting this, and thank you for giving this opportunity.
Thank you, sir. Now I would request Dr. Ashima Sharma ma'am, Senior Professor, Department of Emergency Medicine, NIMS, to give few words on the conference.
Thank you so much, ma'am, for accepting our request to host the toxicology conference at your prestigious institution. I would openly say that my love for this institution has grown leaps and bounds over last 1 year, with my daughter also doing her medical studies over here. So yes, Mamata Medical College has the potential to grow, because as an assessor, when I saw the amount of patients you have, we all learn from patients. So most of the, many of the private medical colleges do not have that, but you being in the city and have a lot of patients, and that patient's load, that OP footfall will help the students to grow. Needless to say that the emergency medicine has grown leaps and bounds under the able leadership of the two professors sirs on the dais, and obviously under the eyes and blessings of the chairman, madam, and Naren sir, and the passion which Dr. Santosh puts in every program he takes is worth and big applause. He never says no to anything which is academic. I like this thing of him, this don't say no if it is academics, this approach of this quality of Dr. Santosh. As for toxicology conference, I am very thank you, my sir, for telling us about climate change. Your point is well taken and will be looked into. And the fact that we would be conducting more and more tox related conferences across the state, and the faculties on the dais, off the dais, give me a small opportunity to introduce to you. Please, my colleagues can raise their hands so that the students can know. We have very senior Dr. Y. Ashok sir from Mallareddy. He is a professor and head of emergency medicine. He is a seasoned anesthesiologist. We have Dr. Vishwa Reddy, professor of emergency medicine from Apollo Medical College. Madam is soon hosting resuscitation updates just like this in December 2021 at Apollo Hyderabad. we have Dr. Anita Silveri. She's Associate Professor in the Department of Emergency Medicine at ESI Medical College, Hyderabad. These two colleagues, as well as Dr. Jyoti Swaroop, who has just completed his senior residency from AEME, New Delhi. Again, probably more of you who work here would connect with him because his alma mater is Mamata Medical College. So coming back to his college to give a talk is definitely an achievement which this person has taken in. And Dr. Ashok Reddy, who has come from NRI Medical College. Dr. Ashok, he is there, and he has also done his DNB Emergency Medicine. I am so thankful to all others of Mamata Medical College on behalf of AEME to give their valuable time to share their knowledge with the students. Thank you so much.
Thank you, ma'am. Now I invite Dr. Chandrasekhar sir, Superintendent GMC Mulugu, to speak a few words.
Good morning all. So nothing to say much about this very going to be good and successful conference on of emergency medicine on the toxicology. Actually, as a call given by Association of Emergency Medicine Educators, AEME, there are three pillars. One Kotamaraju and Ashima Madam, and one more Arnachalam Einstein. So it has been doing wonderful programs in the country and in the state also. So we are responding to their call and action because emergency medicine is the one which is the need of our, because most of the times patients will come in the dire emergency and get neglected with some kind of thing. And Madam has, Ashma Madam has told some of the names. It is something like a connecting the dots actually. So coming to the conferences wise, so we are thematic conferences we are doing not annually but even whenever the time comes. In the January we did respiratory emergencies. Now the toxicology, this has happened to be in the somewhere in the June, July, but because of some problems we couldn't able to. Actually this has to be happen in the Warangal, but because of some problems we have pushed to the right place actually what I am thinking. And this conference is organized very emergency by the emergency medicine of Mamata Medical College. Thanks to Santosh and HODs are here. And definitely we have to thank the Mamata Medical College for organizing this so fine, because I am not new to the Mamata Medical College. As a general medicine faculty, I was good association with Shobhan also. And last year they have conducted, before that year they conducted the state conference of general medicine also. So I am connected to here. And one point I want to tell you is that now the emergency medicine is the coming up branch, very demanding branch and very satisfactory giving branch also. So, and in this regard, so many changes are coming, like that now Khammam is giving, and the other three medical colleges like Mallareddy and Apollo and this Mamata Medical College, and government side also. Of course, NIMS is there from the beginning, and ESI hospital is there. And I want to reiterate that Kakatiya Medical College Warangal has got 5 EM seats 3 years ago. So that is the first government medical college in the state. And this year, the newly established Ramagundam is also got 4 seats. So this community will be going to improve. So that is the reason why the madam is putting hard efforts to connect all the dots to give a big picture. So that is the basis of the occurrence of this conference. Hope you will enjoy the scientific contents of toxicology handpicked by scientific committee, mainly Ashpa madam. Thank you very much for giving that wonderful conference, to the principal, superintendent and other management and lovely audiences. And particular thanks to Santosh. Thank you very much.
Thank you so much, sir. Now I would request Dr. Venkata Kotamaraju, sir, consultant in emergency medicine and clinical toxicologist, Royal Debris Hospitals, UK, to give few words on the conference.
Well, every drug is a poison. Every drug is a poison. It's only the dose that makes a difference. Toxicology is a very important specialty because it forms the interface between emergency medicine, general medicine, critical care, and public health. Toxicology in the United Kingdom, where I practice, is boring because you only see paracetamol poison. Real toxicology is in India, in your hospitals, in your country. So give a big hand to every toxicologist or every physician, every emergency medicine specialist who takes care of it. The sickest patients who present to your emergency department are patients who present with undifferentiated, undiagnosed, unknown, and unhappy problems. And it's our duty to make sure that we keep them safe and treat them in the best possible way. Thank you very much, madam, for hosting us here. Although I am a Pakka Telangana person, I have been away from this land for the last 25 plus years. And this is my first visit to Khammam and to Mamata Medical College. I've heard great things about this great college. Some of my classmates have done their post-graduation here. And madam, of course, has a close relationship with Navya being here in her first year of medicine. And thank you, Dr. Santosh, for taking the time to invite us and for all the hard work and the effort you have put into it, along with the emergency medicine and general medicine departments. Chandrasekhar sir and me, we always keep making fun of each other. And he wants to take away the good things from Mamata Medical College and do it at Warangal. I will leave it for both of you to decide which is the best place to course it. But thank you very much for having us, and we have hopefully crafted a great scientific program that will inspire young minds to take up more and more of emergency medicine. When I started my emergency medicine journey 26 years ago, everybody said people enter into emergency medicine because they are either failed orthopedic surgeons or failed general surgeons. And I fit into that category because I did my general surgical and orthopedic training. But imagine this, which doctor can suture a head, can crack open a chest, can deliver a baby, can apply a splint, and can treat a poisoning case? It's only an emergency medicine doctor. A neurologist can open the brain, or a neurosurgeon can open the brain, but can't fix a splint. He can't crack open a chest. A gynecologist is great at their job to deliver the babies, yes, but in emergency medicine, you are at the forefront of everything. So it's a beautiful specialty, and I urge young postgraduates and young doctors to consider this specialty, because this specialty marries with every other specialty in the hospital. General medicine, critical care, all surgical specialties, and of course, public health as well. So if you haven't thought about it, let me inspire you to take up emergency medicine as your career. It's the best career you can have, and it's a career which is with empathy, leadership, professionalism, ethics. And this is what we want to bring to you, so that when you graduate out of Mamata Medical College, people are able to say that this doctor who passed out from Mamata Medical College is a good doctor. Thank you very much.
Thank you so much, sir. Now I would request our dignitary accepting on behalf of Dr. Shivni ma'am. Now, The memento is being presented to Dr. DVC Shobhan sir by Dr. Sahiti. Dr. Krishna Suman sir will be presented the memento by Dr. Navina. To Dr. Ashima Ma, Dr. Bhavani will be presenting the memento. To Dr. Chandrasekhar sir, Meghna will be presenting the memento. To Dr. Venkata Kotamaraju sir, Ravali will be presenting the memento. To Dr. Mahendra Kumar sir, Bhavani will be presenting the memento. For Dr. Hanmant Rao sir, Sahiti will be presenting the memento. Now I would request all the dignitaries on the dais to have a little photo session. Stand up for a photo session.
Drug is a poison. So, paracetamol poisoning. How many of you think you are confident in managing a patient with paracetamol poisoning? Let me tell you a story. Danielle Welsh was a 19-year-old girl who had short stature, high BMI, and she had chronic pain syndrome. She was always taking analgesic medication. One day, her parents took her to a hospital in Scotland in June 2008. she had upper respiratory infection. The doctors diagnosed upper respiratory infection with possible bacterial infection, did some blood tests, discharged her on some painkillers and antibiotics. She was 19 years old and she weighed 35 kgs. She went home, but she was unable to take the painkillers and the antibiotics because she was continuously vomiting. 2 days later, she who admitted her, prescribed her 1 gram IV paracetamol 4 times a day. She was 19 years old. She weighed 30 kgs. She took paracetamol for the next 48 hours, 4 times a day. Acute liver failure and was transferred to the critical care unit in a hospital in Glasgow. By 11 doctors and 12 nurses over the course of her admission in the hospital. On the evening of and died. She was 19 years old. She weighed 35 kgs. She received 4 grams of IV paracetamol for 48 hours. She was seen by 11 doctors and 12 nurses. The dose which was needed for that girl, and a young life was lost. She was to receive only 35 into 15, 575 milligrams of paracetamol 4 times a day. She received 1 gram 4 times a day. Treating a patient of paracetamol overdose. Paracetamol overdose is the commonest poison in the United Kingdom. It is the commonest cause for acute liver failure. It's the commonest cause for which patients need a liver transplantation. And it's all related to this molecule called as NAPQI. So what are the already alluded to one and how to manage. Most people think they know how to manage paracetamol poisoning. As a toxicologist, I can tell that it is badly managed by physicians. Firstly, it's acute injection. So you paracetamol over a period of 1 hour, and that is acute injection. Second type any amount of paracetamol, irrespective of the dose, staggered over as supratherapeutic excess. And most commonly people in the UK take it because they have dental pain. Instead of taking the maximum dose of 4 grams per day, they take 5 grams, 6 grams, supratherapeutic excess. And the management of each one of them is completely different. And people fail to understand this, and they treat all of them exactly the same. So single acute ingestion is ingestion over a period of 1 hour. Staggered overdose is over a period of 1 hour, and anything little bit extra above and beyond what a 70 kg adult can take. Therapeutic excess. Paracetamol commonly affects the liver and the kidneys, and liver damage doesn't occur until, or doesn't start to happen until up to about in 16 hours time. The liver should break it down and the levels should be 0. A staggered overdose or somebody who has taken paracetamol beyond 16 hours, this nomogram doesn't work. And relying on paracetamol levels to treat patients with staggered overdose is the commonest cause of mistreating a patient with paracetamol overdose. Misinterpretation of paracetamol levels is the first pitfall. So in a patient who has taken staggered overdose, you cannot rely on the levels, because if you look at the nomogram, you can see. If you have a patient who has taken a staggered overdose of paracetamol, having a high level of paracetamol doesn't tell you whether you need to treat them or not. All it tells you is that they have taken significant amounts of paracetamol. If somebody has taken significant amount of paracetamol, you won't find paracetamol level in their blood, because paracetamol disintegrates after 16, 18, 20 hours. So relying on levels in somebody who has taken a staggered overdose is completely unhealthy. If you have a patient and you suspect that you don't know the dose, toxicology patients don't tell you the truth. They don't tell you the amount, they don't tell you the time, and they don't tell you what they have taken. Treat them on the basis of 3 things. Number 1, which Dr. Sharat will talk about later, is the concept of toxidromes. And number 2 is the story. And number 3 is the you have so in somebody who comes in with a staggered overdose, assume that it is a significant poisoning, and unless you can prove that after 4 hours of the last dose of ingestion, they don't have GI symptoms, they don't have acute liver failure, they don't have abdominal pain, their air is normal, and paracetamol level is normal, then you can safely say they haven't taken a significant overdose and you discharge them. So that's the first pitfall. The second pitfall is misrecognition of staggered overdose, which I've already alluded to. So the guidance is you start N-acetylcysteine as soon as possible. We do not wait like this. We after the symptoms, AT paracetamol levels are normal. properly interpret liver function tests. Most people forget to let liver ALT rises much earlier than paracetamol level. If you look at ALT levels and only look at paracetamol level, because on the nomogram, a paracetamol level at 4 hours of 100 or more is significant. But if the patient has got a level of 20, which is not significant, but with a raised ALT, and you fail to recognize, pick up, identify the rise in ALT, and you've missed the boat. And in 8, 10, 12 hours, it will turn into irreversible liver damage, and then you're heading for a liver transplant for this patient. So, two things: delaying treatment in staggered overdoses, relying on paracetamol levels to treat the patients, misinterpretation of paracetamol. And the fourth common thing, and the most common reason why people don't treat or don't receive treatment for paracetamol overdose is not this: delayed administration of NAC, delayed administration of children. The wait time for an ambulance to come into the hospital is somewhere between 4 to 6 hours. The wait time for a patient to be seen after triage is somewhere between 12 to 14 hours. So although the patients are triaged within a few hours, they have their blood tests taken. Because the departments are busy, the nurses are busy, the blood results are not cascaded. Come on to a shift and notice people who had paracetamol levels required treatment 12 hours. And when you go to review these patients, and when you want to start them, they're already developing signs and symptoms of liver failure. So delayed treatment with NAC. And always remember, at least in the countries, patients who present with poisoning usually, not always, usually have an underlying mental health disorder. So we need to treat the mental health symptoms. You may be discharging them from a physical point of view, but they still need mental health input. And there are a lot of patients who will refuse to have treatment and they lack capacity. So you need to address issues like that. So 4 things why we think we can treat paracetamol very well, but the common, even the best paracetamol poisoning. Number 1 is misinterpretation of the liver function test. Number 2, missing treating patients or delaying treating patients with staggered overdose. Number 3, relying on the paracetamol levels to treat staggered overdoses. And number 4, delayed administration of N-acetylcysteine. Of course, if somebody is allergic to N-acetylcysteine, it is not an allergic, it is only an anaphylactic reaction. You can give oral methionine. I am not sure whether it's available here. It's not available even in the UK. US people do give some oral methionine. but otherwise NAC is safe. Of course, with Paraquat poisoning, sometimes with NAC. And nowadays, in US, you can even buy NAC because it is an antioxidizing property for good health. Vishwa is going to talk about toxic alcohols, another topic which is very close. And fomepizole is used for the treatment of toxic alcohol poisoning. But you can use fomepizole even to treat patients with paracetamol poisoning. And we use what is called as the aminotransferase index for this. Aminotransferase index is nothing but the multiplication product of the liver enzymes, ALT, times the paracetamol. And if the answer to that is more than 10,000, then fomepizole is likely to be effective. In the olden days, we used to use what's called as the 21-hour regimen for NAC. So you give the first bag over 1 hour, second bag over 4 hours, third bag over 16 hours. Patients have to remain in the department for 21 hours. And as I said, most of these patients are mental health problems and they don't like to stay in hospitals. So they don't comply with the treatment. Halfway through the treatment, they drop and they leave. Use the number of to increase plans for better treatment, shorter duration of treatment. We have introduced in the last 3 years what is called as the SNAP protocol. SNAP is N-acetylcysteine accelerated protocol for treatment. Some people also call it as Scottish antiemetic protocol for treatment. You use the same dose which you use in the regimen, but you give it over a period of 12 hours. So the dose of drug that is being delivered is 2 bags, first bag over 2 hours, second bag over 10 hours, and that's a 12-hour protocol. So 21 versus 12, they are the treatment protocol. We've talked about fomepizole. And there are some novel biomarkers. So traditional versus SNAP, we've talked about it. Fomepizole, we've talked about it. And all these biomarkers are there. Especially these biomarkers are looking for early signs of vascular injury. Might have significant liver injury from paracetamol poisoning. So in conclusion, we've talked about the types of paracetamol poisons or the types of we've talked about the 4 pitfalls: delayed administration of NAC, failure to identify correctly the liver enzymes, failure to treat patients with staggered overdoses, and relying on paracetamol doses or levels for the treatment, and the management, which is the traditional versus the accelerated protocol. Every drug is a poison, and it's only the dose that's the difference. Paracetamol is the most common poisoning in the UK, most common cause for acute liver failure, most common cause for drug-induced indication for most common drug which is badly managed by physicians around the world. So dear friends, my only request about this to you is to be humble about the disease and the management of paracetamol overdose. Thank you very much.
inside. And I'd like to invite any questions from the audience.
Snap protocol, you divide the 300 into 2 bags.
So initial first batch we need to do larger doses or
100 and 200, right? So the same 300, which is 150, 50 and 50 bags, 1 hour, 4 hours, 16 hours, is given in 2 bags, 2 hours. Duration is reduced, the number of bags are reduced. And as a result, what happens is patient compliance increases, lesser length of stay in the hospital, better treatment, and also lesser risk of anaphylactoid reaction. Because the first bag is what is the reason for somebody getting an anaphylactoid reaction. And in the older protocol, you were giving 150, and here you give 100. It's not an anaphylactic reaction, please bear it in mind. So you give chlorpheniramine, you give prednisolone, you give fluids only to make yourself happy. It doesn't do anything to the patient other than giving symptomatic relief. All you need to do is stop the bag, like in a febrile hemolytic reaction. Stop the bag and restart at a slower rate. So in the older protocol, if somebody developed an anaphylactoid reaction, if you were giving the first bag over 1 hour, then you double the time, you give it over 2 hours. And the second bag over 4 hours, you double it and give it over 8 hours. So that the risk of anaphylactoid reaction continuing is minimized.
Thank you, sir. Thank you for your elaborative presentation.
Thank you very much.
So right, not questions. So in India, so it is not paracetamol that is commonly used for the pains. So like this one, tramadol and aceclofenac. So this has been never studied, I believe. Of course, paracetamol they will take it, but this can be what is called extrapolated to this, or we need to have some more studies. Please, if you can enlighten us. This is a great question to all the younger minds.
Absolutely, yeah, this is a fantastic question. Now, in India, obviously, I always used to say paracetamol poison, and every time I spoke to my friends here, they said, in India, if you prescribe paracetamol, they actually question whether you're a doctor. Because they want some stronger analgesics, non-steroidals, COX inhibitors, gabapentin. Now, my father went to a neurologist and he prescribed him gabapentin. He's got no neuropathic pain. And in the UK, gabapentin is very, very carefully prescribed. And for those of you who do not know, gabapentin and gabapentinoids increase the suicidal risk tendency for patients. So they're not prescribed for a long duration. So paracetamol is not studied because people don't prescribe it here a lot. Now in the UK and European countries, we don't have the luxury of a lot of painkiller medications in our emergency department. The other day, one of the doctors migrated from here and he said, have you got IM diclofenac? We don't have IM diclofenac. We have PR diclofenac, which we give only for renal colic patients. We have paracetamol, we have ibuprofen, we have codeine and tramadol. Otherwise, IV preparations like morphine and phenylephrine. Beyond that, sorry, we don't have any other medication. So the argumentarium is this. The government regulation is you can only buy 2 packets of paracetamol from a supermarket. But unfortunately, the government also, although they don't realize that a patient can hop from one supermarket
afford. And these people go to 5 supermarkets and they stock up paracetamol, so they've got 100 tablets. And every time they want to break up with their boyfriend, girlfriend, or they want to trouble their mother or father, they take 50, 60 paracetamol like Smarties. It is a very, very, very common poison. We treat at least 2 patients every other day with that. And at least 5 to 10 patients a year end up with liver failure. And 1 patient a month, we do this problem of misdiagnosing and not treating properly. Despite lots of education, despite having very rigid protocols, people fail, misinterpret, misrecognize. Because it's a poison which can easily be treated, but at the same time it's very, very harmful. It's a very simple drug, very cheap medication, 16 paisa or 16p for 1 packet of 8 tablets. It costs lakhs. I'm not sure here what analgesics people take overdose on. Are there analgesics people overdose on? Tramadol. Okay, so the opiates is obviously it's a big issue there. You have people, and there are a panel discussion coming up about opiates and why people don't respond to opiate treatment, etc. I think there was a question here. We'll take up the last question in the interest of time.
Sir, any comment about the pediatric overdosing of paracetamol?
Same thing, sir. It's weight based on. Even pediatric, most of the pediatric poisoning is accidental. Most of them are accidental. They usually, unless you want to kill the child, but nobody gives paracetamol to kill child. Non-accidental injury is very common in the UK, but nobody kills them by giving paracetamol for some reason. It could be easily done, but they don't. But they look the same. The treatment remains the same. The protocols are for patients less than 40 kg and more than 40 kg. Danielle Welch was 35. So for all practical purposes, although she was 19, in terms of treatment for NAC, if people identified the paracetamol overdose at the right time, she would have received pediatric dosage of NAC. Thank you very much.
Thank you, sir. And I request sir, please come on the dais to receive a memento. And I like to request Dr. Mamata to present memento to sir.
Thank you.
So right now we're talking on bites and stings emergency management protocol. I invite them on the dais for a talk.
Thank you. Good afternoon, Mamata, and my mentor Ashima Sharma ma'am for giving me the opportunity to talk here on the topic bites and stings. So I am Dr. Anita Silveri, Associate Professor, Department of Emergency Medicine at Essex Medical College, Satnagar. So the topic overview, I will be talking upon types of animal bites, especially focusing upon dog bites and human bites, essential ED management, what has to be done, the antibiotic prophylaxis and antibiotic guidelines, tetanus and rabies prophylaxis, and some complications following these bites. Focusing on some statistics here, the worldwide incidence of poisoning cases for bites is 1% and for stings it is 1.8%. It is very less. You can consider this is very less, but it is because of the disasters which happened. It is really important as an emergency physician to focus on this topic and to learn how to manage these bites. Many organisms like dogs, cats, insects, spiders, scorpions can cause serious illness and sometimes even succumb to death when they are not managed properly. And individuals who have sustained injuries, disabilities or fatalities as a result of coming in touch with the animals significant public health. I think there is some problem with this. The slides are not moving properly. Yes. Bites constitute a vast majority of mammalian bites and poses a significant public health problem, and this is mostly because humans are exposed to risk of rabies, which has 100% mortality. The recent statistics in 2024, the government reported over 3.7 million dog bite cases, and out of which 54 suspected human rabies deaths have happened in India. So what is the ED care? The essential components of treatment are inspection, debridement, irrigation, closure if at all indicated, and rarely complete trauma evaluation is needed. So inspection, what are we supposed to look for? Make sure that you look properly through the wound, look even at the bottom of the wound clearly, and if it needed, just anesthetize the wound and make sure that we see the basis of the wound. Part through the full range of its movements. Debridement helps in preventing the infection by removing the dead tissue, dirt and clots. Any foreign material, if at all present, has to be removed. Cleaning the wound edges properly also leads to small scars and faster healing. So thorough debridement is definitely mandated. Next is irrigation. Irrigation is important to prevent infection. With sufficient amount of fluid, at least about 100 to 200 mils of fluid is needed for inch of the wound, and thorough irrigation with sufficient pressure, say about 7 millipascals is required to irrigate the wound. And especially when rabies is concerned, povidone iodine is effective against viruses and is recommended by CDC for wound irrigation. It may be difficult to irrigate a small puncture wound, especially which happens with these cat bites, but given that these wounds have a high rate of infection, the consideration has to be given to open up these wounds, and thorough irrigation has to be done. Next. There is this study, which is a US based study, which has actually conducted, it's a randomized control trial which was conducted on among 715 subjects following this bites, and what they've done is they have divided them into two groups, wherein half of which are irrigated through tap water and half of them have irrigated through normal saline group. So ultimately the conclusions were there were equivalent infection rates were found in either of the groups. So with which fluid is used for irrigation doesn't matter, but preliminary irrigation is the most important step in managing these bites. Next is about the closure. Primary closure should be considered only if the bite wounds are cleaned effectively. Bite wounds to the hands and lower extremities with delayed presentation, that is more than 8 to 12 hours of presentation or in an immunocompromised host generally should be left open, and to be left open so that they can be healed by delayed secondary intention or by delayed primary closure. The closure management decisions should be at the discretion of the provider after discussing with the patient and considerations with the specialist. Deep sutures should not be placed because they themselves acts as a nidus so that the infection can spread. The rate of infection of mammalian bites is estimated to be nearly 6 to 8% with primary wound closure. Projecting here another randomized control trial. This was between RCT was done among 168 patients who had the incidence of dog bite, and what they have done is they have randomly into two groups here again, wherein one group got their wound sutured and the other wound did not have their wound sutured, and the conclusion was that though the infection rate was similar between both the groups, the cosmetic appearance was significantly better in the wounds that were closed, but surprisingly the infection rate, there was no statistically significant incidence of infection rates among them. The time of management also appeared to be critical, as early treatment resulted in lower infection rates and improved cosmetic appearance regardless of whether suturing was done or no. This is one more trial which is it was conducted in China by Lizong et al. And recently it got published in the year 2023, which focuses on clinical effect analysis of using medical glue versus controversial this suturing following a dog bite cases. So what they have done is 68 children were enrolled following a dog bite, category 3 dog bite in the maxillofacial regions, and one group of children received treatment with medical glue and the other group received this conventional suturing method. And the primary outcome was measured in terms of operation time, patient satisfaction, and the secondary outcome was measured in terms of wound infection rate. And ultimately they concluded that operation time of medical glue was significantly lower than in that of the systematic review out of 5 randomized control trials on examining the various effects of interventions and strategies on occurrence of infections after dog bite, like for example using medical glue or negative pressure wound therapy, hyperbaric oxygen therapy, primary suturing versus no suturing, everything. Ultimately they concluded that there was no significant differences in the incidence of infection rate between the intervention group and the control group. However, recovery time was probably shorter in the intervention group. That means the wound got sutured either through by maybe medical glue or some suturing techniques like that. So additional treatment measures: if the bite wound involves the hand, the consideration should be given to immobilize the hand in a bulky dressing or splint to limit the use and promote the elevation. Tetanus prophylaxis should be considered in all the wounds. Rabies prophylaxis has been indicated for bites, especially pertaining to dog bites, cat bites, wherein rabies status cannot be determined, or in wild animals like fox, bats, raccoons, etc. So proceeding with TT vaccination status. Firstly, when an adult comes to our emergency department, inquire about the previous vaccination status of TT, whether he has received 3 doses. 3 doses meaning 3 lifetime doses, that is when they are young, or 3 doses any time in their lifetime, and then decide upon whether the wound is clean wound or contaminated wound. If the wound is clean and the patient has received the full dose, that is 3 doses, then no vaccine is indicated nor immunoglobulin. But in case the patient has not received these complete 3 doses, then vaccine is indicated, no need for immunoglobulin. On the other hand, if the wound is contaminated and the patient has not received 3 doses, then both vaccine and immunoglobulins are advocated. If the patient has received all the 3 doses, then only vaccine is advocated. Can anybody recognize who is he? So he is a kabaddi player, state level kabaddi player. He accidentally in an event he tried to save a puppy, and ultimately because of the bite of the puppy, which actually was unnoticed, and he didn't visit a hospital, and ultimately he succumbed to rabies and died. So just emphasizing on the point that rabies has 100% mortality and it is a simple and very much preventable disease. So anti-rabies vaccine, which animal bites are we supposed to give anti-rabies vaccine? First we will see for which bites anti-rabies vaccine is not needed. Majority of the times people come to EMD with a history of rodent and then rabbit. In all these cases anti-rabies vaccine is not needed. And small pets like hamsters or guinea pigs, so these are the set of animals wherein ARV is not indicated. However, ARV is indicated if the animal behaves abnormal or rabid suspect. So wherein ARV is indicated in all cases of dog bites, cat bites, monkey bites, bats, wild carnivores, and if any unknown bite or a wild animal bite, in all these cases ARV is indicated. Livestock, if suspected rabies, then again ARV is indicated. So coming to post-exposure prophylaxis, we divide the bites into category 1, 2, 3. One is just the touching or feeding the animals, then licks. Then 2 is nibbling on the uncovered skin or minor scratches. 3 is deep bites wherein there is a bleeder. So the post-exposure process, it is a three-pronged approach. Management of animal bite wounds, then passive immunization with rabies and active immunization with anti-rabies vaccine. So as per the revised guidelines released in 2013 by National Center for Disease Control Delhi, which is a WHO collaborating center for rabies epidemiology, modern cell culture vaccines are used. So these can be given either by intramuscular route or by intradermal route. The recommended WHO recommends the usage of intradermal use, and that because that is more economical, and this has become mandatory since February 2006. So the schedule for rabies vaccine is intramuscular route on the 0, 3, 7, 14 and 28 days. Intradermal, the dose which is given on 14th day is missing, and then we follow a 2-site regimen wherein intradermal for both the deltoids are given at each visit. So special scenarios, in pregnancy vaccination and immunoglobulins are safe irrespective of the trimester of pregnancy. So never withhold post-exposure prophylaxis. Immunocompromised, the dosage is the same, only thing is route prefer IM route over intradermal route. Then switch over from IM to ID route, that is intramuscular to dermal route is, or vice versa, is not recommended, and there is very limited data on this available. Pre-exposure prophylaxis, especially for these veterinary doctors and animal handlers, it is given on 0, 3 and 21 or 28 days. So this is the most common problem we face in EMD. So what are we supposed to do when a patient comes with missed anti-rabies vaccine? So as a general rule, do not restart the entire series. Just give the missed dose as soon as possible, that is when the patient returns. Long, for example, weeks to months. So again, continue the remaining doses, don't repeat the previous ones, because immune memory is retained and the protection will resume after the completion. If patient missed multiple consecutive doses, again still do not restart the schedule, give the next dose immediately and complete the remaining doses as per the new schedule. Then what is inoculants? Yes. So it can be given up to 7 days and not beyond that. If the patient returns after 7 days, he has not received immunoglobulin, do not give immunoglobulins. If the victim has previously completed full anti-rabies vaccine course, now again he has freshly bitten. Okay, so are we supposed to repeat the ARV following this dog bite? So we are supposed to give 2 booster doses. 2 booster doses, that is one on the day 0 and then on the day 3. That is the second dose. But however, immunoglobulins you don't give. They are only once in lifetime. This is because the person has already an immune memory. What to do in this case? The last vaccination was a year ago. Do I still need 2 doses? Okay, the answer is, if the patient has taken the vaccine within 3 months, then you don't have to give the vaccine, repeat the vaccine, but above that you are supposed to give them. Next, coming to prophylactic antibiotics. This is again a most controversial topic. Proper care can reduce the infection more than the prophylactic antibiotics. The prophylactic antibiotics are not required for low risk wounds, recommended only for high risk wounds, that is cat bites which are true puncture wounds wherein you can't clean the bases of the wounds, and then if they are presenting at a later stage and the bites, if the general condition of the patient is very poor, he is immunocompromised, in all of them the answer is yes, you are supposed to give prophylactic antibiotics. So these are a set of people in whom the antibiotic prophylaxis is advocated. A few of the pathogens which are isolated is dog and cat bites include for 5 days, and if the wound infected at the time of presentation itself or grossly contaminated, you can extend it up to 10 days or even longer. The first line oral antibiotic therapy recommended is amoxicillin clavulinate, and for high risk wound infection in the form of particularly from macaque monkey poses a risk apart from rabies. They also pose a risk of herpes virus B infection. Post exposure prophylaxis with valacyclovir or acyclovir should be given for about 14 days after immediate and thorough wound disinfection. So this is article which was published in Lancet regarding the wound management strategy and prevention and preventing the complications. So obviously debride the necrotic tissue, remove any foreign body if at all it is there. If there is suspicion of fracture or a bone penetration that has occurred, radiography is indicated. Prophylactic antibiotics in selected cases. Then consider MRSA also, that it should be suspected and kept in mind. And first line antibiotics for that include trimethoprim, sulfamethoxazole, doxycycline, minoxidil to be kept in mind. Then hospitalization if indicated, especially if the patient lands up into sepsis or with spreading cellulitis, hospitalization is warranted. Then culture for aerobes and anaerobes if at all required. Then another topic is human bites of the total bites. The etiology is mostly because of the other person who making a fist and then punching over the opponent's face. So it will cause a impact especially on these metacarpal bones and the skin over. So and occlusion is one first mechanism, and another mechanism is occlusion bites. So occlusion bites usually cause less deep injury, but the worrisome is this closed fist injuries. The reason being, though they look very small, not severe, the real damage is because of the germs in the human mouth, and the most common bacteria isolated is Echinella corrodens. The viruses like herpes, hepatitis B, C and HIV can also be transmitted through these this type of bites. So you have to keep an eye on or a watch on that. Closed fist injuries, that is punch injuries to the mouth, poses a risk of infection because the cut lies directly on the skin over the knuckles. So whenever the infection, whatever the infection is there, it can spread through these joint capsules into the palmar aponeurosis, and this might pose a danger complication like synovitis or arthritis. Measures like wound cleaning, pain relief, tetanus vaccine, and then coverage of antibiotics is required, and if at all any complication happens, then wound debridement should be advocated. Complications is, as I told you, if the person is hepatitis or HIV positive, then there are chances of transmitting of the virus, though it is extremely rare but has to be considered. HIV prophylaxis is indicated only if the wound is percutaneous and the mouth is contaminated with the blood. Hepatitis B and C management after a bite, that is C, no post exposure prophylaxis is required, only monitoring and close follow up is required. But for B, immunoglobulins, hepatitis B immunoglobulins only if the exposed person is not vaccinated or is or if he is a non-responder. If the person's immunity status is unknown, test for his anti-HBsAg antibodies. If the titer is less than 10, then you are supposed to start the vaccination and give the immunoglobulins. The last topic is scorpion stings. So probing into a little history, this is because this Dr. Himatrao Bavaskar, he is a physician. He recently got India's most prestigious Padma Shri award for his extensive research and work done in In 1980, the scorpion stings in rural villages were almost nearly fatal, probably because of the lack of treatment, medicine and medical awareness. It was this person, that is Dr. Himatrao Bavaskar, a physician who discovered the effective treatment, and because of his great contributions, the mortality rate has reduced from about 40% to 1%. So that is really good, and for which Padma Shri award was given in the year 2022 to him. Scorpion venom, it is again highly toxic and causes and spreads rapidly, causing early onset of symptoms. The venom potency varies by species to species. The most dangerous species mainly inject neurotoxic peptides. Wide variation in these toxins make antivenom the development of the antivenom very challenging. Venom symptoms include early and late symptoms. The early symptoms are mostly cholinergic, late symptoms are adrenergic. Management here is pain management by giving digital block with local anesthetic. The pain management is the treatment for scorpion sting, and monitoring, watch for cardiopulmonary complications, especially these myocarditis, LV failure, cardiogenic shock, assess for clinical signs, then use all these adjuncts. Out for previously used for scorpion sting are like lytic cocktail or insulin glucose drip. All these are outdated, no more used. Prazosin is the key drug, especially whenever you find these severe systemic symptoms. So prazosin is the drug of choice, and it reduces the mortality from 30 to 1%. Antivenom, in many cases it might be effective, but because of the availability and the cost and reduced benefit in the late and severe envenomations, works best early. When you give early, it might work best, and before severe toxicity sets in, if at all you are supposed to give, then give antivenom. The current recommended treatment is the combined use of prazosin as well as scorpion antivenom if at all available. If given within 4 hours plus timely referral if you do not have it, then closed ICU monitoring is definitely needed, especially in the background of this cardiac instability. So other drugs which are to be avoided here are steroids, antihistaminics, calcium channel blockers and diuretics. They are to be avoided because they worsen the cardiac complications. Then the take home messages: children are at a severe risk for complications of scorpion envenomation, sometimes even posing to death. The common complications following this red scorpion bite include cardiovascular complications like pulmonary edema and myocarditis. Timely detection of pulmonary edema and administration of prazosin can help prevent death due to scorpion. And then building up the primary prompt referral. All these things: a thorough wound care, delay in primary closure, tetanus, rabies prophylaxis, and keeping in mind that antibiotics are needed for a few of the, especially human bites, because they pose the risk of infection, especially these closed fist injuries. And then effective treatment requires training, pathways, and education. So with this I conclude this topic. Thank you.
Thank you so much, ma'am, for giving the valuable insights.
Any questions from the audience? Ma'am, your talk was very elaborate, and in fact you covered a huge topic in such a small amount of time, which is very commendable. I had one doubt. Now, patients, when they are presenting with dog scratches and cat scratches, do they need any
then anti-rabies vaccine is definitely indicated because they are at a high risk of progressing to rabies, which has 100% mortality. So yes, vaccine is definitely indicated. And about immunoglobulins, they are indicated in category 3 bites.
Thank you.
Just to add up one point, always vaccine to be given only deltoid layer, and
Yes.
not in the gluteal region, and RAG should be infiltrated around.
Maximum around the wound.
If it is not sufficient, we need to dilute and
Correct.
make it.
Because it is estimated that nearly about up till 48 hours, whatever virus is there, it is active at the wound site for nearly 48 hours. So it is always better to maximally infiltrate the wound site with these immunoglobulins.
Thank you, Dr. Any more questions from the audience? Post-graduates?
Not a question, madam. In a general discussion, I want to know info from the senior persons. Actually, we have discussed the topic extensively has been discussed on management of the animal bites, vaccination, immunoglobulins and all. We have actually encountered 2 cases where the patient has already come with full-blown rabies. Patient was having rabies encephalitis, and patient has come in the terminal stage to us. So, we know that rabies will ultimately make the patient succumb to death. But what my doubt was, is it a notifiable, because it is a notifiable disease, so what is the process of that notification? In your public health perspective, how should we notify it to the authorities so that subsequently we need to prevent the spread of it, or availability of immunoglobulins could be made available to the patient? Just I want to know the information.
Madam, usually rabies cases are not handled at our hospital. We send to this Narayanguda hospital, and I think there is a registry which is maintained for all these bite cases there, and probably from there the government of India seeks the census from.
Because I just had to ask that, because in front of me I saw the patient, young patient who was succumbed to death, and there was no immunoglobulin available in such time, and we could not even notify to the local authorities. So there was a rise in the incidence of the cases. So I thought maybe I will know it maybe the next time so that it will be useful. Thank you.
Immunoglobulins are available in the government hospitals. All district government hospitals, they do have immunoglobulins vaccines available. But as you asked regarding notifying the concerned authorities for this encephalitis,
But all the hospitals were not taking up the case. No patient, the patient was because it is a rabies. No, we don't have this. No patient, no hospitals were taking up the case. And the government hospitals referred. That's why
So for any notification part, actually the DMHO is responsible. There is a one wing called District Surveillance Officer. So you just tell him and he will come with all the this thing. And just you find out which district you are. So DMHO will have a wing called District Surveillance, and even WHO is having a surveillance for all communicable, notifiable diseases. That team has to come. So then only it will be there. So I have one doubt, madam.
Yes.
So wound has to close or open, because there is no difference in 5 trials. Closed or open?
Sir, it depends upon, it is always better to keep the wound open and let it heal by secondary intention, sir. But in case the wound is very big, majority crush injuries, wherein it needs at least stay sutures to be applied. those can be applied, that too after thorough debridement. This is what the evidence says.
Yeah, thorough debridement will be the first
And
priority.
irrigation.
True, the irrigation is also mandatory, but flows are open.
For
So
simple
because there
wounds,
is, in the trials what you have shown now, there is no big difference and.
yes sir, in the infection rate there is no much of difference, only cosmetic appearance wise they say suturing left right, but what we advocate is for simple wounds to be left open until and unless it is a very huge wound which needs probably state sutures.
Confusion is still there.
Probably a research topic, sir. Thank you very much.
Excuse me, madam. If the dog is alive after 10 days, can we discontinue the remaining injections?
Sir, theory says that, but I feel because rabies carries 100% mortality, it is always better to give the whole course of vaccination.
Because I was told that no dog survives beyond 10 days if it is rabid.
That is true, sir, and most of the instances where we get bite from rabid are street dogs, and it is very difficult to trace the.
If you can trace, suppose pet dog with you.
Literature says you can discontinue if the dog is not rabid, but in spite of which, to me, it is you are supposed to take the full dose. At least vaccination.
Now I would request Dr. Krishna Suman sir to present a momentum. With this, we will end the session 1. We will be proceeding to session 2. Thank you. And I would like to thank our chairpersons for participating.
It's my pleasure to invite esteemed chairpersons for our next session. Dr. Mamata sir, Professor, Department of Emergency Medicine, Mamata Medical College. Dr. Ranjit sir, Assistant Professor, Department of General Medicine, Mamata Medical College. I would like to call upon our first speaker for this session, Dr. Jyoti Swarup, MBBS MD Emergency Medicine from AEMS, New Delhi, to deliver his talk on salicylate poisoning. I request our chairpersons to introduce our speaker.
So, I would like to invite Dr. Jyoti Swarup sir, MBBS MD Emergency Medicine from AEMS, New Delhi. So, MBBS from Mamata Medical College and MD from AEMS, New Delhi, Emergency Medicine. First topic is salicylate poisoning, salicylate toxicity, patterns and reflex. More please.
పనిచేస్తుంది అది దీని కనుక అన్న కాలమేగా ఓకే ఇది కాదు ఇక్కడ లైక్ ఏందన్నా స్లో అవుతుందా ఓకే hello
Sir has received some awards also from Industry Award
Hello.
for Best in Emergency Physician Award and the Best Students Award at Jubilee. And he has received both during his MBBS year in Pediatrics, Obstetrics and Gynecology in final year. And Sir has received various awards.
Thank you. Hello. Mic. Call mic. Okay. Okay. So very good afternoon, everyone. So here, so at this, when this drug gets into the patient, then the patient will be, can overdose himself, right? So you know which of he somewhat agitated and he is full of anything else, but he ear is ringing. Okay, so BP is 100/70 and respiratory rate is 38, and also there is still now. What
do we want to stabilize? Is a BP of 100 rate of trying to do that. So there is an approach. You can't take history fully, HOP. First, before coming to a diagnosis. So when you have minimal some lab investigation, if you can work in emergencies, because if you delay, what will happen is there will unstable physiology. Even with normal vomiting, loose stools, gastroenteritis can lead to that. Okay, so we manage. So the patient asks whether give some. What do you want to do now? Neck rigidity? Huh? Okay, you want blood gas? Okay, so blood sugars are 98 milligram per deciliter. What do you want to do? This patient with a normal blood glucose. There are, we'll be discussing about all these variations of you need to give administer. Okay, on this we will try to diagnose some toxins. which if it is increased, if it can be respiratory rate increases, that is overdose. And if there is no response, similarly increase, you will assess the oral cavity. You assess the oral cavity if it is dry, or it can be normal as well. So if it is normal, points to if it is increased, so any drug, we focus on 4 Ds. So what is the drug, and what is the dose, and what is the duration of ingestion or intake, and what is the
In a patient with intentional harm or accidental injection or homicidal injection,
this one, so that will be more than the therapeutic one. And duration,
we can differentiate based on acute or chronic, right? Acute or chronic, and also
usually within few hours or that, so we can differentiate. And
route can be what? Oral, IV aspirin is available. So usually, obviously, so topical
is available.
You know, you have many preparations. So this is a tablet form, aspirin.
It has 75 mg,
325 mg and other variations.
150.
So this, what is this? Yeah, so this is what? Topical analysis.
So topic that has 31%
of methyl salicylate, 31%. And if a patient has chronic usage of this daily, you know, topical is normal, and you know, and also in areas where skin absorption is more, like genital areas, inner thighs, so where the skin is thin and also absorption is faster, so patient might develop chronic chronic salicylate poisoning. Okay, so topical and also, and anyone recognize this?
Yes, anyone, what is this? Anyone can recognize this? What is this oil?
Oil of wintergreen. This is called as, in Ayurveda is called as Gandapura oil. Okay, this has high methyl salicylate. Okay, and normally what is the aspirin? We measure in mg, right? In this one ml contains 1.4 grams of aspirin. Okay, 1 ml contains 1.4 grams, not mg. 1.4 grams. So,
and
1 teaspoon
is enough, 7 grams.
Are the toxic doses reached. 1 teaspoon is enough. And if a patient or a toddler in our
and if he is having contact with this one, accidentally ingest,
that will be a death sentence for him.
Okay, so
1 teaspoon is
also a death sentence for this.
And
you know, most of the
Dr. Ortho oil and some other, Ayurvedic, this sort of thing, usually has some, you can see in this one,
So this is called as Gaultheria oil.
That is Gaultheria is the scientific name on this one. Okay, Gaultheria is the Ayurvedic name. And some other agents
Which has aspirant salicylate.
or Pepto-Bismol, which is used for anti-diarrheal agents.
So and
Not just the general physicians, cardiologists and the physicians, emergency physicians. So dermatologists use a lot, and also it is advised, but it's in a low concentration, and also they will apply on that.
so this should not cause
Usually
until they are extensively.
right? So and everyone has had alam chai, ginger. Headache will be, you will have you can feel that headache, disappear within minutes. So ginger has salicylate in it. Okay, so everyday ginger or other chutney can also, it is not
good.
Chronic toxicity
It's also
if it in large quantities. Okay, so has little bit. Okay,
So that
these are all this one, and also sometimes when heat can also increase, heat can cause vasodilatation at that local area, so that will increase the absorption of the drug. Okay, so the common sources are all this,
which we have discussed, and these are all the user.
normal available salicylates. So the cutaneous form depends on dose, frequency, age, surface area. So you need to remember these things. And occlusive dressing. Any patient having an inflammation and you have applied some analgesic cream over it, that will also increase the absorption. Okay. And psoriasis, which is a like the skin, like is partially discoloring, so that in that disease was done, so it will increase the absorption.
So and
The main side effects, like the side effects of the aspirin, can be remembered as
there can be some
susceptible to bleeding,
Raynaud syndrome in children,
and irritation of ears. And all these side effects will be a salicylate toxicities manifestation. That's all. So the toxicity can be acute or chronic. Acute toxicity usually we see in intentional harm or accidental harm of the patients, young patients.
usually they are extremely obvious. The patient will
himself tell the
injection of the drug.
And key symptoms would be,
As it is an acute injection, they will have all manifestation most of the times. And if the patient has, around
less or
moderate toxicity or mild toxicity, they will have some,
they don't have the organ toxicity as well, the toxicity symptoms.
And in chronic intoxication, it is deceptive.
It has many masks, which we will discuss. So, and some
Invisible killer will be our oil of wintergreen.
So that would be, if you consume at least 5 ml is the 10 kg child. You need to remember that. So you should be aware that the Ayurvedic medications, which we assume that this is benign, is actually can be harmful. Okay. So, and the toxic dose would be 150 mg per kg is less than that would be
having a minimal symptoms, 150 around
9 grams in a 70 or
60 kg.
And 150 to 300 would cause mild to moderate, and more than 300 is severe, and more than 500 is a potentially lethal toxic dose. And we are trying to stabilize that first patient. Suddenly, second patient comes. Okay. So this is on bed number 2. Her name is Sugunamma.
So she is transferred from a
nursing home,
and she is complaining of some fever. And this
patient,
the
transfer sheet from that
nursing home
stated that it is they are suspecting some urosepsis in that, and she is appearing confused, distinct, and mumbling. And her vitals are technically there. BP is around 160, heart rate is around 5. Temperature is also around normal. So what do you do in this case, ma'am? Directly anadrops. For our first patient is still waiting for our management. It's still not improved. Okay, the Mahesh is not improved, Subinama is just over, right?
So what do you want to do? So her normal vitals are
around 100 to 60, it's relatively in a borderline state, but then for an elderly patient it's okay. And heart rate is somewhat increased. Okay, there is relative tachycardia. Okay, and her labs are like this. WBC counts are around 14K, anemia is 16, lactate is 2.2, and the treating team assume that this is something could be, obviously the patient is in nursing home, she might have contracted some disease, this could be some sepsis. So start with sepsis bundle care. Okay. So fluids they have given, then I will start on
antibiotics.
4 hours later the patient is curated. And around that time her son, who stays in Hyderabad, she came. So he told that that the patient was using some analgesic cream, okay, for last 3-4 years. So this sort of presentation can be also be seen. So what I'm expecting here, sepsis. So sepsis mimical. This could be a potential salicylate toxin. Okay, because the patient is an elderly and she will be on some multiple drugs, and there will be polypharmacy type of thing and multiple drug interactions. So and also, if the patient uses multiple times on a daily basis the analgesic cream and other drugs usually, so orally also there will be analgesic
drugs, medications for her.
So usually she might
be having some
chronic salicylate poisoning. Okay, we should suspect that. So there is high index of suspicion is required for patients. Not just acute is evident. The patient himself still. So obviously patient will tell that he has ingested. But in chronic,
it may be sepsis or some other
disease drug. So aspirin works by what? COX inhibitor, right? So COX1 is this one.
Like antibiotic, analgesics, and antipyretic. COX2 also inhibit and it reduces the
blood flow and other drugs, as it reduces the mucosal blood flow and it can cause gastritis, other side effects. So the salicylate once ingested, it will cause what? It will be hydrolyzed in the stomach and also
it will get absorbed.
After it enters the blood, so there will be kinetics. So it will have some certain half-life. It will be eliminated or metabolized. So the half-life of normal therapeutic aspirin is 2 to 4, and peak concentration will reach in 1 hour, and entry period is somewhat delayed. When compared to the toxic one, half-life is
around 20 hours,
and peak concentration can be prolonged. As Sir has pointed out earlier in sessions, so there is acute ingestion and there is staggered one, and also there is some supratherapeutic. So here, what happens with aspirin is once it gets dissolved, usually when but this free salicylate will have an impact on the organs as well, right? So in salicylate it will be combined with the glycine, and it will 73% will be salicylic acid, and the remaining 10% will be phenolic and acyl glucuronide and genesic acid. So these are the metabolites of a salicylate, and usually zero order is the one, and also there can be first order elimination in a toxic dose. Okay. And once the salicylate is in the blood, it will obviously enter into the organs. So once it enters the brain, it will have what? Immediately it will stimulate the medulla and it will increase the respiratory rate, causing respiratory alkalosis. So direct respiratory alkalosis stimulate. So this will increase the ventilation, and because of the increased ventilation, so there will be, and also pH will increase, and also there will be requirement of more energy, and fat will also be, there will be increased lipolysis as well for that. And it is a mitochondrial uncoupler, so it directly acts at the electron transport chain. So where ATP is produced. So because of that, the normal glycolysis, then after that the further steps, electron transport chain will be halted, and also the ATP won't be generated. So there is no energy, and there will be a lot of heat generation. So there will be hyperthermia. So because of this, patient might have some fever. Okay. So because of the metabolic uncoupling, and biochemically it will manifest as metabolic acidosis. So there is respiratory alkalosis because of direct stimulation, metabolic acidosis because of the uncoupling. Okay. And there will be non-ion gap as well. So in the mitochondria, usually it will increase the lactate production, and so lactate will increase, so there will be Khammam, high anion gap. Then at the nephron, it will also cause non-ion gap metabolic acidosis. So there are two metabolic acidosis and one respiratory alkalosis. So this is the classic presentation of our salicylate. Okay, so it is causing what? It will directly stimulate respiratory center, and it will also interfere with the biochemical mechanisms that will cause metabolic acidosis. So these are the two things. And when it is uncoupling oxidative phosphorylation, it is causing hyperpyrexia. And the other, lactate and anion gap metabolic acidosis. So there will be, initially you will find respiratory alkalosis, alkalemia and alkaluria. Intermediate phase you will find respiratory alkalosis with metabolic acidosis and alkalemia and aciduria. In late phases, metabolic acidosis with either respiratory alkalosis or acidosis. So this is like a acid-base roller coaster. So patient might have, might be presenting to emergency in any state. So you need to have a high index of suspicion for diagnosing this. So when acid-base, this sort of things are there. So what is our next step in this? What will be our next step, sir? So patient has primary, this one, respiratory alkalosis, metabolic. What do you want to do now? You remember our first patient? Patient had a history of seizures. You want to do anything for that? Huh? Sorry?
Given benzodiazepines.
Anything else, sir? Calcium? Why, ma'am? Why? Okay, so we will discuss what to give, and is the glucose normal in that patients of salicylate? So because, so patient with normal glycemia will have seizures in salicylates. Okay, so in these patients we need to give dextrose for these patients because there will be uncoupling, right? Even though there is serum glucose, normal glucose level, there will be hypoglycemia and also direct neural toxicity as well. Okay, so in these patients, so this is a paradox of salicylate poisoning. And increased Khammam patients, so usually the usual differentials will be renal failure and ketoacidosis, toxins and sepsis, and lactic acidosis. So these are our usual mnemonics which we use for diagnosing Khammam. And in patients with salicylates, you need to remember 3 pHs. So serum pH, there is tissue pH and urine pH. So serum pH, what do you want to do in this one? You want an acidic pH or an alkalotic? Alkalemic, Sir, what do you want?
Alkalotic.
Why? So why can't be a normal one?
Why can't we target for normal pH? Okay, so in acidosis, salicylate will be in non-ionic form. In alkalosis, it will be in ionic form. Non-ionic form, is it diffusible, or ionic form is permeable to, across the membranes, which is permeable? Ionic can permeate or diffuse across the membranes. So non-ionic can diffuse, right? So ionic can't diffuse, so it can only stay in that, a compartment. So if it is a non-ionic, it's a green signal. It will directly, get into any organ it wants. So CNS, kidney, liver, anywhere it can go, it will directly have its effects on it there. So if it is an ionic form, it's a red light. So it can't go. So green, the non-ionic form diffuses across membranes, it will cause organ toxicity. Ionic form is non-permeable, it stays in that blood vessels. Okay, so which one do you want now? Ionic form or non-ionic form in the blood vessels? Ionic form, because at least we are limiting the toxic drug in that compartment, right? Blood vessels. So obviously it should stay. So we should target what? Alkalotic. Yeah. So alkalemic pH is what we should target for. Okay. So for us, ionic is a good guy. Non-ionic is a bad guy. Okay. Relatively, obviously both can interchange anytime. Okay. So ionic is somewhat a better one, and so for that we need to increase that alkalotic part. Okay, and non-ionic is a bad guy. So it can move across and also change across that. Okay, so to do that, what do we want? What should we do then? What is our base which we can administer bicarbonate? Okay, so we need to have a strategy to incorporate bicarbonate into our management. Okay, so bicarbonate is like we have to maintain an alkalemic one. And also when we have to do, and also not just the serum pH, if we increase the urinary pH. So normally acidic urine will cause what? Again, acidic will cause non-ionic form, right? So again it can come back into blood. In the urine part I'm telling you. So we need to also alkalinize the urine as well. So once we administer serum, soda bicarb, obviously we have to target that the urine pH should also increase. So this will increase the excretion of the salicylate. Okay. So there is serum, we have to target pH more than 7.5 and also urinary pH more than 7.5. Okay. So this will increase our metabolism. Okay. And when we are trying to diagnose that, there is another patient in the emergency. So this is Ramesh, who is a 75-year-old male, and he was brought in by his family for his strange behavior, tremors, and he had a history of alcohol use disorder. Okay, and when you examine, he's ataxic and he's having slurred speech, and he's agitated and with tremors. What do you suspect in this? With an alcohol use disorder? Huh? Some withdrawal or anything else? Wernicke's, okay, anything else? So there are many differences for a patient coming with the outer mental status, obviously. So his alcohol level is 0, ammonia is normal, CD8 is normal, and routine investigations are also normal. And when you ask for detailed drug history, the daughter told that the patient was using a lot of analgesics for his back pain. So salicylates again. So in this one, it could be anything, and patient was diagnosed with some encephalopathy of undetermined origin because the all routine investigation is normal. This is a real case, okay, published in NEJM. So normal symptoms of our salicylates will be what? Hyperventilation, not just the rate, there will be hyperypnea, means the minute ventilation will be high. So rate will be high and tidal volume will be high in these patients. And fever, tinnitus, vomiting and acidosis. So all the symptoms will be there, and also patients with mild will have relatively come out less symptoms, and diaphoresis, headache, and this one. With patients with moderate to severe will have all the organ toxic or end organ damage symptoms. Like patient will have kidney failure and other things, and also patient might throw up seizures and respiratory distress. There is a entity called as salicylate induced pulmonary edema as well. So this sort of thing. So many presentations can happen in patients with salicylate toxicity. And how do we diagnose a patient with salicylate toxicity? How do we diagnose? You know the symptoms, right? How do we diagnose? Based on what? Sir? Based on the history is one thing. Then based on presentation, blood gas, and anything else? Some serum level you want to do? Serum assay of the salicylate, yeah? Then after that, anything else you want to do? Okay, so serum salicylate is one thing, but so if you want to just diagnose the patient on serum salicylate, in early part of presentation, will that be reliable? Will that be reliable? Obviously no, right? So the nomogram, which was, in a paracetamol poisoning, usually we use what? Rumac-Matthew nomogram, where we plot against that. Here we use something called as Dunn nomogram, which was used. Now it is obsolete. We don't use that because the absorption is erratic, and so we don't use that. Yeah. Yeah, sorry. Sure. Oh, sorry. Maybe. So we have come to what? The clinical features, mild, moderate, severe part, where we have seen presentations varied from normal physiological variations from normal respiratory one, and along with that patient might also have some severe symptoms like cerebral edema, pulmonary edema, renal failure, and other things. So in all these patients we need to first of all diagnose. So it is diagnosis based on history and physical examination. History mainly the drug history and other things, and properly examining the patient. And blood gas will have classic respiratory alkalosis with metabolic acidosis, and also we need to send serum salicylate. There is a test called as ferrichloride test, bedside. Urine we can do that, but that is somewhat, sensitivity is less. There are confounders as well. So purple color, if it turns into, the urine turns into the purple color, not the, we have to check urine pH. Urine this one. So we have to continuously measure not just the serum, blood gas, but also urinary pH, so that whether our management is effective or not. Okay, so moderate, then we need to do after like moderate to severe and this one. So what is your strategy, treatment strategy or principles, management principles? So management strategy of the patients will be what? Starts with again airway. Priority will be like that. So A, B, C we will go, and also we will evaluate other things. We have to stabilize their physiology. So in these patients, patient will be of what? See, patient will be tachypneic, right? So minute ventilation is high. So patient is generating almost like 40 to 50 liters per minute of minute ventilation. There is rate, increased rate, tachypnea is there. There is increased tidal volume as well. So minute ventilation is high in these patients. So if you intubate these patients, like with normal routine management, like give induction, give paralytics, patient is gone. Patient won't come back. And there are many studies and review articles and also case series on these patients. Patient was intubated, then peri-intubation arrest was there. Post-intubation patient died. And they could not revive, loss was not achieved at all. So when you are doing an intubation in these patients, so when we intubate the patients, we need to follow a strategy called as, there is something called as push dose pressors in a patient with shock, right? So in these patients, we have to use push dose bicarb. So we administer 2 milliequivalents of bicarbonate earlier on and we need to achieve a good alkalemia, then we need to intubate. Because when we are, and also awake intubation is preferred. When we use a paralytic, what will happen is during that apnea, patient will have what? Suddenly drop in the pH, and suddenly when pH drops, that ionic form becomes non-ionic and then it will diffuse across the membrane into the blood-brain barrier, then neurotoxicity, and patient will drop seizures. And that is one thing. So awake intubation is preferred. Then after that, coming to the breathing and ventilation, breathing part. So breathing respiratory rate is high, right? So you can use something non-invasive if at all the patient is having severe work of breathing. That's all. So usually that is preferred. If the patient collapses or if the patient airway is threatened, then you don't have anything, but you have to keep a higher rate. Mechanical ventilation settings should be high in those patients. Then in patients with salicylate toxicity, usually you will find there will be a lot of volume depletion. So volume depletion you have to correct with fluids. Fluids should be given around 10, like 20 ml per kg based on the requirement. You need to assess with focus and IBC. You have to check for that. And usually volume depletion will be around 4 to 6 liters. Volume depletion will be there. So you need to appropriately resuscitate the patient. So after fluid depletion, you need to remember one DSP, dextrose, S for soda bicarb, P for potassium, DSP. Okay, this is the treatment. We don't have any antidote for this one, but there is supportive management. But with this dextrose, soda bicarb and potassium supplementation, the patient will improve. So dextrose usually 1 to 2 milliequivalent per kg you will use, and also along with that you will serially monitor, and you need to supplement with that soda bicarb. Soda bicarb you will use around 1 to 2 milliequivalents, and dextrose refill water D50 based on the patient requirement, and potassium supplementation 20 to 40 milliequivalents with continuous monitoring. If you don't correct potassium, if the patient's pH won't improve. So hypokalemia will have an effect on the pH as well. So obviously the patient, if there is hypokalemia, you need to supplement with potassium. Okay. So DSP is one thing. Airway you should properly manage. Usually it is better to avoid intubation in a patient with, even though patient is severely tachypneic, the patient will try to compensate it because there is medullary stimulation, right? So that is one thing. And glucose, even with the normal or normal levels, you need to supplement or administer dextrose in these patients. So these are the main things. And finally, when the patient, you suspect that patient is having a salicylate, we need to remove it, right? So how do you remove? There is some entry point and exit point. Entry, when patients comes to emergency, you will do what? Decontamination with activated charcoal. So activated charcoal 1 gram per kg, and in adults you can go till 100 grams, and usually children 50 grams. Activated charcoal is one thing, and multi-dose regimen is important, and also enhanced elimination is important. And hemodialysis we have to activate as soon as possible because it will take some time to arrange everything for hemodialysis. Okay, so fluids, salts, and sugars. This is our treatment strategy for salicylate toxicity. Thank you very much, and sorry for extending and going beyond the time. I try to do my best. Thank you so much.
Thank you so much, sir.
And I'd like to thank organizers for giving me the opportunity to deliver this. Thank you.
Thank you, Dr. Dilshul. Sir, it was an extensive talk and covering most of the thing. I think with this, if there are any doubts, we can catch up with the lunch session. We'll be breaking down for the lunch session right now. It's only for 15 minutes in view of the time.
Yeah, already we are behind the time. I request Dr. Hanumantrao sir to hand over a memento to our speaker.
Yeah.
So we'll break for the lunch. I request all of you to join as soon as possible because we are running behind the time.
Yeah, we'll break only for 15 minutes and we'll get back to the topics as soon as possible. Thanks. Dr. Sindhura graduated from SSIMS Davangere, topper from the EJU days, and she did her MD from JJM Medical College and gold medalist from there. Did her SR in Bangalore Medical College and Victoria Hospital during the COVID days, and presently working as a consultant in Sindhu Hospital and AIG and Continental Hospitals. So she is going to
decontamination, when and how? So over to you, Sidhu.
Thank you, sir. A very good afternoon to one and all. It is a privilege to be here at the Toxicology conference, and I thank all the organizers for this opportunity. Coming to my topic, I'll be discussing about decontamination techniques, when and what to use. So before we get into the topic, this is the outline through which I'll be taking you through. First we'll be discussing on principles of decontamination, and then a quick dermal decontamination and ocular decontamination insights, and a detailed GI decontamination will be dealt herein, and then finally we'll see a stepwise practical approach of decontamination in the ED. So coming to the principles of decontamination, the primary goal is to prevent further systemic absorption. And like we've always been talking of, ABCDs is the first thing that we have to support. And then consider time since exposure, substance properties and all while decontaminating, and always balance potential benefit versus risk. Risk as in the aspiration, perforation, electrolyte disturbances, etc. So coming to dermal decontamination is usually indicated when any liquids or powders are on the skin that can be absorbed or cause local injury. So the first and foremost thing is to remove the contaminated clothing immediately, through which we would be cutting down the toxin load by around 80 to 90%. And here also comes the concept of dry decontamination. So this dry decontamination should be done first, particularly if the chemical is particulate or adsorbable, as in case of vesicants or elemental metals. And the dry decontaminating agents are either powders or fullers earth that we can use, and this should be followed by our traditional hydrotherapy. So hydrotherapy is to irrigate with copious water for at least 15 minutes, and this duration is for longer in case of corrosives or irritants. Always avoid aggressive scrubbing for corrosives. Remove clothing and irrigate underclothing if needed. So coming to the next ocular decontamination, this is one of the most important thing that we can do, because it is the first most preventable cause of blindness that we encounter in the ED. So whenever a patient has had any chemical exposure, the initial symptoms might not be that evident, but immediate copious irrigation with Morgan's lens or saline should be done as the first step in ocular decontamination, and that has to be continued for 30 plus minutes for alkalis and corrosives, because they seep in more rapidly. And then check visual acuity, that is pH of conjunctival sac, and repeat the ocular decontamination until pH normalizes to between 7 to 7.4. And avoid neutralizing acids or alkalis with chemicals. Strictly irrigation only is the key. So coming to GI decontamination, not many controlled clinical studies have proven that there is any great outcome benefit when it comes to using GI decontamination. But we can definitely understand when it can help and when it should not be performed. So GI decontamination may help, and it is most likely to be beneficial when a patient presents within 1 to 2 hours of ingestion and has taken a potentially toxic amount, and when the patient is clinically stable enough for decontamination, that is airway being protected and no other major contraindications being present. And number 4, but not the least, the substance is amenable to decontamination is what has to be considered. And when not to perform decontamination is when the patient has come to us very late and the drug is likely absorbed, and when there is a clearly non-toxic ingestion, and if the substance is not absorbed by charcoal or not removable, and when decontamination would increase risk, as in case of caustics, hydrocarbons, etc. So methods of GI decontamination will be dealt in 4 major modalities. Number 1 is activated charcoal, number 2 is multi-dose activated charcoal, number 3 is whole bowel irrigation, and 4 is gastric lavage. So what is activated charcoal? Activated charcoal is a highly absorbent carbon network that binds toxins in the GI tract. and it is most effective when given early. Best is within less than 1 hour, and it is also effective when there is significant toxin remaining in the stomach, and it's the drug that is absorbable by charcoal, and that is what we have to be clear about. So even though the 1 hour rule exists, benefit may extend beyond 1 hour, especially for large ingestions, sustained release formulations, and for those drugs with delayed gastric emptying. So coming to the contraindications of activated charcoal, the absolute contraindications are mainly depressed mental status without airway protection, and other absolute contraindication is intestinal obstruction. However, the relative contraindications are late presentation of the patient, high aspiration risk as in case of hydrocarbons, and when endoscopy is needed as in case of caustics. Usually the activated charcoal, if used, obscures the view in endoscopy, and that's the reason it is a relative contraindication. And this is the list of poorly absorbed toxins where charcoal is not recommended. Heavy metals like arsenic, lead, mercury, iron, and inorganic ions like lithium, sodium, calcium, potassium, magnesium, boric acid, corrosives, hydrocarbons, alcohols, and essential oils. In all of these agents, activated charcoal is not recommended. Coming to the dosing, it is usually remembered as 1 gram per kg. In adults, it is usually given as 50 grams. And in children between 1 to 12 years, it is given as 0.5 to 1 gram per kg. And in infants less than 1 year, it is given as 10 to 25 grams. And the goal of dosing is activated charcoal to toxin ratio should be between 10:1. And how do we administer activated charcoal? It should be mixed with water as gritty slurry. And this of course was not palatable. So flavoring can increase compliance, but may reduce absorption. So sorbitol containing formulations are usually well tolerated, but sorbitol again works as rectal evacuate, so it should be avoided in repeated doses in children. So coming to the complications of using activated charcoal, they are very low, but activated charcoal is generally safe. But the bare minimum complications that we can see are nausea, vomiting, abdominal discomfort, constipation, and all of that. And aspiration risk is really low. It is less than 1%, and especially it is seen when there is unprotected airway and when activated charcoal is given with gastric lavage and when the NG tube is misplaced. So coming to the evidence that we see on activated charcoal, there's a lot of volunteer data which says that up to 95% reduction in absorption is there when given within 5 minutes, and 50 to 75% reduction of the absorption of the toxin is seen if the activated charcoal is given within 1 hour. And there are mixed results beyond 2 to 3 hours, and it is all drug dependent. So coming to the clinical data, a lot of randomized control studies have shown no consistent improvement in mortality or ICU stay or clinical deterioration. But observational studies show a lower liver injury when activated charcoal is given up to 8 to 12 hours after acetaminophen ingestion. And there is a benefit in massive paracetamol, rivaroxaban, and selected delayed release drugs. So the bottom line is activated charcoal helps when the right patient is chosen, not as routine. So coming to the next modality, that is the multi-dose activated charcoal. It basically enhances elimination via three different ways. One is it interrupts the enterohepatic recirculation, and the second way is by gut dialysis, which is nothing but the gradient-based diffusion from bloodstream to gut. And number 3 is it reduces absorption of delayed release drugs. So this is usually indicated in life-threatening injections of some of the medications like carbamazepine, dapsone, phenobarbital, quinine, theophylline, in which there is strongest evidence. And it is also found to be beneficial in phenytoin, digoxin, amitriptyline, nadolol, and piroxicam. But there is limited clinical evidence in these cases. So the contraindications are same as what are seen with single dose activated charcoal. But apart from that, the other contraindications are when there is IES, suspected bowel obstruction, and when there is poor gut motility, MDAC is contraindicated. And how do we dose the MDAC? Initial dose is as per single dose activated charcoal, and then on 25 grams every 2 hours or 50 grams every 4 hours. And the infusion rate should be minimum of 12.5 grams per hour. And always remember, avoid adding sorbitol repeatedly. So the complications here also are minimum, and they are either constipation, bowel obstruction, and a couple of rare case reports have been shown where there is bowel perforation post multi-dose activated charcoal. But the evidence is not so clear. And coming to the evidence regarding MDAC, volunteer trials have consistently shown increased drug clearance, and large randomized control studies prove no overall mortality benefit, likely due to late presentation in all of them. And in one positive randomized control study, MDAC has shown to improve outcomes in yellow oleander poisoning. So coming to the next modality, which is whole bowel irrigation. Whole bowel irrigation is polyethylene glycol electrolyte solution flushed at high volumes until stools are seen to be clear. So indications of whole bowel irrigation are it is most useful for extended release or entering coated formulations when activated charcoal may no longer help, and in poorly absorbable toxins like in case of iron, lithium and lead containing foreign bodies. And importantly, it is done in body packers where endoscopy is also contraindicated because the risk of rupture of those packets is well seen. And last is some transdermal patches which have been accidentally ingested, like I'm talking of some clonidine patches related study which shows that there is indication of whole bowel irrigation in them. But however, the evidence is sparse and not used for fentanyl patches though. So coming to the dosing of whole bowel irrigation, in infants between 9 months to 6 years, it should be given as 500 ml per hour. In 6 to 12 years of age group, it should be given as 1 liter per hour, and in adults, it should be given as 1.5 to 2 liter per hour. Always continue until the rectal effluent is clear. Coming to the contraindications, again, IBS, bowel obstruction, GI perforation, significant GI bleeding, or any hemodynamic stability or intractable vomiting, if at all is there, then whole bowel irrigation is contraindicated. And complications are minimum, nausea, vomiting, bloating, cramping can be seen, and there is no strong evidence of aspiration when used appropriately. So evidence on whole bowel irrigation goes like this. In volunteer studies, we've seen a lot of mixed results, and they say that it may interfere with charcoal if given simultaneously, but case studies support benefit in iron and body packers. Retrospective data support use in lithium ingestion. So that was about whole bowel irrigation. Coming to the last modality of GI decontamination, which is gastric lavage. It refers to the passage of a large bore oro or nasogastric tube followed by repetitive instillation and aspiration of small aliquots of fluid in an attempt to aspirate pills or toxins from within the stomach. And when do we have to consider this? It is usually considered when there is potentially lethal ingestion and when the patient presents to us within 1 hour, and if the patient has a airway protected, and when the toxin is not absorbable by charcoal, or if there is a massive ingestion. So what are the contraindications? It is not to be done when the airway is unprotected, and it should not be done in caustic ingestion or hydrocarbon ingestion. Also when there is GI bleeding risk and in cases of recent GI surgery. So the complications are majorly aspiration pneumonia, esophageal or gastric perforation, hypoxia, dysrhythmia, fluid or electrolyte imbalance, and sometimes it is shown to push tablets beyond the pylorus. But evidence says that gastric lavage is rarely indicated now, and routine use is not recommended by either American Academy or European Association of Poison Control. And volunteer and clinical trials show that it's frequently ineffective and may push tablets forward into small intestine, and there are higher aspiration rates than charcoal, and there is no improvement in clinical outcomes compared to activated charcoal. But rare subgroup benefit when performed within less than 1 hour in selected massive injections is found in evidence. So coming to the practical ED algorithmic approach for GI decontamination, in the step 1, we always have to assess ABCDEs and then do an airway protection. If GCS is less than 8 or if there is vomiting, intubate for airway protection, not for the purpose of charcoal. And in the step 2, risk assessment is what has to be done. Always ask what toxin, how much, when, formulation, if it is sustained release or extended release, and if there are any co-injections, and the symptoms. Having asked about those, and coming to the third step, choose the safest decontamination. In a scenario where the patient presents to you within less than 1 hour with high risk ingestion, the best modality is activated charcoal with or without lavage, and that depends from center to center. And in case of 1 to 4 hours of time since ingestion, and if there is large ingestion, then activated charcoal again. And in case of sustained release or extended release ingestion, or especially in late presentation, whole bubble irrigation with activated charcoal is the best modality. And in case of lithium or iron toxicity, whole bubble irrigation is the best modality, and in life-threatening toxicity of carbamazepine or phenobarbital and theophylline, multi-dose activated charcoal is the best modality. And in case of body packers, undoubtedly whole bubble irrigation is the only modality that we can do, and here charcoal should be avoided. And in case of caustics and hydrocarbons, avoid all GI decontamination. So takeaways is activated charcoal, if given early, is most helpful, and the multi-dose activated charcoal is only for a small group of life-threatening drugs, and whole bubble
Next speaker, Dr. Vishwa Reddy, MD Emergency Medicine, SLP Apollo Medical College, Hyderabad.
dear senior colleagues, and my dear students. Today I am here to speak on behalf of intoxication, that is toxic alcohol intoxication, and emergency department approach, management, and key takeaways, and the current recommendations of the treatment part. So, toxic alcohols, whenever we use the word, what actually comes into our mind? Mainly, we hear about chronic alcoholic consumption, patients coming with alcohol withdrawal, but as such, acute intoxications, maybe in our Indian emergency setup, is not very common, but still, we do see cases which come with acute alcoholic intoxication. So, what are the common toxic alcohols we see? Anyone? Methanol, ethyl glycol, isopropyl alcohol, all these things. So mainly, what actually happens in this toxic alcohol ingestion and what we should be aware of is a thing which will be discussed in the beginning in the pathophysiology part. I mean the metabolism, where the enzymes which actually degradation of these toxic alcohols produce toxic metabolites. Subsequent to that, the accumulation of these toxic metabolites will make the patient land in severe metabolic acidosis, and there comes the concept of osmolar gap, and where the patient lands in acute toxicity, and subsequent to that, patient lands in the systemic complications. So firstly, as he has already told, methanol, ethylene glycol, and isopropyl alcohol are the most common toxic alcohols encountered. So, whenever we proceed with this approach to this, first I would like to make a case-based approach. A young male patient comes to the emergency department, says that the patient has taken some alcohol which he was using to clean his windshield wiper he was using, and subsequent to that, he had a toxic ingestion to that as a part of the. And subsequently, he landed in our emergency department. On presenting to the emergency department, his vitals were, his main complaints were patient was having, one patient was presented and he presents with respiratory distress, and he also says some GI irritation, and he has some visual discomfort, and that blurring of vision was there, that typical snowflakes appearance was there. So these things, this was one kind of presentation. Vitals were, respiratory alkalosis was there, and patient was having metabolic acidosis on point of care investigations, and ophthalmology referred showed hyperemia of the optics. So this was there. So what could be the possible urine toxicology screen was set, and subsequent to that awaited. And how do we need to approach this patient? This was one kind of presentation. And the other okay, so this was one kind of presentation. So here, whenever we remember a case who typically presents with respiratory alkalosis and subsequently presents with visual blindness, what is the common thing among the toxic alcohols, or the common thing among the poisonous substances, intoxicated substances? You remember? Anyone? Methyl alcohol. Okay. So this is the clinical clue which makes us to have a high index of suspicion of the alcohol, and that is methyl alcohol. So what actually causes toxicity of the methyl alcohol? In the methyl alcohol, and subsequent to that in the ethylene glycol, mainly alcohol dehydrogenase, and subsequent to that aldehyde dehydrogenase is the enzyme which metabolizes, and subsequently the metabolite formic acid, okay, and glycolic acid makes the accumulation of this toxic metabolites, creates a cellular oxidative stress, where there are oxidative stress induced, typical oxidative hypoxicus, a vicious circle will be encountered, and the patient will have a free radical oxidative metabolism will be there, and subsequent to that, patient will land in the toxicity accumulation, and these metabolites actually go to the brain, retina, and patient will have severe metabolic acidosis. This was one kind of presentation. And the other kind of presentation what I want to show you is so this was the one which I was telling. The second scenario is the patient presents with so this was the let us go ahead and check with this scenario. Now the patient had a hyperemic optic disc, and the metabolism which I was describing was about this accumulation of the toxic metabolites, which includes the formic acid and glycolic acid. Here we were discussing about the methanol toxicity. So what are the differentials we need to consider whenever we encounter a patient with such poisoning, and how we need to maintain this patient? So other differentials other than the methanol poisoning, what are the other differentials we need to consider whenever a patient presents with increased anion gap, metabolic acidosis or severe metabolic acidosis? Whenever we encounter a metabolic acidosis, we check for the anion gap, and we see that whether there is an increased anion gap, and subsequent to that we make the differentials considered. These are the few differentials we need to consider whenever we encounter, that is uremic acidosis, diabetic ketoacidosis, or we encounter other poisons like salicylates, theophylline, benzyl alcohol, all these things. As just now you were listening to some poisoning with salicylate poisoning, where the patient also will have respiratory alkalosis and patient will have metabolic acidosis. And after checking the anion gap, subsequently we need to go ahead and check the osmolarity. What is this osmolarity? What is actually is the osmolarity? Osmolarity is actually how a solvent, a substance, a liquid substance we have which quantifies the solutes. The amount of solutes present which contributes to the osmolarity of the solution at the deep, when it is deep. So there is a gap between measured osmolarity and estimated osmolarity. So whenever there exists a gap, why this gap exists? Because whenever there are some particles in the substance bind to each other, and subsequently that decreases the osmolarity of the substance, cations and anions. So this creates an osmolar gap. Whenever there exists an osmolar gap, subsequent to that, we should also have a high index of suspicion of few poisons. So this entire metabolism of toxic alcohols revolves around the surplus hypoxicus, which is the pathophysiology, and also elevated anion gap, metabolic acidosis, and also osmolar gap. So whenever there is an elevated osmolar gap, which we calculate normally with the formula of the osmolarity, which we will discuss in the next slide, we need to have a suspicion of these poisons, which include methanol, ethanol, ethylene glycol, mannitol, and isopropanol. All these things should be suspected. So how to calculate the osmolar gap? We use the common formula by which we calculate the osmolar gap, which includes the 2 into sodium by the normally which we use here, because in addition to the normal blood urea nitrogen and in addition to the normal creatine what we use, we also have ethyl alcohol, where we divide it by the formula and we calculate the osmolar gap, that is ethyl alcohol by 4.6. 2 into sodium by 1 by, and subsequent ethyl alcohol by 4.6 is the formula which we need to calculate the osmolar. Now approach to in the emergency department about the such patient. First thing what we use is normal emergency department stabilization, that is airway, breathing and circulation. Subsequent to that, and we need to check the detailed examination and send urine toxicology metabolites, metabolic panel should be screened. In some cases where we suspect intoxication and patient lands in coma, where the patient is having a comatose state, there we should also go for brain imaging, where because the toxic metabolites accumulation occurs in the basal ganglia, in the retina, and subsequently patient will have a necrosis in the brain. So there we should also go for brain imaging with CT and MRI. That should be done. Next part is the immediate point of care investigations. ABCD approach, point of care investigations. What is the next part we need to go to? That is accumulation of the toxic metabolites and what are the stages of the pathophysiology which is encountered in the methyl alcohol or ethanol poisoning. Whenever there we encounter a patient with ethanol poisoning, what I have told you, that is increased metabolic acidosis and also increased osmolar gap along with the presence of respiratory alkalosis and blindness, that is retinal toxicity is encountered. Whereas the other alcohols like ethyl alcohol, we see a phase where initially there will be involvement of central nervous, then cardiac, and then subsequently renal. All these were the stages. So if at all the patient progresses to a stage of comatose state and subsequently the patient is having severe metabolic acidosis and also there is involvement of the cardiac and renal, hemodialysis will be the next thing. There will be certain indications where if osmolar gap is, normal osmolar gap exists, which includes, now what is the normal osmolar gap? Any idea, anyone? Sorry? Minus 19. Less than 10. Okay, so when we will consider there exists an elevated osmolar gap, when do we consider it as a toxicity, alcohol toxicity? Whenever the osmolar gap is greater than 10, there exists some kind of indications where we need to consider acute poisoning and severe poisoning, where there will be indications for hemodialysis also. Whenever there is an elevated osmolar gap, along with the measurement of the toxin levels which are greater than 50 milligrams, then subsequent to that patient may land in the severe complications, systemic complications, and we may need to consider hemodialysis as the treatment of choice. If at all, this is what the pathophysiology which I am discussing about the ethyl alcohol. Elevated metabolic acidosis, elevated osmolar gap, always consider two poisons, that is methanol and ethylene glycol. Whereas if at all there is ketosis, but there is no severe osmolar gap is not elevated, then you go and suspect isopropyl alcohol, where this is the case, but similar manifestations of metabolic acidosis. And also there is an inverse relationship between metabolic acidosis and osmolar gap. Whenever you see in acute poisoning, patient will have severe, subsequent to the metabolism of the drug, after the initial half an hour or initial patient, the metabolic acidosis will be increasing. And whenever after the late stage, there also will be increase in the osmolar gap. Initially there will be a metabolic acidosis, but osmolar gap will be normal. But subsequently, when the osmolar gap is elevated, patient will land in chronic stage and systemic complications need to be encountered in the patient. Now, among all the poisons, how to differentiate and how to go and treat the patient among the three poisons, that is notorious poisons, which includes methanol, ethylene glycol and isopropyl alcohol. Approach to the management of the patient is being given in the algorithm. Phenol, the slide permits, will be an easy approach.
Recording in progress.
So this was what I was talking initially, that is airway breathing circulation and the correction of the acidosis, supplemental oxygen, and subsequent to that we need to set the following investigations, that is calculation of the anion gap and osmolar gap, checking for the renal functions. As I have told you, patient will land in uremic metabolic acidosis and also urine analysis, particularly for the ethylene glycol, where urine oxalate crystals will be present, and toxic alcohol screening levels. Okay, fine. Whenever we encounter a patient with the toxic intoxication with toxic alcohols, we always need to remember look for red flag signs of ocular toxicity, increased metabolic acidosis, as well as elevated osmolar gap. So these three things will make us, whenever if there is persistent respiratory alkalosis along with symptoms of ocular blindness, then think of methanol. Whereas when the patient is not having any signs of ocular blindness or involvement of the retinal, no blurring of vision, but patient is having elevated metabolic acidosis and increased osmolar gap, always think of the other two alcohols. So there is ethylene glycol. Whereas if there is an elevated metabolic acidosis but with ketonemia, acidosis with normal osmolar gap, mainly think of isopropyl alcohol. These are the key things to be considered. Now, what does the evidence say? So as per the existing literature, there are very few studies. One is Swarovski trial, which was done late in 2005, and also Lin et al. These two trials only support calculation of osmolar gap for the detection of the poisons, that is toxic alcohol, the diagnosis of toxic alcohol poisoning. These two trials were there. So as per the existing literature, they say that osmolar gap, although specific to know about the poisoning, there are many false positive and false negative results. I mean, there are also conditions where there is elevated osmolar gap, but the patient is not having substance intoxication with any of the toxic alcohols. This is one condition. So this excludes the specificity of osmolar gap in thinking about the toxic alcohol poisoning. Whereas few studies say that osmolar gap is as much specific in knowing about the intoxication of the toxic alcohol poisoning when compared to the toxin levels. Normally we calculate serum methanol levels or urine toxicology screen inside when the blood levels of the alcohols. Compared to that, osmolar gap is more specific in diagnosing the poisoning and differentiating the kind of poison with the toxic alcohol. So these were the two studies which support. One study support, and but we cannot exclude, and it is very not specific. The existing literature says that research should be undertaken to calculate how much is the osmolar gap specific in diagnosing the toxic alcohol poison. So these were the few studies which were undertaken. Apart from that, what I want to tell is, in the ED, whenever you encounter a patient with toxic alcohol poisoning, always remember to exclude the diagnosis and also treat the patient with the emergency management. Early management decreases the mortality and morbidity of the patient. We should not wait for the blood levels of the alcohols. Only symptomatic treatment, supportive treatment, emergency hemodialysis and stabilization of the patient as according to the osmolar gap and acidosis. Treating the acidosis is an important thing to be considered in the emergency department. So these are the few indications for the hemodialysis which are to be considered. That is osmolar gap greater than 10 milliosmolar as told, and considering the pH, serum bicarbonate and presence of urine oxalate crystals, especially in ethylene glycol poisoning. And adjunct therapies apart from the normal hemodialysis and normal antidote therapies which are to be considered are for methanol we need to give folinic acid as well as ethylene glycol, thiamine plus pyridox. So how much dosage should be given and how much should be continued for the patient. So this is a summary actually where we need to give to the patient. When always consider for methanol, ethylene glycol, we need to consider fomepizole to be given to the patient. If at all fomepizole is not available, subsequently we need to give ethanol. What actually this fomepizole it blocks the enzyme aldehyde dehydrogenase and subsequently prevents the accumulation of the toxic metabolites. So this is how the treatment should be continued by giving the antidotes. So these are the differentiating features where I have told ethanol, methanol, ethylene glycol and isopropyl alcohol. So these are the key diagnostic clues to be considered. As I have already told, visual blurring, headache and abdominal pain, ethanol should be suspected. CNS depression, cardiorespiratory failure and renal failure, ethylene glycol to be suspected. So this is the algorithmic approach which I want to be known to differentiate the toxic alcohol poisoning. Always consider early use of antidote, that is fomepizole, or if at all not available, ethanol, and always go for respect to early hemodialysis if at all there is indicated for the patient. So these were the two studies which I was telling, that is osmolar gap, arterial pH, anion gap and serum alcohol concentration to be evaluated. But it was found that following gastrointestinal decontamination has limited efficacy, and whereas early use of antidote, renal replacement therapy and correction of metabolic derangements is recommended, and thiamine and pyridoxine are also recommended as adjuncts to the treatment. So this was the study which I was telling. It has higher specificities, whereas osmolar gap has higher specificity and positive predictive value without very few, that is the sensitivity is increased and calculated as per the equation. So what are the main things, clinical points we need to consider is poisoning with all the toxic alcohol characteristically present with a great challenge to the emergency department. So always calculate osmolar gap and check for the metabolic acidosis. Early initiation of antidote, fomepizole or ethanol, and early initiation of hemodialysis would be the life-saving treatment for the patient. Maybe I thought if students are interactive, I would go for a quiz, but how much time is there or how much it is?
1 minute.
Okay, quickly.
We have a quiz at the end. Some questions are there of this. So if you want one or two questions.
2 questions you can ask.
So what is the antidote you consider and how much dose do you consider whenever you consider a patient with poisoning with methanol or whenever you consider poisoning with ethylene glycol? Antidote to be considered. What is the dose to be given? If at all fomepizole is not available, 50 mg per kg, subsequent to the 10 mg per kg is a start dose and subsequent to that dose. If at all a patient is having the stage of accumulation of calcium oxalate crystals in the urine, what is the strong suspicion of the toxic alcohol you have in your mind? Ethylene glycol. So 2 questions.
Thank you, madam.
Thank you.
May I request Dr. Mahendra Kumar sir to present the memento to Dr. Vishwa Reddy.
Thank you, ma'am, and thank you, Mahendra Kumar sir. Quickly, we'll move to the next topic. Next topic will be by Dr. Sharat Chandra Puluri, who did his MD emergency medicine from NIMS, and he has also achievement of procuring President's Gold Medal in DNB emergency medicine. He is right now consultant of emergency medicine in Yashoda Hospitals. Sir, may I now invite you for your topic. Sir will be speaking on toxidromes, which is very important for us in day-to-day life because most of the poisons are classified based on the toxidromes they show. So may I now invite you and take over the stage. Thank you.
Hello. It's there. Should I get my laptop? Hi. Good afternoon, everyone. I know technical glitches all the way. Let's hope it opens up, and my topic is going to be quite brief, quite specific. My aim is to make you understand why we need toxidromes in the first place. Why did somebody coin the fancy term? Why do we need them? Yeah? So, are they going to search it on Google? Oh, great. Alright. Okay, the layers are working and the slides are working. Fantastic. Let's start. Okay, first of all, thank you so much to the organizers for giving me this opportunity, and let's delve into the topic. Alright. We are going to be turning into detectives. Yes, that's the job of recognizing these toxidromes. Why? Yeah? So let's do that. Let's hook you up with this small case scenario. It's a 25-year-old man, right? Coming with in agitation, coming in agitation, he's sweating, pupils are wide, heart rates of 140, BP is 160/90. What's going on? You don't need to answer, don't worry. Just pause here for 10 seconds and then run it through your minds. I did not say he consumed something. He just has this presentation and he's not giving you any history. Okay? Just think about it. I'm going to pause for 5 more seconds. If you have some answers, fantastic. Let's decode this in the end, right? So, such patients, when they come first to you, throughout the entire day you've been hearing what to do first. Please take care of the ABCs first. Those take precedence always. After that, you have a small detective tools, you know. You need to have a tool to be Sherlock Holmes in the ear. Yes? So what are they? First, look at the mind. You can notice this as the patient is coming to you. Is he delirious? Is he shouting at you? Is he cursing you? Sometimes, I don't know, they may be even flirting with you. It happened to me once, okay? Because he was delirious and it's a he. It was embarrassing. But yeah, that can happen with the patient, right? And look at the face and eyes. Flushed, dry, cracked lips. And pupils are wide, blown out, opening, not opening. How's the skin? Again, sweaty, moist, clammy, flushed, cold, hot, whatever. Yes? And look at the vitals and some other conditions like, you know, some patients may have some tremors, they may be jittery, and they may have some rigidity. So all these things, these are your detective tools based on which you diagnose your toxidrome. Now, well, the name itself says, big surprise, huh? Toxidrome means toxic syndrome. There were two physicians, Dr. Moffinson and Dr. Greenstein. Sorry if I pronounced them wrong, but back in 1970s, they thought we could just coin a fancy term where a cohort of symptoms collectively present a syndrome. If it's because of a toxin, let's call it toxic syndrome, and combining together to call it toxidrome. Okay? Now, I'm going to re-emphasize here and say, if a patient has consumed a toxin and has come to you, you don't need to diagnose anything. You know it is because of a toxin. The whole purpose of knowing toxidromes is when you don't know the cause of those presentations. If you know that this could be because of a toxin also, not just the routine sepsis, MI, DCLD, liver failure, no. Have some, you know, if these are fitting into some toxidromes in the back of your head, you will also think, maybe he consumed something, maybe I'm missing something. If you do not know this, you won't think of it, you won't diagnose it. And then, Venkat sir clearly explained what happened to that young lady, right? They did not think of a toxidrome happening in that case. which is why the patient lost her life. Similar things can happen. So that's the whole purpose of knowing toxidromes, not just to know which toxin this belongs to, but to know that this could also be because of a toxin. A routine medical presentation can also be because of a toxin. Trust me, I have even seen trauma patients, trauma happening because of toxins. They drink, they consume something else with it, which I won't name now. They fall down, they come with head injury. What do you think? Outright. It's some head injury, some bleed in the brain. You do a CT scan, you find nothing. You think it's diffuse axonal injury. But please, upon delving into deeper history, it is found that the patient has consumed alcohol with some opioids. Yes? So this is where the importance of toxidrome anchors on. Alright, so quickly to understand, either it can affect your sympathetic system, pushing it into an overdrive state where you have a patient with hot, tachycardic, sweaty skin, and you may have a parasympathetic overdrive. The patient is like a sludge leaking from everywhere. That's what sludge means, right? And that's going to be mnemonic in further slides as well. And you have a CNS depressant. Could be anything again. So these are the three major circles of drugs or toxins where your toxidromes fit into. Now, if I have to classify it a little further, let's talk about suspect cards. Okay, I gave some fancy names. Between us, I took some help of ChatGPT as well. But content is mine, generation is ChatGPT's credit. Okay, so with that, first one I would like to call it a hyperactive thief. Thief comes, he would like to steal something. What happens when he wants to do something, or when you want to steal something? Maybe steal credit? I don't know. What do? You have the fight and flight response, don't you? Yes, so what happens with that? Your pupils are dilated, you want to see better, yes, and you have sweating, tachycardia, hypertension, agitation, hyperthermia, or you want to steal someone's heart, same thing happens, agreed or not? Yeah? So, the patient is hot, mad, red and wet. So this entire thing feeds into a fight and flight response, yes, so this is a sympathomimetic overdrive, or can I call it a toxin which pushes this sympathetic system into overdrive, is causing this syndrome. So this toxic syndrome is sympathomimetic toxidrome. So with this condition, you don't need to know which toxin exactly this is. And you know, at this point I have to say, you know how many toxins are there in the world? Any of you have any idea? Thousands? Thousands? Can I say at least thousands? And Venkat sir, you would agree with me, antidotes, how many toxins actually have antidotes? Maybe 30? Maybe 30 to 40? Yes? How many do you know? I barely know 20 toxins which actually have antidotes, whereas the poisons are thousands. So, the concept of toxidrome is so that when they have these constellation of symptoms, you know what to do immediately. So, ABCs are always first, and then you do. My first line is going to be supportive management in every thing, okay? Of course, and because cooling, and most of the agitated patients because of toxins, benzodiazepines, okay? They are your miracle drugs for all agitated toxic patients, okay? Agitated toxic patients, right? So, these are the simple supportive managements that you can do for a sympathetic toxidrome. Now comes our favorite mnemonic, which I don't seem to understand even till now. So, I'm gonna call him Mad Hatter. You know, people say mad as a hatter. I didn't know why hatters were mad. I was surprised until my final year when I actually found out that back in the late 19th century, hatters were using mercury to felt the hats, to make the hats, in simpler words. And they were inhaling the fumes, which kind of made them delirious and mad. So, which is why that idiom of mad as a hatter came into existence, right? So, what are our pearls? This mnemonic is that it's as old as time, right? Hot as a hair. I never understood why hairs are hot. Okay, red as a beet makes sense, blind as a bat makes sense, dry as a bone. Really? They couldn't come up with a better analogy for dry. My presentation probably is drier than a bone. Yeah, but still, so to remember this, I had to create another mnemonic, which is why personally I don't like this mnemonic that much, but there are fans of this mnemonic, which is why I had to satisfy them. Okay, but please remember the physiology behind it. It is an anticholinergic overdrive. Yes, so what happens? You will have all the sympathomimetic syndromes except, any idea? Dry as a bone. The patients don't sweat. That's your differentiating feature from sympathomimetic toxidrome. Yes? And again, the treatment is supportive care, like I said, and you have an antidote. You can use physostigmine, which is a cholinesterase inhibitor, and again, check for cardiac conduction abnormalities before you give physostigmine because it can interfere with conduction of the heart, right? And again, because the patient is agitated, benzos done. Alright. My favorite, the sludge monster. Okay, so this is a typical cholinergic toxidrome. Come on, shout out one cholinergic toxin. Thank you. Organophosphates, yes. So there are many others as well, but most common, our favorite thing right from MBBS is organophosphates. Yes. So we all know this mnemonic. It is SLUDGE. I missed the D here. I'm sorry. D stands for diarrhea, but the rest you can read out, right? So for this, how do you treat? In this, because the patient is leaking everywhere, airway takes precedence over any other supportive management. I had to mention it separately here. Yes? And atropine and pralidoxime are the antidotes. Pralidoxime, there are some, conflicting evidences for carbamates and all, but still no harm in giving a single dose. Yes? And after that, supportive management. But there is a caveat to this sludge monster. These may not immediately kill you. You know what kills in cholinergic toxidromes? Any idea? These. Yes, the killer bees, which are bradycardia, bronchoria and bronchospasm. Well, the treatment remains the same. Give atropine and pralidoxime while simultaneously taking care of the airway. Yeah, but you have to remember these. Alright. So this is about a cholinergic toxidrome. Right? Next comes. Yeah, nowadays it's on the rise, right? With more cancer patients surviving longer, and I don't want to say this, but more exploring happening around, more fancy drugs coming out with really fancy names. Okay, the street names you should hear, they will really surprise you. So all these opioids, they depress your CNS. Yes, no surprise there. So this causes CNS depression, and the classical feature, as we all remember, is pet point pupils. And respiratory depression is most pronounced in opioid overdose. Unlike in other CNS depressants, I repeat, unlike in other CNS depressants, opioid toxins can cause the most respiratory depression, which is why you'll have a patient probably having the rate of 876 also, which is why antidote for opioids is included even in the BLS. Yes, they recognize that this is quite common, at least in Western countries. It's becoming, we are catching up. Not something to be proud of, but we are. Okay. And finally, coma. So other pearls again, airway takes precedence here. Naloxone is the antidote of choice, especially in emergency medicine. We don't go beyond naloxone using naltrexone, there are some fancy other names. Okay, we commonly use naloxone. And one thing you need to understand here is the patient may need multiple doses. Okay, we actually had a case when I was a resident in NIMS. A case was under general medicine. It was an elderly female. They did not have a proper history. No cause for artery sensory was found out. Pupils were like 2 mm, not reacting. All investigations were done, normal. We just wanted to try, let's give 1 dose of naloxone. Did not work. 2 doses, did not work. 3 doses, did not work. I had to send them out to get more naloxones also. Finally, after giving about 10 milligrams of naloxone, the patient began showing response. Later, when we became true detectives and used our colleagues from general medicine, we found out that the patient had a husband who was a cancer patient. And he was on morphine. And she got vexed with him, dealing with cancer patients, no judgments there. And then she took those tablets to take her life. Okay? So my point here is the patient may need multiple doses because the potency varies. With 1 dose, the patient may not show response. The patient may need repetitive doses. So book says give at least 15 milligrams, and if it is that the patient is still not responding, then probably rule out an opioid toxicity. I hope that's clear. Yes. Double dose effect or something. So the patients again have CNS depression. Like I said, they are not completely knocked out, so they have slurred speech, especially in alcoholics who probably have an underlying Wernicke's also, right? And they have ataxia, and most of them have normal vital signs unless it is a severe toxicity where true respiratory depression happens. Okay, so treatment for them, supportive care. You don't further give benzodiazepines to them, and flumazenil is the antidote. And again, flumazenil rarely used. Only if it is a severe toxicity, flumazenil is advised because it has its own side effects happening to it. So if it is a severe toxicity where airway is compromised, then you go ahead and give flumazenil. So conventionally, these were the toxidromes. These were the 5 toxidromes, starting with sympathomimetic, anticholinergic, cholinergic, opioid, and sedative hypnotics. But recently, Gen Z, they take it so much that most of them are either getting diagnosed with depression or they are going into depression. So many things are around the world. So what's happening? People are put on citalopram, escitalopram, or some non-triptyline antidepressants. Most of them have SSRIs. So overdose of that or a staggered dose, like sir was telling, patients can land up with something called serotonin syndrome. For those of you who don't know, let me surprise you. Do we use cough syrups normally? Do we prescribe them? Does it have a component called dextromethorphan? That can cause serotonin syndrome with hypotension. Any of you have any idea an antibiotic which can cause serotonin syndrome? Use it for linezolid. Fantastic. Yes. A common painkiller that we use left and right. Tramadol. It has a very high potency for serotonin syndrome. A common antiemetic that we use. Metoclopramide, fantastic. All these drugs do precipitate serotonin syndrome, and trust me, even fentanyl can cause serotonin syndrome. If you are giving a pre-medication for intubation, patient is landing with high blood pressures, tachycardia, hyperthermia, please do think of serotonin syndrome also. Okay? And neuroleptic malignant syndrome, it's a co-brother of serotonin syndrome. The differentiating feature is serotonin syndrome is jittery. They have myoclonus. Okay? But whereas neuroleptic malignant syndrome, which commonly happens because of antipsychotics, they have high dopamine state, right? So they go into a kind of rigidity, not myoclonus. That's the differentiating feature between serotonin syndrome and NMS, right? Treatment again, supportive care, agitation, toxins, benzos, hyperthermia, so cool them, and cyproheptadine plus minus. Okay, you cannot. Alright, so these are some tables, don't worry, I'm not going to run through these tables. These are going to be given as handouts, so take it directly from Goldfrank's Toxicology. So find them, it's a beautiful table, which drugs affect what, all the vitals have been clearly, beautifully elaborated there, which drugs affect what kind of vital signs. And this entirely summarizes my presentation, which drug causes which vital sign deficit, which toxidrome causes, including withdrawals. Again, not going into details because we have dealt with them in detail. Okay? So, I'm going to just take 2 minutes, quick answers. 10 seconds, come on. What do you think? Sympathomimetic? Agreed? Fantastic. Fantastic. How did you come to that, sir? Yes, hyperthermia. Very good. Hypotension. That was the clue. Okay. Hypotension. See, trust me, not all patients, there is a significant overlap. You know I'm talking about toxidrome. But why can't it be sepsis? Why can't it be sepsis? This is the purpose of having toxidromes in the back of your mind. Think of sepsis, yes. At the same time, delve into history. So you'll find the culprit agent. Oh, come on. Thank you so much. Yeah. Just for finishing sake. Anticholinergic. What was the clue here? Yes. Hot as my presentation. Okay. With that, these are my references. You can scan them, and I thank you so much.
Thank you, Dr. Chandra. Normally, it's very difficult to remember these toxidromes. I have tried very much, but always I keep forgetting. Thank you for putting them in a flashcard basis, so it will be easy for us to pick up and memorize. Any questions? Yeah, if there are no questions, quickly we'll move on to the next section.
I request Dr. Krishna Suman sir to present memento to Dr. Sharat Chandra sir.
Thank you, sir. Next topic by Dr. Murukonda Vinod Babu, MD DM Nephrology, MD from Jipman, PM from CMC Vellore. This topic is early renal replacement therapy, toxicology, indications, innovations and impact. He is son of the soil from Khammam.
Good evening, good afternoon everyone. Today we will discuss about the role of renal replacement therapy in toxicology. Here, where minutes matter more than milli equivalents. First of all, why renal replacement therapy matters in toxicology? Because most of the poisons or toxins are dialyzable, at the same time they are time sensitive. So if you do the early renal replacement therapy, it will prevent the organ failure, eventually it improves the survival. And in fact, most of the toxins, the severity continues, even the serum levels decreases. And serum levels may but tissue levels won't. And that is a thing. And before a patient presents to you with any poison, you need to see whether the first poison is dialyzable or not. To see whether the poison is dialyzable or not, you need to see mainly 4 things. That is a slip criteria. That means S is the molecular weight of the poison or size of the poison. If the size of the poison is less than 500 Dalton, that is a small size poison, mostly removed by the hemodialysis. Hemodialysis removes the small size poisons. And second thing, L. L is low protein binding. If the poison is or toxin is high protein binding, it will be difficult to remove by dialysis. Dialysis will remove only low protein binding poisons. And third thing is I, that is volume of intravascular distribution or volume of distribution. If the poison has high volume of distribution, it will distribute rapidly into the tissues. So it will be difficult to remove by dialysis. So if the same poison has low volume of distribution, then it's easier to remove the toxin because most of the poison is situated in the intravascular space. And fourth thing, P is polar or water soluble. If the poison is water soluble, then most of the poison lies within the intravascular space. It's easier to remove by dialysis. If it is not lipid soluble, it will be redistributed into the tissues. It's difficult to remove by dialysis. So if a patient comes with you then you need to see whether the toxin or poison is dialyzable or not by simple these 4 things, whether the size, protein binding, volume of distribution, water soluble or not. And here you can see the same thing, slip criteria. And most of the poisons are small molecular weight with low protein binding. That means you can remove by dialysis. If the same poison or toxin is high protein binding and has high molecular weight, large molecular weight, then it's difficult to remove by dialysis. Then you need to consider other options like either high cutoff dialyzers or hemoperfusion. That is where poison or toxin is removed by hemoadsorption, where resins or charcoal is used to remove the toxin. Here if you see methanol, which are there on the right hand side, like methanol, ethylene glycol, lithium, salicylate and theophylline has small molecular weight along with low protein binding. That means we can remove easily with dialysis. while Paraquat and carbamazepine has high protein binding and large molecular weight. The further you need adsorption techniques like hemoperfusion to remove the toxin. Yeah, we all know what are the general indications for dialysis and any poison. We all know there's a regular renal indications like refractory metabolic acidosis, refractory hyperkalemia, though fluid overload, which may not be seen in toxicology cases, and other conditions like other indications are like CNS toxicity or cardiovascular instability. These situations are there because of the poison. Then we need to consider renal replacement therapy in this any poison, any toxin use. Yeah, we'll discuss about a clinical scenario here. It's a 32-year-old gay male. He presented to you around 10 hours later after taking a illicit liquor. He complains of blurred vision and nausea, and vitals at presentation was stable. Even ABG at presentation also showing pH of 7.27 with a bicarb of 70. He is drowsy but arousable. In this, like he has come to you and you are in the emergency room. What do you want to do? Whether you want to give only fomepizole or along with fomepizole you want to go for urgent dialysis. For all the PGs here, what's your option? Like what do you want to go? Only fomepizole or along with you want to go for dialysis also? A or B? For A, who want to go for A? For B? Yeah. Why do you want to go for dialysis also? Yeah, there is a blurring of vision is there. Why here blurring of vision is there? Methanol is converted into formic acid. This formic acid will go and deposit in the optic nerve, which causes optic nerve mitochondrial dysfunction and causes blurring of vision. If you give fomepizole alone, it will just inhibit the alcohol dehydrogenase. That means it will prevent the further conversion of methanol to formic acid. It will not remove the formic acid that has already present in the body. So, if you do the dialysis, it will remove both methanol and formic acid. That's why in these patients you have to go for, along with fomepizole, you need to go for dialysis also. Because this fomepizole just by the time, while dialysis will save the vision also. Whenever a patient with methanol poisoning comes to you, if there is a blurring of vision or if there is a metabolic acidosis pH 7.25, then you need to go for dialysis as early as possible. Yeah, this is the same thing we have discussed. We will discuss what are the other indications for dialysis in methanol poisoning. As we have already discussed, pH 7.25 with blurring of vision, and at the same time, if the methanol level is more than 50 mg per deciliter, if there is a organ toxicity is there despite fomepizole. The best modality is hemodialysis. Intermittent hemodialysis is nothing but same as a regular hemodialysis that we are using regularly. So, because why we have to go for regular hemodialysis, it has the highest clearance. And how these pattern of type of dialysis we'll discuss later. If patient comes to you with ethanol poison, like ethylene glycol poisoning, you need to go for dialysis. If there is acidosis is there less than 7.25 with the renal failure because of the calcium oxalate crystals you can see here in these oxalic acid will go and deposit in the kidneys and form the calcium oxalate crystals, and if there is osmolar gap, as our previous speaker has already discussed, if the osmolar gap is more than 20 at presentation, then we need to consider dialysis. And if the serum ethylene glycol level is more than 50 mg per deciliter, hemodialysis is preferred. We'll discuss about one more clinical scenario. She is a 55-year-old female who is on chronic lithium therapy for bipolar disorder. She presents to you with vomiting, tremor and confusion. Her lithium level at presentation is 3.8 milliequivalents per liter with some renal dysfunction of creat 2 is there. And you have started her on dialysis in view of high lithium levels. Post dialysis, you have checked the lithium level and the lithium level is 1.2 milliequivalents per liter. And clinically she is fine, like all this whatever tremors, confusion, all the things has improved. So what is your plan of action right now? Whether you want to, she is stable, you want to shift her to the room from ICU, or you want to do the repeat lithium levels and you want to continue close monitor, or you want to repeat the dialysis immediately? A or B? B. Why? because lithium is one poison where, especially in patients who are on chronic lithium treatment, the lithium is stored in the tissues. So if you do the dialysis will remove only the plasma lithium. After that, around 4 to 6 hours later, the lithium from the tissues will leak back into the blood, and again lithium will increase in the blood. Then again, after 6 hours after the dialysis, again patients may have these symptoms like confusion, seizures, all these things can have. That's why you need to send the serum lithium levels not after dialysis. You need to send the serum lithium levels around 6 hours after the dialysis. Based on that, you need to take the decision regarding the dialysis. In fact, lithium is not a one dialysis toxin. Always you need to expect the rebound in these patients. You need to plan for repeat hemodialysis. Around 2 to 3 sessions of hemodialysis is needed in these patients who are on chronic lithium therapy. Yeah, this we have already discussed. Yeah, especially this thing is seen especially who are on chronic users for the psychiatric disorders. We need to go for renal displacement therapy. We have already discussed. If the lithium level is more than 4 milliequivalent per liter with renal dysfunction, if the lithium level is more than 5 milliequivalents per liter with normal kidneys, normal renal function, also we need to go for renal replacement therapy. If there is a neurotoxicity in the form of severe confusion, seizures are there, also you need to consider renal replacement therapy. Obviously, the preferable one is internal hemodialysis only, but you need to consider rebound phenomenon in these patients. Yeah, then we'll discuss about 2 to 3 other poisons and when we need to go for dialysis, especially salicylate poisons, patients who are taking like for pain, like aspirin, who are taking it over the counter. Then if the patient, those patients presents to you, then you need to consider renal replacement therapy. If the salicylate level is more than 100 milligrams per deciliter, or if there is a CNS involvement in the form of altered mental status, or if there is a severe metabolic acidosis or renal insufficiency is there, or pulmonary edema is there, you need to consider. And obviously, the previous speakers already they must have discussed about the characteristic ABG abnormality in these patients, like respiratory alkalosis with the combined metabolic acidosis. The preferred modality is hemodialysis. And theophylline toxicity is mostly taken by especially who are on for chronic lung disease, either for asthma, COPD. Most of the patients who are on theophylline as part of bronchodilator therapy, they'll come up with you with theophylline toxicity. You need to consider renal replacement therapy in these patients if the level is more than 100 micrograms per ml. And especially this theophylline can cause cardiac toxicity, especially if they have life-threatening arrhythmias then you need to consider. And if there are refractory seizures, hypotension is there also, then you need to consider renal replacement therapy in this patient. Obviously, here also hemodialysis is preferable because we have already discussed all these toxins are small molecular, small size molecules with low protein binding. Most of the patients who are on anti-seizure, part of anti-seizure medications, if they come with valproate overdose, then you need to consider renal replacement therapy. If the level is, according to latest guidelines, if the level is more than 1300 milligrams per liter, then you need to consider renal replacement therapy. In these patients, valproate causes toxicity mainly by it causes inhibition of the urea cycle, which leads to the increased ammonia level. That's why it will cause hyperammonemia. At the same time, it causes mitochondrial dysfunction, which leads to the cerebral edema. And this hyperammonemia also will cause cerebral edema. And at the same time, this valproate will cause a decrease in systemic vascular resistance, leads to refractory shock. So in all these things, these are all can develop because of valproate overdose. Especially in valproate overdose, you need to consider continuous renal replacement therapy rather than hemodialysis. So far we have discussed all poisons, we want to go for hemodialysis. Here we want to go for CRRT because either here or hyperammonemia because of acute liver failure. If CRRT is there, it's preferable when compared to hemodialysis because we don't want ammonia to come down too fast because if you are removing, because hemodialysis will remove the ammonia or solutes very rapidly. So plasma solute load will come rapidly while brain solute load is still on higher side. So there is a osmotic gradient between the plasma and brain. which will causes movement of the solvent, that is water, from the intravascular to space to the brain cells. It leads to the swelling of the brain cells, leads to worsening of the cerebral edema. That is nothing but dialysis disequilibrium syndrome, which we will see after intermittent hemodialysis. That is why in patients with valproate toxicity where hyperammonemia is seen, or in any acute liver failure where hyperammonemia is there, we need to remove the toxins very slowly so that we can prevent the osmotic gradient between the plasma and brain, so that this cerebral edema, we can prevent the worsening of the cerebral edema, and we can prevent the development of seizures. That is why when any hyperammonemia or valproate toxicity, CRRT is preferable, that too with very low blood flow to prevent the intracranial pressure shifts. Whenever like in 2 times cities, CRRT may not be available everywhere. In these cases, you can try hybrid model, that is hybrid model between hemodialysis and CRRT. What is that? We are doing what is that? SLAD or extended daily dialysis. That's nothing but slow, low efficiency dialysis that we'll do for 6 to 12 hours. That is a medium variant between hemodialysis and CRRT. Yeah, this is a final clinical scenario. He is a 30-year-old farmer. He presents around 2 hours after ingesting Paraquat around 30 ml. He presented with nausea and vomiting. Vitals are normal, even presentation ABC also normal. What is the best immediate extracorporeal strategy? We are all doing this, hemoperfusion. Why hemoperfusion? Because like Paraquat, what will happen is within minutes to hours, the Paraquat that is there in the blood will be sequestrated into the lung. Whatever extracorporeal therapy you are doing will not remove the Paraquat from the lung. It will remove only from the intravascular space. And from in between the hemodialysis and hemoperfusion, hemodialysis removes the poison by diffusion. The rate of removal is very low when compared to hemoperfusion, where it removes the poison by adsorption. So it removes the Paraquat at a rapid rate when compared to hemodialysis. That is why we need to choose hemoperfusion when compared to hemodialysis. So early hemoperfusion works. That too within 4 to 6 hours after ingestion, and once the Paraquat is sequestrated in the lung, it may not be useful because this sequestrated Paraquat will cause free radical activation and superoxide mediated lung injury, causing the respiratory failure. So that's why we need to initiate hemoperfusion as early as possible to prevent the deposition in the lung tissues. For protein-bound toxins like carbamazepine and rapidly sequestrating toxins like Paraquat, hemoperfusion is the ideal treatment. Yeah, so far we have discussed some 7 to 8 poisons, and we have discussed hemodialysis for few poisons and CRRT for few poisons. When CRRT is not available, so that we have discussed, and at the end we have discussed the hemoperfusion. So this is a where types of renal replacement therapies we have discussed. There is intermittent hemodialysis is nothing but regular hemodialysis we are using. Then second one is CRRT. If it is not available, we are using the hybrid variant, that is SLAD or extended daily dialysis. And if it is a toxin is highly protein bound, or if we need rapid removal, we are using hemoperfusion. What is the pros and cons of each variety? We'll see here. Regular hemodialysis, it removes the toxins at a very rapid rate. So we can remove the toxin at a very rapid rate, and we can prevent the organ damage. So it's most of the times the patient is stable, regular hemodialysis is preferable. But the limitations, we cannot use in patients with hemodynamic instability, because in regular hemodialysis, we need to put the blood flow rate around some 300 to 400 ml. That means at any time 300 ml of blood is outside the body. If patient is already hemodynamically unstable, it will further worsen the hemodynamic instability. That's why we cannot do in hemodynamically unstable patients. In those patients, you can try CRRT. In CRRT, the blood flow, you can do the dialysis even with the 30 to 40 ml of blood flow rate. That means at any point of time, only 30 ml of blood is outside the body. It will prevent further worsening of the hemodynamic instability. That's why whenever patient is hemodynamically unstable, go for CRRT. If hemodynamically stable, then regular hemodialysis is preferable. And CRRT we have already discussed, and it is useful for hemodynamically unstable patients, and if there is a cerebral edema. It will prevent the worsening of the underlying cerebral edema. While cerebral edema worsening can be seen with irregular hemodialysis because of dialysis disequilibrium syndrome, and especially it is useful in ammonium, hyperammonemia or valproate poisonings. The limitations is the rate of removal of toxin is very slow. That means 4 hours of hemodialysis equal to nearly 24 hours of CRRT with respect to toxin removal. Yeah, hemoperfusion mainly for protein-bound toxins like carbamazepine, theophylline, and paraquat, where we need to remove the toxin very early by hemoabsorption. And yeah, pros are it removes the toxin very rapidly. Cons are there's a side effects like thrombocytopenia are seen. Sometimes cartridge saturation is seen. That's why you need to repeat you need to go for one more cartridge even after 4 hours. Yeah. What are the newer things which are coming for the past 2 to 3 years? We are saying for toxin removal, higher cutoff membranes are coming. Like in dialysis, in these higher cutoff membranes, the pore size is around 2 to 3 times higher than the regular hemodialysis pore size. That means we can remove even mid-sized toxins also. In hemodialysis, we can remove only small-sized toxins. By using these high cutoff membranes, we can remove even mid-sized toxins also, like myoglobin, light chain, others, sometimes cytokines, all these things. And second thing is, we already discussed extended daily dialysis or slow low efficiency dialysis, which is a hybrid variant between regular dialysis and CRRT. And third thing is newer adsorptive variants like auxiliaries, cytosorbalkani. Cytosol mainly removes the cytokines, so which is mainly used in cytokine storm, while auxiliaries will remove along with cytokines, it will remove the endotoxins also. And newer things are point of care toxin level predictive rules. We are for us to detect the toxin level, it's taking too much time. If newer point of care toxin levels are coming, it will be easier for us to take the decision. And one more thing is AI assisted extracorporeal therapy decision algorithms. With these algorithms, you can input the patient age, what is the amount of toxin he has taken, what is the vitals, and you can put the basic ABG and renal parameters. Based on that, it will give you whether hemodialysis or renal replacement therapy is needed or not. If it is needed, what type of RRT we need to consider, and whether is there any chance of rebound is there or not. When we need to consider stopping, all these things we can come to know with these AI assisted models. These are all coming up in for the past 1 to 2 years. At the end, I like to what modality, how to choose the right modality. Whenever a patient comes with poisoning, just by slip criteria, find out whether the poison is dialyzable or not. If it is dialyzable, then just assess the clinical severity based on acidosis, whether cardiovascular instability is there or not, or CNS depression is there or not. If clinical indication is there, then you need to choose the modality. Which one to go? If patient is hemodynamically stable, go for dialysis. Unstable, go for CRRT. Or if cerebral edema is there, go for CRRT. If you don't have facility, go for hybrid variant, that is SLAD. If the poison is protein bound, then you need to go for hemoperfusion. If you are expecting any cytokine storm, then you can consider auxiliaries or cytosol. And if you are expecting rebound, then you need to consider for repeat sessions. It is the modality you need to follow in any toxin. Yeah, it's the same thing. Yeah, and this my end slide. Whenever a patient comes to just see this by slip criteria whether it's a dialyzable or not. HD is always king for classical dialyzable toxins. CRRT for brain and ammonia, brain in ammonia and BPA, valproic acid. Hemoperfusion is for protein-bound toxins. Auxiliaries and cytosol are for cytokine storm. Yeah, dialysis is not to treat the dialysis does not treat poisoning. It buys time for organs to survive the poison. Yeah, thank you. Yeah, any doubts? I'm happy to answer.
Thank you, sir, for highlighting the importance of nephrology and dialysis in toxicology. So both together can bring miracles in patients' life, especially in treating Paraquat poison, which will Dr. Ranjit will be dealing next. Any doubts? Any questions? Thank you, sir. I request Dr. Chandrasekhar sir to present a memento to Dr. Vinod.
Sir, sir.
Thank you, Chandrasekhar sir, and thank you, Dr. Vinod. So quickly we'll move to the next topic. It's my pleasure to invite the next speaker, Dr. Ranjit. He is my colleague and go-to person in treating difficult poison cases in Khammam. He also recently completed his Toxicology fellowship from Mamata, so he is the best person to discuss the next topic, that is Paraquat poisons.
Yeah. Hi, good evening everyone. I think we reached to the end of the conference. There is glucotoxicity and lots of toxicology going on, dumping in your brain. I guess Paraquats is something, there's nothing to discuss much in Paraquat, but it is very important to talk about Paraquat because any person who is consuming a little amount of Paraquat and comes to our hospital in the early hours, there is some treatment which is available which can help save the patients. I think they got the wrong slide there. Anyway, go through the PowerPoint. I think it's downloaded. Anyway, first I would like to introduce Satyanarayana sir, who is sitting there. So sir has started a group called as Doctors Against Paraquat. He has gone to the Home Minister level, to JP Nadda and everyone to ban the Paraquat. He has even framed some laws that Paraquat has to be banned in the country. And I should thank sir for doing all these things because Paraquat is such a compound which needs to ban as soon as possible, sir, and I thank you for the work, sir. So, first, why the Paraquat is so deadly? Because the Paraquat which is available right now is 24% SL. When I say 24% SL, it is almost 24 grams in 1 liter. I mean, why is it so hard to ban this product? It's because there are lots of farmers in India. You know, our country is mainly dependent on the farmers, right? If the farmers doesn't have any work, I mean, if there are no people to work, they need this herbicide to be sprayed on the grass or to kill the pesticide. So it is very difficult to ban a product which is very helpful to the farmers. But only minuscule amount of people who are consuming it. Let's say the farmer's son or a farmer's daughter in that emotional situation, they do consume a little bit thinking that it will not harm them. Sir, I just drank a cap of it, that's it, nothing will happen to me. Of course, in this one, if you drink more than 20 ml and if your presentation is more than 6 hours, definitely there is a risk, right? So, I mean, I have almost 42 slides, I think we can't go through all of them, and our brain can hold till 5 minutes, I guess. More than that, I don't think so we can, hold any information. So, straight away, as I have mentioned, 50% of the mortality happens. It is banned in most of the educated countries. This was discovered in Europe, if I am not wrong, in the UK. And they have banned it. But in India and developing countries such as Bangladesh, Nepal, African nations, it's still going on, right? Even there are some studies showing that if the Paraquat is mixed in the soil, it might cause Parkinson's disease in the later part of life. Yeah, as I mentioned, Paraquat dichloride, it is absorbed fast. It's very fast. If the person has consumed Paraquat, within 2 hours, there's a rapid J absorption and it will get transported to the lungs, and in lungs, the alveolar cells are damaged, and that's it. If the lung is involved, faster, we will lose the patient. As I mentioned, each bottle contains 24 grams. Of course, the names are also so attractive. When the patient brings, when the patient comes, they tell, sir, he drank knockout. Of course, he will be knocked out, right? Then Paraquat, ruler, ozone, undertaker, and king of all is gramoxone. My God, if the patient comes to you saying that he has consumed 10 ml of gramoxone, they are the leaders. Syngenta, pesticide manufacturer Syngenta are the leaders in Paraquat. They have the strongest component of Paraquat with them. After discussing with the government or something, I think they made the molecule much easier. Before, they used to dip the grapes and keep it so that they can kill their spouses or something like that. Now they made it pungent and easily they can emit it out once they consume and there's a burning sensation there. So I think it is better than in that way. Why is it so toxic? It's because of two things, right? One is generation of superoxide anion and the second is oxidation of cellular NADPH. When they say this subject, I do, it's very difficult to discuss more of pathophysiology in poisonings, right? I'll be discussing 4 mechanisms. One is redox cycling, second is lung selectivity, the other organs which are getting damaged, and what are the new insights in this era, right? So coming to redox recycling, I think as Sir has used ChatGPT, I also used some ChatGPT and Gamma AI. With that, I prepared this diagram. I think that diagram is clearly explaining that when Paraquat is reduced by, Paraquat is reduced by NADPH to Paraquat radical, okay? Then this formation of Paraquat radical, this Paraquat radical is then oxidized by molecular oxygen to form superoxide. Then this superoxide is then with superoxide dismutase forms hydrogen peroxide, finally hydroxyl radicals. All this going cycling process and create a cascade causing lipid peroxidation, DNA fragmentation and mitochondrial damage. So every time, even though this slide is boring, I feel like explaining every time because I don't know, tomorrow someone of this conference can come out with some experimental therapy which can cure Paraquat poisoning. So we need to understand this to manage Paraquat poisoning in the first place. So again, if the person comes to you and his lungs are already damaged, there's nothing, there's no going back, right? So initial part is acute alveolitis, further leading to respiratory distress, then impaired oxygen exchange, finally fibrosis. So these are the changes. Phase 1, early inflammatory, then fibroproliferative, last is late fibrotic. Once the fibrosis sets in, there is no way going back. And as Vinod sir has covered extensively about kidneys, first thing which gets affected is kidneys, right? And the only thing that you can do in kidneys is hemoperfusion. What happens is tubular necrosis and glomerular damage. These are the new therapies which are coming up in Paraquat extensively, antifibrotic therapies, peroxidase inhibitors and mesenchymal stem cell therapy. I don't know whether you guys know it or not. There are some researches going on in India itself regarding mesenchymal stem cell therapy in Paraquat poisoning. I think I have heard from one of the doctors saying that he is doing wonders with this. But again, still the data has to come out regarding mesenchymal stem cell therapy, how well it is helpful. And we ourselves at the institute also have done some study on Paraquat, taking few patients and seeing how fast are the patient deteriorating and what is going on there. Before that, we should understand swallowing more than 30 ml of 20 to 24% of Paraquat concentrate is usually lethal. What are the presentations? Usually these presentation complaints, if it is mild, it is asymptomatic. Most of the times they are asymptomatic, people doesn't know what is happening with the patient. Finally, they'll come back after the complications to us. But if they tell us before itself that they are having some other symptoms, then it is easy to diagnose. But these patients who have consumed very less amount, it is difficult to diagnose. Moderate amount, again they can present faster. They have vomiting, diarrhea, abdominal pain and all those things. And if it is more than 40 mg per kg body weight, they will land up in hypotension and cardiac arrest. I think we have seen this Paraquat tongue. These are our patients. These are the Paraquat tongues. When they show this, when we don't know what is the poisoning, and when they show this kind of tongue after 3 to 4 days, this occurs after 3 to 4 days, we understand, yes, of course he has consumed Paraquat. Or it doesn't matter what the patient says, but if you see this kind of tongue, we should always suspect Paraquat poisoning. So yeah, other symptoms would be confusion, coughing, persistent vomiting, abdominal pain, excess saliva. If you have been at the side of a Paraquat consumption patient, there will be excess saliva which is coming out of his mouth, drooling all the time, trying to spit out what is going on, right? There might be increased sweating, diarrhea and weakness. All these GI symptoms are because of adulterating the product, right? They have altered the product so that the patient will recognize it in the early phase itself that they have consumed it. And My God, if the patient is coming with this symptom, sir, I'm having burning sensation all over the body, refer the patient immediately. Where? To the higher center or to the person who you don't like, right? Because he'll 100% have a risk of death, right? If the patient is presenting with burning sensation to your casualty, and if you are the EM physician, say finish, the game is over. It doesn't matter what you do. You do hemoperfusion, you do whatever is necessary, the game is over, right? The risk of death is almost 100% if the presentation is with burning sensation all over the body. So what are the things you need to inspect in this kind of patients? Of course, as I said, first inspect the oral cavity, mouth and pharynx, assess the dehydration level, monitor respiratory rate and pulse oximeter, because it is very important that you don't start oxygen in few patients. One of it is Paraquat. If you start oxygen in these patients, it will cause much harm than benefit, right? Because of generation of reactive oxygenation species. Next, again, it's important to monitor cardiovascular monitoring and respiratory monitoring, because if the patient has ECG changes in the earlier phase of presentation, that means he has consumed higher levels. Again, there is high risk of mortality. These are all clinical signs. Whether we can do some tests to find out? Yes. We can also do kidney assessment, kidney function assessment, and find out, right? How? If the rate of increase of creatinine is more than 1 milligram per deciliter every day, again, the consumption is very high. This is the research done, which has shown that if the rate is increases more than, when you calculate this, I think you'll get to more than 1.1 milligram per deciliter. If it is more than that in one day, it is increased with associated with increased risk of death. Again, lactic acid levels also can be helpful. This is one thing I wanted to discuss, that is urine Paraquat levels. If we do at our center, we do urine Paraquat levels. We use these sachets. I mean, it's not exactly the same sachets, but we take sodium bicarbonate and sodium diethionate. We mix it with the urine of Paraquat patient, and if the color is blue, as I've shown in the previous slide, it is severe poisoning. So coming to the last thing, management evidences. Of course, as sir has discussed in the previous presentation, definitely most of the poisons have no antidote. All the thing we can do is supportive management. Coming to the supportive management, all the things we can do is, first is gastric lavage or early decontamination. It is very important. One, gastric lavage. Second thing, using of activated charcoal. I think madam has clearly explained regarding the activated charcoal. What we use is, we use this activated charcoal. This is from Steris. It is available 50 grams. Bottle is available like this. It is already charcoal inside there, right? You just mix water and directly make the patient drink it, or we usually give it through NG tube. Second thing is toxin elimination. These are the things we can use for elimination. First priority is hemoperfusion. If you have hemoperfusion and if you do it within 4 hours, there is high chance that you can save the patient. Rest of the things, very less helpful, hemodialysis, CRRT, I think sir has clearly explained regarding all those. I don't need to go into that. But one thing you should understand is hemoperfusion is effective only if it is done as early as possible. If you do it effective within 4 hours, it is very good. I would like to tell a story at this point. One patient has come to our hospital saying that he has consumed Paraquat, mixing with glyphosate. So I think we took a call. Sir told, okay, we'll go for hemoperfusion because he presented early, within 2 hours. Then we started hemoperfusion for this patient. He's doing better. Finally, everything has improved, and we have seen that his creatinine has never increased. Then we asked the patient, we went back and asked him, dude, did you really take Paraquat like you? Because it's the history what they tell us, right? Because his tongue also didn't show any Paraquat tongue or anything. Then we asked him, did you really take? No sir, there is something called as glyphosate. It is also a herbicide, right? When they say Gadimandu, it might not be Paraquat all the time. It might be a glyphosate also. So he mixed the glyphosate in Paraquat bottle. People thinking that it is Paraquat, they brought him here. They brought the Paraquat bottle. But finally he has gone through a hemoperfusion, but it didn't do any harm to him. And finally he has improved and he has left home. But it is not the scenario with the most of the Paraquat patients. I thought he was the lucky one. And coming to the pharmacological therapy, anyone managing Paraquat here use steroids? Steroids. I think 2 of the steroids which we use as methylprednisolone, 1 gram, every day for 3 days, and the other one is dexamethasone. Cyclophosphamide again is one more thing. Again, I asked sir whether we should use it or not. In young patients, it's very difficult to use, and elderly, I think we can give it a try. Other thing would be antioxidants such as N-acetylcysteine, vitamin C, and vitamin E. All these things we are trying to use because we are trying to save the patient at the end of the day. Most of the times, we know that this guy will not survive, but we should always give it a try. I'll show you our study, what has happened, and it will also give us an insight. And see, again, there's a study done in Japan and Korea where they have used Organophosphate. They have used 30 mg. It is also available in India, but they use for neurological patients, I guess. And it is also showing some slight improvement, but not in pulmonary fibrosis, but from Paraquat poisoning itself. As I told, the role of vitamin E and C and N-acetylcysteine is always present, right? Other supportive care includes fluid resuscitation, vasopressors, renal support, nutrition, analgesia, prevent infections, and manage arrhythmias. Antifibrotics should be started at the early phase itself. I think I should emphasize that pulmonary fibrosis, once sets in, is irreversible. So we should always act previously only. Use some immunotherapy, immunosuppressive therapy to reduce inflammation and delay fibrosis. Antifibrotic agents also are useful. There are some experimental therapies also which are available, which will help in preventing pulmonary fibrosis. Once the pulmonary fibrosis sets in, we are done. So that's all. I think this is a summary of all the tests, what we can do and everything. And these are some studies from where I have collected the data, where they have used dexamethasone or methylprednisolone, and they have shown some mortality improvement and stuff. So this is our study. Finally, to close up with, in 1 minute I think I'll close this. So our study we have done at our center. The stay we have seen was around 1 to 7 days. Totally 15 patients I think survived. 15 patients who have taken, only 4 have survived, with 9 patients succumbing immediately after the hospitalization. And out of these 4 patients, 2 of them have come for follow-up. So only 2 patients have returned, because Paraquat, if they have consumed very less, they'll die after 1 month, maybe after 30 days or 40 days because of pulmonary fibrosis. But these 2 patients have come for follow-up. Yeah. So this is the Paraquat tongue when he was admitted to our center, and on follow-up after 3 weeks, this is how. What I think is he has consumed less than 20 ml, and he has consumed less than 20 ml and come within 6 hours, and we have started hemoperfusion by the time. These are a few lucky patients who might have survived. And this is patient Y. Again, day 5-6 of admission, he had the same presentation. They all have decided when they come to hospital itself, sir, he is going to die. Yeah, we also tell, yeah, he is going to die, but we'll try. And after 1 month, this is how. These are a few lucky patients who have made it. So coming to the conclusion, early recognition and removal is the cornerstone of treatment. Gastric lavage decontamination by activated charcoal up to 50 grams. Use oxygen only if SPO is less than 90%. Rice tube insertion should be done as early as possible, because if delayed, can cause difficulty to insert and cause peritonitis if you cause some rupture or something. Enhance elimination by hemoperfusion, anti-inflammatory agents to reduce inflammation and pulmonary fibrosis. Antioxidants such as NAC, vitamin C and E should be given and are useful. These are some poor prognosis indicators and my references. I have taken all these references from where I have prepared my slides. One of the good studies by Gaurav et al. Is Paraquat, management of Paraquat injection from British Journal of Clinical Pharmacology. If you have some time, you can go through that. Thank you so much. Any questions on Paraquat? I would be interested.
Always the same enthusiasm whenever we talk to Ranjit about Paraquat. Any questions?
I think,
yeah.
I was just wondering that people say no oxygen, what do we do when
Madam,
the patient is practical? I was wondering, we always say no oxygen, but what do we do when the patient is taking NAC, dyspneic, short of breath, saturations in 70s? We often give oxygen.
Yeah, ma'am. If the saturation drops less than 85%, I think we still wait till 85, because if you start, yeah, I mean, in this studies, because I can't tell about my own self, but in this study they mentioned wait till 92% or 90%, but we do wait till 85%, because after that again he will die because of respiratory hypoxia, right? So I think that's where we do intubate him and forget the rest of the things.
Perfect presentation.
Thank you. I think we all should support Satyanarayana sir in his group, where he is working for banning the Paraquat. I think it might be a very difficult task to ban a pesticide in countries like India because there is lots of political hierarchy where we want to reach. But sir has reached to Delhi.
Yeah, but we reached to ministry directly.
Yeah.
Get it banned.
Yeah, to ban it, but
taking all the efforts.
Sir, may I have a minute?
Yeah.
So this, I think this will help, sir, because in Orissa, in 2023, they already banned Paraquat. So what they do is, whenever the season is there for the removing the fungicide, so they ban it. This is the government order. So every year during that time, for 60 days, 90 days, they ban it. So in the Orissa, they are doing from past 2023. So that is done by the governor of the Orissa. So maybe we take this because how the government in India works is to form a new law. It's very difficult. So we take the reference of the Orissa, use this document and give the reference in our own state. Because in India, the health is a state matter, only the state will have to act upon it. Center has no role in implementing the orders in the state. So we can take this to the governor and give the reference to him, so they can take an action, and they cannot ban completely, because what happens again in the black market, it will come again. So just to reduce it, so in yearly, seasonally, they can reduce the sale of the Paraquat. So I will drop it to sir, and now I give the mic to sir to say a few words on this occasion.
One more thing, if you can't ban, at least you should reduce the percentage. It's 24 grams. I mean, which is too high. Glyphosate is available at 30.5 grams at least.
And Dr. Satish, I am not good orator actually, staying fair. I have did a MEM from Apollo, semi-recognized. After that, I moved to Varangal Road, Chandrasekhar sir knows me. After that, suddenly I started seeing Paraquat cases. Till then, we saw only basic poisoning cases in Apollo. I thought that only villages, districts are seeing this type of cases. So 8 years back, I started this movement, sir, with 5 doctors. Now we are 200 doctors, sir. And I have made central minister and Venkaiah Naidu, sir, when he is vice president. As sir told, it is in central hands and not in state hands. Because state can only hold for 60 to 90 days. Even court can hold for 60 to 90 days. And one more thing, sir, for why I am telling central is health matters only to central, sir, not state cannot do this. And its ministry is in Nadda, sir. Health and agriculture, both are in Nadda, sir's hand. That's why I met him. And I met Vice President, sir, also. Next, I met agriculture scientists. And I met these people, sir. Odisha people who work for this. And Kerala also I met, sir. Anything to my wife that she is. And I'm asking to reduce the size of the bottle, sir. 1 liter bottle is costing around 1,300 only, sir. 1 liter bottle. If you can mix in Khammam water tank, go in Khammam will like, sir.
Yeah.
And I'm asking to reduce it to 20 ml size.
And also it's available on Amazon. They can order from Amazon and get it. That's the worst part. Yes, sir?
Sir, on stage.
Very good evening to everyone. Myself, Dr. Mamata. Previously, we worked in Sunshine Hospital, Hyderabad for 5 years. There, we have never seen a single Paraquat poisoning case. So, we studied in the books, but after that, practically we didn't know anything. So, after moving to Varangal, there we used to see Paraquat cases. They used to come, we used to give a bad counseling. In that way, they used to die like that. So, before 8 years back, we have met an agriculture scientist, Dr. Srinivas Ramanathan. So, we wrote to them, like, the patients are dying like this, so is there any solution for that? So, they are also working on the same thing, but we didn't get any answer from him. After coming to Khammam, cases are increasing. So, we have seen many cases after coming to Khammam. Probably weekly once or monthly 4 cases like that we used to see. And patients are at least surviving. So we met Venkaiah Naidu, Vice President, scientists, and Odisha people and Kerala people also to at least ban the Paraquat or else reduce the size. Paraquat, if you know, it is available in Amazon also. One of the patients they bought in Amazon, they died like that after getting from Amazon. So they have to restrict the Paraquat. We are fighting, we have formed a society, DAPP, Doctors Against Paraquat Poisoning. We are having 300 members in that. And many people, they are meeting their respective district collectors and And finally, we got the recognition from central government, from agriculture and family welfare. They asked to submit Paraquat depths data to the collector and DMHOs so that they can take action. So I think this is a great step for our fight after 8 years. I'm happy to see, and I'll be happy if they really restrict or ban or decrease the size or increase the price of the Paraquat. Thank you.
This is a wonderful work actually. So why I want to add one more point about this. This movement is very active. I know Satyanarayana who has been doing, and Asim Iqbal from Varangal is also collecting all the data. I think of late we have seen a letter from the ministry that all medical colleges or teaching hospitals, even private and public, has to send the Paraquat data. But what I think this data may be very tip of iceberg, because some of the patients will die before they are coming to any registry. So that's also. But we also in the parallel what Santosh said. So if it is banned, alcohol is also banned for some few years back. But then it has come into this thing. So if it is with size can be reduced, that's good idea. But we have to ask these what is called agriculture scientists to do something alternative which is better than Paraquat for weeds. But at the same time it is safe to the human beings. So that is one.
Also, sir.
But because this momentum is there, hope this will be banned by the central government soon.
I hope with that I made the talk interesting.
Shall I add one word? In the US, the farmers are there, so they are using the Paraquat, they are getting the Parkinson's. So they have also started the movement in US. So they have the Farmers Association. So they are fighting it because they use the low concentration. But after 30 years of use, 20 years of use, they are getting the Parkinson.
We made them also in US, sir. Dr. G.V. Ramanjanayal. Dr. G.V. Ramanjanayal, sir, IRS, but he came into the farming and agriculture scientist. He is also involved in this, sir. And we tied up with the University of Edinburgh also. They are helping. They did already previous works in Sri Lanka and China, sir. They only back. They helped us like this. And now Sri Lanka doesn't have Paraquat, sir. And also they have the same University of Edinburgh research.
Thank you, Dr. Ranjit, for your elaborate presentation on Paraquat. I now request Dr. Ashma Madam to present a memento to Dr. Ranjit.
Thank you.
Those PGs who are presenting your posters and papers, please.
So one more small request. I request Ashma Madam and Venkat sir and Ashok sir. So some Khammam declaration against this one. So we will send it as a paper. We are all giving a support to this call. So as a scientific professional body, and we can give it 10 members, let people will sign in on this document and send it again, because we are in depth discussed about all these things. So some you take an initiative, we all sign and send it to the central government. So one paper, but definitely it is by this almost what is the attendance today has endorsed that this vision. So
it's a very good.
Sir, we can get 400 signatures, sir. If you want, we can do it as a movement. Start with this conference.
Yes.
I will get to the mic.
I'm so grateful to all this, and salutations to you. And you see this, everyone thinks the same, but the person who takes the momentum ahead, who takes that step ahead, that is by you. You have done so well till now, and everyone out here reciprocates or resonates what you are trying to do. So I request Dr. Santosh and everyone here to initiate this. Sir, wonderful thought. We should do it. And it is my honor and pleasure to give the momentum to sir, because this is again a super talk.
Thank you, ma'am.
Your talk was also very super.
Thank you, Dr. Ranjit. Postgraduates, be ready with your paper and posters and go to the lecture gallery one. Quickly, we'll have a tea break and come back for a panel discussion.
So only the postgraduates who are presenting can go over there.
Hope everyone has been recharged with the free break. So now I request our panelists, Dr. Chandrasekhar sir and Dr. AEME ma'am, please come on the dais. Now I'd like to introduce Dr. V.V. Ashok Kumar Reddy garu.
Shall we continue? Yes. Okay, I'll invite you. Yes. So, welcome back to the last session of today's scientific program. I invite Dr. V.V. Ashok Kumar Reddy, who is working as an assistant professor at NRI Medical College, Guntur, and he is going to deliver importance of ECG and ABG in the emergency room. I welcome Ashok.
Sir, thank you, sir. Thanks to the Organized committee for giving me this opportunity to take a class. Today I'm going to discuss about ECG and ABG in toxicology. So, first of all, we take on ECG. What are the normal parameters of the ECG? What we see in the normal ECG? That is, we see the P wave, PR interval, PR segment, QRS, ST segment, and T wave, and followed by U wave, something heavy manner. PR interval will be less than 200 milliseconds, and QRS less than 120 milliseconds, and you have to check for the ST segment for ST depression and elevation, and also the T wave abnormalities like tall T waves and hyperactive T waves. So we will check all these things in a systematic manner. Next, why ECG is important in the emergency room in the poison patients? Because it can be done as screening tool. It can be for the diagnosis, prognosis, and the monitoring progression to guide management and disposal of the patients. And also, why it is a screening test? Because it can be easily available, non-invasive, and inexpensive, and identifies urgent but potentially life-threatening conduction abnormalities. What are the cardiotoxic manifestations? What all can be seen in this? Phosphoryl channel blockers can be seen as broad QRS complexes, and also right axis division can be seen. Most commonly, you can see in the ECGs in the ED toxicology. This is tachycardia. Also, you can see as bradycardia and VT, VF. In potassium channel blockers, you can see the QT prolongation, also the hyperactive and tall T waves. How to approach in ECG? First of all, like in any other situation, we will see the rate, rhythm, and regularity, and also determine QRS complex. And next, we go to the right axis deviation. What we have to see is R in AVR and S in 1 in AVL. That are the most prominent things. Next, we go to QT interval. But through Bezos formula, can access the QTC. That is 440 in males and 460 in females. That is the normal range. If it is more than that, that is abnormal, and if it is more than 500, that is a more likely chance of getting the toxins. And ECG most commonly we use in the case of chest pain and dystonia. Like that, in the patients with toxicology, in toxicology patients also, we can see the patients with coronary artery disease, alveolar abnormalities also. And for example, in case of cocaine, the patient may present with chest pain and dyspnea as a consequence of coronary artery spasm. In these cases, patient may present as ST-related edema or ST depression also, and patient may sometimes get pulmonary embolism. And ECG may detect the slight changes of the electrolytes like calcium and potassium. First, we go for the action potential of the cardiac muscle. So we have 5 phases. Phase 4 basically depend on the potassium efflux, and phase 0 is mostly depends on the sodium influx. And phase 1 and phase 3 depends on the potassium only, and phase 2 depends on potassium efflux and calcium influx. So if there is any abnormalities in sodium, you can see the abnormality of the QRS, that is ventricular repolation. There is any abnormality in the potassium or calcium, you can see the QTC and also ST segment and also T waves. That is how we diagnose any toxicology screening. For example, if we see any sodium channel blockers, there is any sodium channel blockers, there is a less, actually there is a steep slope will be there normally. If there is in sodium channel blockade, the steep slope will not be seen and there is widening will be there. So gradual sloping will be there. That causes the widening of the QRS. The range of QRS depends on the degree of the blockade. Coming to the potential blockers, the phase 1 and phase 3 and also phase 2 depends on the potassium. Phase 2 combines with calcium also. In case potassium blockade interrupts the reactivity of potassium current, also the phase 2 and phase 3, it causes the prolongation of QT interval and also the T wave abnormalities. That is like the presence of U waves also can be seen. And in case of low QTC, torches depointers will be seen. And also in the beta blockade and the calcium channel blockade, there is a blockage of L-type calcium channels and there is a stoppage of calcium channel antagonism and causes the decreased automaticity of sodium SC node and AV node. So the automaticity will be decreased. The patient will present as sinus bradycardia and later can be present as AV nodal blocks. And if you see in ECG, this if it is a normal sinus rhythm, what are the points we have to see? If you see any normal AV block in this ECG, we have to go for suspicion of beta blockers and calcium channel blockers. If we see any ECG like R in AVR or S in AVR, we go for sodium channel blockers like TCA. And patient having any degree level of consciousness or with normal sinus rhythm or sinus tachy, we have to look for opioid intoxication. The patient has cholinergic symptoms like sweat and all, we have to go suspicion of organophosphates. If any low QTC, I had suspicion of antidepressants and also sodium channel blockers. If it is, what happens if they see any bradycardia? That is, if we see any AV blocks, again the same, beta blockers and calcium channel blockers. And if we see any enhanced adoptable ABPVC, digoxin toxicity should be suspected. And in these cases, if we see tall TVS also, digoxin can cause hyperkalemia, that can cause again tall TVS that because of digoxin. And again, the patient having any opioid toxidrome, have to suspect opioids and can long QT can sometimes be prolonged. QTC sometimes prolonged. Again, cholinergic toxidrome opioids, opioid poisoning. Come up with the normal vital signs, that is because of centric hypnotics. Again, you can see R in AVR and S in AVL, we will go for TCA. What are the tachycardia which is normally seen, but if tachycardia with YD curves, go for TCA and other sodium channel blockers. And also with the cocaine. There are complex can be seen in many causes, either toxidromes or sympathomimetics or anything else. We can see the radicals, the drugs causing the bradycardia and patient having going into AV blocks. What are those things? Especially sodium channel blockers, calcium channel blockers and beta blockers. These beta blockers and calcium channel blockers and cardiac glycosides like digoxin, which these cause decreased automaticity and also cause AV node blocks and bradycardia. In organophosphate compounds, initially tachycardia may be seen, but later bradycardia will be seen. We know the killer is that bronchospasm, bradycardia, and bronchoria. So one of the B is this in the organophosphates. What are the common ECG findings seen? That is the QT prolongation, QRS widening, or bradycardia, ST elevation. ST elevation and depression, that especially in the cocaine and now we have to suspect. And tachycardia, usually which is normally seen in many cases. If any suspect acute poison patient, look for any ectopics. If there is an ectopy, there is high risk of patient going into cardiac arrhythmias. There is no ectopy, look for any sinus rhythm. If there is sinus rhythm, look for normal QTC. If the QTC is normal, there is low risk of going into cardiac abnormalities. If there is QTC is less than 500, going to TD process is low risk, and if it is more than 500, that is a very high chance of going into torsions. And in case of any acute poisonings, we have to look for the patient is going to deteriorate. In regular ACLS standard protocols will not be subsided. We have to add for antidote and also anti-anemic options. We have to choose it. So, can anyone say what can be this? This can be deoxytoxicity and patient having scooping of the ST segment and patient having first degree block. That is a hockey stick cycle. This is a classical sign of deoxytoxicity. What can be this one? You can see ST segment elevation, hyperacute TVS. Patient having chest pain, history of cocaine. Yes. That can be similarly present as MI. What is this rhythm? Sinus pride. Sinus pride, what is the cause of intoxication? Beta blockers or calcium channel blockers. Actually, this patient is because of sotalol intoxication, sotalol overdose. What is this? Tall peak TVS. That is hyperkalemia, can be presented in case of AK or CKD and also in deoxytoxicity also. And I want to show this because of this. You have to differentiate between hyperacute TVS and tall TVS. Hyperacute TVS, tall TVS, that is tapering will be there, base will be narrow. Hyperacute TVS, broad base and like bell shape. The tapering is not there. There is a difference between hyperacute TVS and tall. Hyperacute TVS may convert into ST segment elevations later on, and that is a classical sign of MI. But hyperacute TVS is because of potassium. Tall TVS is because of hyperkalemia. Coming to the ABG, one of the parameters we have is pH, that is 7.35 to 7.45, PaO2 is 60 to 100%, PaCO2 35 to 45, and Vicar 20 to 26 are saturation 88 to 100%, and gap 8 to 12. That is the normal parameters. In special mention, I have to mention about the methylhemoglobinemia because in ABG, that is the sole thing we can do in the initial stages of to diagnose the methylhemoglobinemia. In what happens is, in methylhemoglobinemia, oxygen carrying capacity of circulating hemoglobin occurs due to conversion of 4 iron species from the ferrous state will convert to ferric state. So the ferric state cannot bind to the oxygen and cannot carry the oxygen through the blood. So the oxygen carrying capacity will be decreased. And the methylhemoglobinemia, patient may have hypoxemia and patient may have present of chocolate colored blood can be seen, and the diagnosis can be confirmed with either arterial or venous blood gas and with co-oximetry. Normally ABG values will be shown as PaO2 will be high and low saturation level. Saturation will be around 80 or 85 something like that. But PaO2 will be higher, some 100 or 150 or 200 also can be seen. Even with oxygen therapy, patient will not be recovering, the saturation will be still less. So in that case, that is called as a PaO2 saturation gap. That is PaO2 will be higher, but saturation is in the lower side. So in that case, you have to go. That is a key indicator for interpreting the hemoglobin substitute to carry oxygen. You can see this ABG. The PaO2 is around 350, but SO2 is around. PaO2 is PaO2 is 596, but the SO2 is around 80 to 86. Even with oxygen therapy, the patient saturation levels is not improving. So in that case, we have to check for co-oximetry. In the oximetry, the pulse oximeter check the oxygen carrying capacity of oxyhemoglobin only. So in co-oximetry, it will measure the oxygen carrying capacity of various levels of hemoglobin, various wavelengths of hemoglobin. That is like methylhemoglobinemia or carboxyhemoglobinemia. So everything will be done. And In here, in the co-oximetry, we can see the methyl that is 40%, but pulse oximetry is 94%. Even though PaO2 is almost same. So PaO2 is high, methyl is 40%. So in this case, if you have the ABG, only oximetry, there is disparity. And if you have the co-oximetry, that we can diagnose little bit easily. Here we have 4 types of ABG abnormalities: that is respiratory acidosis, alkalosis, metabolic acidosis, and alkalosis, and lactic acidosis. In respiratory acidosis, maybe because of that is CO2 is increased, that hypoventilation occur within the normal respiratory rate if the titer volume is decreased. Because of poor gas exchange, CO2 accumulation will be seen. The major cause of are opioid intoxication and selective hypnotic intoxication. Opioids may lead to hypoventilation through mu-opioid receptor mediated blockage. This leads to problems of hypercapnia, suppression of normal drive of respiration. In case of opioid intoxication, if you give naloxone, the patient hypoventilation is the best predictor for response for naloxone. In case of flumazenil should not be given in patients of benzodiazepine tolerant or dependent cases because it may induce seizures and life-threatening causes. In any case of opioid or any sedative injections, first we have to take care of the airway. So intubate the patient, mechanically ventilate, then go for antidotes. Coming to metabolic alkalosis, there are 5 types of roughly 5 causes. That is compensation to respiratory acidosis, addition to any bicarb, any loss of chloride due to loss of chloride, appropriate or inappropriate mineral particulate excess. Metabolic acidosis can be because of either compensation to metabolic respiratory alkalosis or addition of any acid, or inability because of RTA, renal tubulosis type 1 or type 2, type 4, and also because of type 2. There are 2 types of metabolic acidosis. There is normal analytic metabolic acidosis and also high analytic metabolic acidosis. So in normal analytic metabolic acidosis, the examples will be like arterial toxins, toxins inducing diarrhea, and also injection of absorbable acid, carbonic anhydrase inhibitors, and toluene ethylene glycol, and dilutional acidosis. And we know the HACMA, that is high analytic metabolic acidosis, the carbon bites, the denotes cyanide, alcohol, ketoacidosis, toluene, methanol, metformin, uranium, decay, paraldehyde, iron, isonic acid, lactates, ethylene glycol, salicylates, and salicic ketosis. This is case series which was taken from one study. In this case of ethylene glycol, there is pH, that is severe metabolic high analytic metabolic acidosis. pH will be in acidotic in 2 cases. Bicarb is severe metabolic acidosis is there. Bicarb, and also lactates are higher. The only difference between ethylene glycol and decay, what are the difference? 2 APs are side by side. How can you differentiate between decay and ethylene glycol? Sugars can be normal in these cases, but in decay sugars will be high, more than 250. And there are various causes of lactates, that is anaerobic metabolism, and also the causes like seizures, oxygen demand, except like interference with oxygen utilization, any local ischemia, metabolism to lactate, like in propylene glycol, inability to clear lactates in metformin or ethanol poisoning. So these are my references, and thank you.
Thank you, doctor. You have given a detailed and importance of initial ABG and ECG non-toxicology cases. As the patient comes, first thing we do is ABG and ECG in critical care. I have highlighted the importance of each. Thank you very much.
Thank you.
Any questions? 1 or 2 questions are allowed. So these go in parallel with the toxidromes, what you have learned. So definitely in analysis of the toxidromes, include the ECG, what various poisons will give the changes in the ECG, and ABG also. So if any questions, please. Otherwise, if no questions.
Thank you, sir. Now I request Dr. Chandrasekhar sir and my ma'am to give a sheet to the Now let's move on to the next session. Now I request Dr. Shruti ma'am to come onto the dais. She'll be telling about the radiology in toxicology.
Again, this is a very important topic. Also helps in toxidrome analysis, the radiology part in poisoning. Sometimes we may be wondering how this radiology imaging will help in diagnosing which poison and poison is not known.
So good evening one and all, respected chairpersons and respected faculty and colleagues and all postgraduate students. Today my topic is imaging and toxicology, where toxin leaves a trace. Every toxin leaves a trace in your body. So what are the clinical implications of imaging in toxicology? So first is obviously in acute poisoning cases, and the second is to know some patients might present to you in a delayed manner after hospital hopping with delayed presentations of the acute poisoning. So in that cases, to track the side effects of the toxin of initial poisoning, we can do it. And also in case of body packers or body stuffers, and also ingested foreign objects, especially in pediatric age group. So this is the first case scenario of an 18-year-old healthy male, previously healthy male who was admitted in the ER with a history of attempted suicide with compound X. On admission, he just has high serum creatinine level, but otherwise asymptomatic. He was discharged after day 10 with his normal renal parameters, but after day 10, on day 10, he started having respiratory symptoms which were unresponsive to any local treatments. And by day 30, he developed overt lung fibrosis. So these are the X-rays of this patient, and picture 1 is on day of admission, whereas picture B is on day 10 of the admission, and BC is on day 30. As you can see, there is gradually haziness developing in the both lungs, predominantly on the right side in the middle zone, and by the day of 30, bilateral lungs were involved, and more predominantly right side showed this haziness and patches over the right side, entire lung, and left side especially in the lower lobes. This indicates fibrosis. And this is a CT of the same patient showing diffuse pulmonary fibrosis involving both lungs, predominantly over the right side, and you can see some cystic areas present. Can you guess what this compound is? Paraquat. As other eminent speakers have elaborately spoke about this. Can you please tell me what other medical drug can cause the same condition? Yes, Amidol. So this is the second case. A 24-year-old psychiatric patient presented to ER after accidental ingestion of a compound X. So here in CTs, you can see there is a sorry. No, sir, both are going forward. That's the point. So, in that CT, you can see that black arrow indicating upwards, that you can see air around the very bronchial area. And here in This orange arrow indicates air in the hepatic vasculature, and also you can see that translucency in the mesenteric area. The blue arrow indicates pneumoperitoneum, and there is also pneumomediastinum. So, in what conditions can you see this? Yes, corrosive and acoustic agents ingestion, which can lead to corrosive damage in the esophagus or tracheal, which leads to air leakage and cause of your either pneumomediastinum or pneumoperitoneum. So the other important complications that you might see in caustic injuries is stricture formation. Here are two cases. There's a young female who has ingested caustic compound and has presented with a delayed presentation of eclasia-like symptom because of eclasia-like syndrome because of the stricture presented in the esophagus, and that you can see a plain stricture present in the mid-segment of the esophagus. And this is a case of 28-year-old male who was brought to ER in an unresponsive state after allegedly having an unknown amount of alcohol with unknown amount of sleeping pills, and he allegedly had 2 vomiting episodes in supine position before becoming unresponsive, and attendants gave you a history of gurgling sounds before CT. And a CT showed those bilateral infiltrates in the dependent zones. PGs, any idea what is this? Aspiration pneumonitis. If it is present within a sterile compounds or inhaled gastric contents, aspirated into your lungs, within 1 hour the presentation will be like this, and you can see bilateral pulmonary lobe infiltrates in the dependent zones. And this is interesting. This is a case of a 32-year-old male presented to ER with a case of cough SOE after ingestion of a compound X for a video swallow test. And the initial X-ray revealed a metal density infiltrate in the superior segment of the right lower lobe. So basically this is a case of a Williams swallow study gone wrong, some of which has been aspirated into the right middle lobe of the lung. And usually most of the compound will resolve on its reabsorbs on its own, but some might always retain in the lungs. Again, this is a 43-year-old female which presents to ER with complaints of dyspnea, non-productive cough and central chest pain within 2 weeks of evolution, and she has a history of a single exposure to inhalation to the high concentration bleach at her workplace, and her chest graph showed areas of discrete hypotranslucency as marked yellow you can see in the upper lobes of her thoracis. And this is a CT of the same patient which shows a ground-glass opacities peribronchiovascular areas in the upper part of the lungs, and also in the middle axial cut shows the middle lobe involved. And this is a case of 1-year-old female presents with the concerns for refusing to eat and increased drooling, and she has been doing very well until the afternoon, playing at cousin's house, and suddenly she started spitting out food, not interested in eating or drinking of any food, and she seems to be having increased drooling and altered sensorium as she goes on, and she's becoming more restless. And you can, on arrival to ER, you can see there is tachycardia and slightly elevated blood pressure, and temperature is around 99. And her saturations are normal, respiratory rate and saturations are normal, and in esophagus revealed a small foreign body below the clavicle area, and this is important because you just need to rule out between 2 things, that is, it can be either a coin or a battle battery. The 2 things that you can do is, one is, how can you rule out the 2 signs? Can you say? What are the 2 signs which helps you differentiate between a coin and a battle battery? The right side one shows a hollow sign. Look for a translucency ring around the outer border. If it is there, then it's likely a button battery. Also, the second one is step down sign. So you can see on the lateral X-ray there is a bulge protruding from the out rim that indicates a step off sign. It is it indicates a button battery. So once the patient, once you are confirmed there is a foreign body, it is highly important that you remove the foreign body ASAP, ideally within 1 hour, because lithium batteries and all, they cause caustic injuries and also liquefatic necrosis and may lead to perforation and the damage starts as early as 15 minutes after ingestion. So it is highly important that you push this case towards your endoscopic gastroenterology and for the removal of the object. The next case is a 57-year-old male patient who was admitted to the hospital with a diagnosis of metabolic acidosis and coma after ingestion of compound X. And MRI was, initial stabilization was done and all fine, and MRI was performed on day 10 after the 10 days of admission, and it showed following features like bilateral lentiform nuclear necrosis is seen, and also in image there is subcortical hemorrhages scattered over white matter lesions are seen in the picture E and all. So can you say what compound is this? This has also been elaborately discussed. Methanol intoxication. Methanol intoxication, one of the pathognomic MRI finding is bilateral lentiform nucleus necrosis. So this is a case of a 31-year-old woman who was brought to ER after found lying unconscious in the bathroom. She was brought to the ER after 1 hour, and there are no evidence of seizures, vomiting, trauma at the time of incidents, and no history of fever or any substance abuse in the past. And MRI was taken, and it shows a patchy enhancement of the globi pallidi indicating necrosis. Any idea what poisoning is this? Yes, sir. Carbon monoxide.
It is in the bathroom.
It is in the bathroom, and carbon monoxide is tend to have a predilection for watershed areas, especially globi pallidi. Because carbon monoxide poisonings also tend to cause hypotension, and hypotension leads to necrosis of the watershed areas. So, this is the pathognomic. The globi pallidi has CO has more predilection for globi pallidi necrosis. This is the same for the same patient for the same poisoning. So you can see diffuse translucency, hypodensity over the subcortical white matter there in the CT. It's not very well appreciated here. And also there is focal necrosis in cortical necrosis seen in carbon monoxide poisoning, especially in the right side of the temporal lobes. So this is another case, a 45-year-old male presented to ER with complaints of upper abdominal pain, and upper abdominal radiograph update showed radio-opaque xenobiotic. So after further questioning, the patient revealed that he took Pepto-Bismol tablets for his multiple numbers for his peptic ulcer disease. Bismuth being a radio-opaque material, it has been seen in the radiographs. So this is a case of a 27-year-old female who presented to ER with the symptoms of nasal congestion and chest pain. So she reported having the chest pain after about 8 hours after first use of a substance X via nasal insufflation. And EKG shows normal sinus rhythm with no ischemic changes, and chest X-ray reveals a red mark showing a radiolucent area at the heart border, indicating pneumomediastinum. Can you tell me what drug is it? Can you tell me what drug is it? Hint is in the history. It's cocaine. Cocaine. Nasal insufflation. So when they take a deep breath, it creates a negative pressure in the upper airways. So for an ideal absorption, usually they hold their breath, which creates a positive pressure. In total, it increases your intrathoracic pressure, leading to alveolar rupture. So that will lead to your pneumomediastinum. Also, there might be seen air tracking, peribronchosvastular areas and interstitium, which is also called Macklin sign. It's because of Macklin effect. So this is another case of a 32-year-old male who was presented to ER by airport staff. So this is typical nausea, abdominal pain and distension as soon as he was landed in the airport. And plain X-rays shows ovoid-like structures in the large intestine, and also your CT shows multiple opaque substances seen in the rectum. So this is a typical case of your body packers. So you can, anytime an airport staff brings any patient, they might get a patient with a suspicion of not eating en route the entire flight, or if there is any rupture of your body packs inside, they might present with any toxidromes, overdose toxidromes. So you should always be aware of these body packers. This last case is of a body stuffer. So what is the difference between body packer and stuffer? Yeah, packer is premeditated. He's a mute. He's premeditated the entire plan and he's doing. Stuffers are, they stuff it into their body when they are actually when they are at the risk of getting caught by the officials. So this is such case where a 16-year-old male was brought to ER from a juvenile detention center with complaints of persistent intractable epigastric pain along with a pleuritic chest pain and with multiple episodes of vomiting over the past 4 days. He also complains of dysphagia and rhinophagia. So probably he thought he stuffed a pack of illicit drugs after being caught by the juvenile detention center. So you can see there is a pack of stuff that's been in the distal esophagus which is causing his pains and other symptoms. So this is a typical case of your body stuffers. Thank you. This ends my session. Thank you for this opportunity.
So very nice lucid presentation, a very good case show of all the very interesting cases. Definitely this will help if you have any questions. So if there are no questions, we will end the session here.
So we will do the panel.
Yeah.
Thank you, sir. So, thank you, ma'am. Now I request Dr. Venkat Kotamarata sir to hand over the moment to Shruti.
Very happy to be here. Thank you for the opportunity to the organizing team of Mamata Medical College, the Departments of Emergency Medicine and General Medicine, and to all those online, watching us online, welcome. So now we have the panel discussion. The topic for our panel discussion today is when the poison is uncommon or unknown. So the entire idea of a panel discussion is we have a panel of experts here that we do have very extensively experienced clinicians with us, and we have questions for them, often that the doubts that are in the minds of young doctors and multiple practicing clinicians, and see their opinions from their experience and expertise. So for today, as we have been witness to the multiple extensive talks this morning, when we talk about poisoning in India, we reflexively go to OP compounds or alcohols or snake bite, sedatives, etc., etc. But every ED, every emergency department or every clinic, every first responder also has another category of patients, those who ingest substances that are lying casually anywhere, everywhere, that are probably found on your bathroom shelves, in your closet somewhere, in a grocery, anywhere. And when such patients come in, we often don't exactly know what to do because it is loading. Okay. So these are the uncommon but very easily available poisons. And my name is Nitya. I am an emergency medicine physician. I'm currently a senior resident in the Department of Emergency Medicine at Nizam's Institute of Medical Sciences, Hyderabad. And I am very honored to be moderating the session of when the poison is uncommon or unknown. And with us we have 4 very eminent clinicians. Dr. Ashima Sharma, I don't think she needs an introduction here. And we have with us Dr. Venkat Kotamaraju sir, toxicologist himself. We, along with being a very experienced emergency medicine physician in the UK, and we have with us Dr. Chandrasekhar sir, who is the head of the General Medicine Department at KMC Warangal, and we have with us Dr. Ashok sir, who is the Emergency Medicine HOD from Malaria Institute in Hyderabad. So even while, yeah, that is the slide, that is the presentation, yes. So the initial idea was to have it for 50 minutes, but since we're short of time, we will cut to very important questions and substances that we often encounter but don't really know what to do, because we have multiple textbooks. We don't find these substances in these textbooks. Is this, how do I go?
You need to show that way.
This way. Yeah, we don't have this in textbooks, and we've had an excellent talk on Toxidromes, but these don't fit in Toxidromes either, so what do we do? This is a very known mnemonic that we read, the RNSI dead. This is how we approach any case of poisoning. But today we have with us these 4 doctors who will tell us how to approach cases that may not necessarily fit in here, or we don't have an answer to easily available in any textbook. So we'll start with a compound that is very, very commonly available, that I'm sure everybody owns a bottle of this, and this is something that is meant for the nails, not for the veins, but we have several cases of acetone poisoning that we kind of encounter. So, ma'am, Ashima ma'am, this question is for you. It's one of, acetone is one of the most common household solvents. So, my question for you is, in the ED, what is your initial assessment and what vital sign assessment is most important when you see a case of acetone poisoning?
Thank you, Dr. Nitya. So yes, nail polish removal has been, and paints remover, or all these compounds have been used for poisoning, and they contain acetone. And we were discussing acetone when Dr. Vishwa was talking about isopropyl. And we also understand that acetone, even our body fat changes into acetone. So we all have little bit acetone in the air we breathe, the food we eat, and the water we drink. But then when it is consumed as in the quantity that it will cause issues, it will affect every system, organ system of the body. Right from CNS to GIT to cardiovascular to respiratory. Not only, it has been reported in 2022, a case report where it has got cardiovascular collapse and death as well. So how to find out whether it was acetone in ED, because as you were saying that what vital signs, so yes, there will be issues with tachycardia, tachypnea. Acetone has to change to carbon dioxide and water. So this all helps only for excretion of it. Hypotension, as I am telling that there is a case of cardiovascular collapse, also confusion, ataxia, sometimes seizures activity. So I would look out for and ketosis. The most prominent thing is ketosis. So I would be looking out for ketosis, ketonuria and ketonemia to reach to my diagnosis in case I have no idea what the person has consumed. But most of the time they come up with this. And I'll also look out for this GI bleed, which is also very common because in acetone. So putting in a rice tube where you can see red blood coming out for long. So this is what I would be looking out for.
Okay, so this is for the sick patient who has consumed acetone. how would you counsel somebody who is asymptomatic after consuming acetone in a small quantity?
Okay, so if the quantity is small, so I could not find a reference to what exactly would be the amount which will cause problem, but I could find out that if it is when it is a byproduct of isopropyl alcohol, which is used for this hand sanitizers and all, then more than 4 ml per kg will cause issues. So in a 70 kg adult. So I would say that it might be that you are day one you are okay, you just have abdominal pain, nausea, vomiting, but still you have to be under observation for next 24 to 48 hours till the acetone has not been exhaled out. And I would not be using any ethanol or fomepizole here because especially because it will delay in case it is from isopropyl alcohol, it will delay its further degradation to acetone and will cause longer duration of toxicity. So this is a little different, which Dr. Vishwa has also illustrated, that this compound normally, 48 hours. That is what my thought process is.
So it is definitely not safe to discharge somebody who is...
Again, the literature is a little sparse on it, but they say that one should keep the patient for under observation till the bicarbs are not more than 20, the patient pH is not more than 7.2, especially the venous bicarb, and not be in a hurry to discharge them, and they can come back with further issues. So yes.
Okay.
And I would not be worried about the creatinine, which can have false elevations with acetone, because what we do normally in creatinine in the lab, that we have to do it by calorimetric methods to know the real creatinine values. That is also very important.
Okay. Well, thank you, ma'am, for that. Moving on to our next compound, it is something that is found in every Indian household, very culturally significant, and I will take a seat here. And this is culturally very significant, found in every household in many purposes. So this is something that makes its toxicity much more deceptive. My question to you, Chandrasekhar sir, would be about this compound, if everybody has not recognized it, it's camphor. It's very pleasant to smell, but when it goes in, it's as violent as it can get. So sir, how does early decontamination, we've had a great talk on decontamination, but when it comes to this compound, a very highly volatile substance as camphor, does early decontamination impact the outcome when we talk about camphor toxicity, and does it prevent the CNS effects?
Yeah, it's a very good question. Very common household accident also, particularly children, kids, and they may accidentally swallow also. If it is doing the very serious pujas and all, it may have this thing. But one particular thing about this thing is, it is highly volatile, and I don't think if you want to do decontaminate by different methods, it doesn't have any purpose, because it is immediately absorbed. Instead of spending much, wasting time on the decontamination methods, but look for what is the symptom and how you can stabilize the patients. Say for example, patient may develop seizures, intractable seizures. You better treat on the symptomatic wise, and instead of decontamination, you try to eliminate as early as possible whatever the method is available. So for particularly this camphor, better you spend more time on the elimination and symptoms and other vitals, how it is. So that is what my opinion is.
Okay. So, being a very highly volatile substance, unless you can possibly decontaminate in 5 minutes of ingestion, I don't think there would be any use to it. Thank you, sir. So, moving on to, because of the lack of time, we're going to jump to our next substance here. This is a very interesting poison, something that we have seen in RED. I'm not sure if everybody here has seen the same, but it's something blue. Any guesses? It's something blue. It's found in every college or school lab. Any guesses? One more guess. Okay, so we'll move to the blue solution that can bring red flags. This is a case that we have seen in RED. We had a resident, I wouldn't name which department, okay, but we had a resident come in with Benedict's reagent, copper sulfate toxicity. And this question is for you, Venkat Kodagraju sir, that are there, what is the best practice for acute management and follow-up? Especially because there are no guidelines and this can be a corrosive. Is there anything that you would like to tell us about the acute management if we receive a case like this?
So Benedict's solution, if you haven't used in the chemistry lab, then you've not really gone into the lab. Right? You get a beautiful red brick red color and it's used for reducing sugars. So the problem with Benedict's is two things. You have to treat it as a corrosive poison as well as a heavy metal poison. So it does four things. Number one, it burns the gut. So you have corrosive burns, there is the risk of perforation, hematemesis. Number two, it attacks your red cells. So you have hemolysis and methemoglobinemia. Number three, it hits your kidneys. So you have an acute kidney injury. And number four, it stresses your liver. So you have liver injury, transaminitis. So to answer your question, how are we going to approach? Well, there's no antidote for this. So you treat the burns and also the corrosive burns. Because it's a corrosive, activated charcoal is not indicated. You're not going to induce emesis. Always ABCs for every poison. Contact the nephrologist early. And sometimes if it is severe poisoning, you can use, for copper particularly, you can use chelating agents like BAL or penicillamine or EDP. And of course, the last thing is, if you want to treat the hemolysis or methemoglobinemia, you give methylene. So although it's a rare poison, it's a lethal poison. So you have to do dual treatment of treating the corrosive aspect of it as well as the heavy metal aspect.
Thank you, sir. So we now know what to do if we have a patient with Benedict's reagent. For our next substance, this is something that I'm sure everyone in the room has encountered a patient with, and yet we don't have any guidelines, no antidote, no textbook talks about it. Super vast amount. My question to you, Ashok sir, is what makes this hair dye uniquely hazardous compared to other usual toxins, and what in particular causes the most dreaded craniofacial airway edema when this toxin is consumed?
Hair dye poisoning is comparatively very rare, but it still can happen in case of psychologically disturbed women or men in the home. It is available easily, and accidentally also it can happen when the child consumes it. So these are the two possibilities, and it is a serious poison because it is oil based. First thing is it is oil based, and the chemical is irritated to respiratory tract. It disturbs the hemodynamic stability of the cardiovascular system, and it also is irritated to the gastrointestinal tract. So this is something to be taken seriously, and you've got positive history of consuming this thing before coming to ED. Then you have to be quick reaction, do something. First of all, gastric decontamination you should try, because it's not corrosive luckily, but it's poisonous material. So as soon as possible, you either try to get it out of the stomach by lavas, or you have to use the activated charcoal and do that thing that will reduce the absorption of this particular chemical into the blood. And once it enters the blood, it will cause both biphagic reaction, both hypotension and hypertension, and there will be tachycardia, and this may continue for a long time, so you have to be careful. And main treatment for this poisoning, we don't have any specific antidote, so we have to give supportive. What happens here, because of the oily substance, that upper airway gets irritated, and upper airway will end up in edema, angiolytic edema, because of the anaphylactic reaction plus oily base. And this particular thing which irritates the upper airway causes narrowing of the upper airway, and patient may suffer difficulty in breathing and saturation may fall. So it is always wise to identify these complications and intubate the patient at the earliest before it becomes too narrow. And once you secure the airway, you have to give 100% oxygen to correct the hypoxia. And this small amount of chemical inhaled also will cause bronchospasm, then patient may require bronchodilators. And main treatment for this poisoning is supportive by not allowing it to complicate the issues. And secondly, at the end of the treatment, patient recovers, you have to do effective counseling, not to use such methods to end the life. Then proper counseling is very essential here. And ultimately, in rare cases, patient may require hemodialysis. In that thing also, because it's a small molecule, gets filtered out. That is a possibility. But very few patients will end up in that level and reach at
Sir, so would you are you suggesting that every case of succombasmal poisoning should be intubated?
That depends on the saturation levels. If they are comfortably, continuously maintained beyond 95%, you can just wait for some time. And you can do the oral examination also by doing the tongue depression and see if there is any edema, redness in the skin. And if you suspect any edema developing, it is better to intubate. There is no harm in intubation in a normal patient, and after some time you can extubate if everything is going well. But definitive signs of hypoxia and upper airway edema, you have to intubate at the earliest.
Okay, thank you, sir. So we have one round of questions before we finish this. And ma'am, this question is for you. Given all the unknown poisons without antidotes, without guidelines, without, like Dr. Sharath was mentioning, the known poisons are in thousands, but the known antidotes are only 20 to 30 antidotes. So how do we build, as a very senior ED physician in a leadership role, how do you think we should build protocols for EDs when the market keeps inventing new unregulated substances every year?
So this brings in two poison control centers where we can call, and this happens in our ED whenever there is unknown poison or a toxin which is detected, the students do call, like this Benedict. I remember the student writing in the group that at 3 a.m. he called up CMC Vellore and found out what all has to be done. So this is one thing, is that every state should invest in making a comprehensive toxicology center, poison information center. And from there, all people who are leading the departments should take the information and put up their protocols. The protocol should not differ from one ED to other. They should be the same so that the confusion is not there. Sometimes the patient comes to us and tells us that this was not done there, or this could have been done early. So this takes away the trust which the attendants have in us. So we have to ensure that it is not only inter-department, intra-department, but also inter-institutions, that we have to work on at least one toxin per month to have our own registry of the common toxins. And I am sure that the conferences like this can give us foray to work on it further. That's what I feel. Yeah.
So a uniform code between every ED.
Yeah.
Is your suggestion? Okay. Thank you, ma'am. We've had a wonderful introduction about Doctors Against Paraquat Poisoning. We met Dr. Satish and we had a great time earlier now. But Venkatraman sir, as a toxicologist, what, in your opinion, what direction should public health policy take when we have all of these substances with no antidotes, high mortality, morbidity? Do you believe that, as a clinical toxicologist, what direction should the policy move?
That's a great question. So, high-risk substances, no antidotes, they warrant tighter control. And as toxicologists, we have the authority to advocate for greater policies, as Madam said, development guidelines, have surveillance registries. Of course, in the UK, we are very blessed because we have what is called as the NPIS, National Poisons Information Center. And we have something called as a tox space. And we log into it and look after each poison. Alternative is we can call up the National Poisons Information Center. They are based in Birmingham, London, Cardiff, and Scotland, in Edinburgh and Scotland. And there's somebody, usually it's a pharmacologist. Some of the emergency medicine physicians and toxicologists are on call, or you have acute medicine physicians who can give you some guidance about cases in real time. So if you have a case in front of you and you follow the tox-based guidelines, if you have some more questions, you can read them out. But generally I've found that we are the best people to treat because we are the people who actually are in the front line and we see the cases in the emergency department. So tighter controls, and if you have concentrated solutions, you should have it restricted to labs where we can have greater control and surveillance. And of course, we've talked about registries, having a database, so this is something again we can work on. We've talked about toxicology fellowship, how we can collaborate nationally and internationally. Maybe we can talk about having a toxicology database, which probably this conference will give us an impetus also to work on. We found that people who have got a lot of interest in toxicology, a lot of people doing great philanthropy work passionately on Paraquat poisoning. So there is a lot of scope. It's only about finding the passion to drive your innovation.
Thank you, sir. On this note, I would like to, I'm sure all of us here know, but I think I would like to just reiterate that we do have poison control centers, poison information centers. In India, we have about 29 very established regional poison control centers, but we have two very well-known national poison information centers, one in AEMS New Delhi and one in CMC Vellore, that are available 24/7. So to every junior doctor here, every PG, every intern, if you are here, please make use of this because they're available 24/7 every single day. And these are very underutilized in our practice, so maybe next time you can all make use of it. Sir, coming back to the ED, my question for you, Ashok sir, is what are the documentation must-dos when cases are unknown? And these cases are likely to eventually become medical legal cases. So what, according to you, as an ED physician, what do you think is the most one or two very important points in documentation?
First of all the emergency departments should have a standard operating procedures already prepared by senior toxicologists or senior emergency physicians. They must be available there in the emergency room. SOPs must be prepared with a lot of thoughtfulness and advanced thinking. And all the junior doctors, they should follow these SOPs. Once they follow the SOPs, generally they don't go wrong. Number 2 is, especially for these poisoning cases, there should be a printed format to write the case sheet so that nothing is forgotten, nothing is missed out. So the printed format for the toxicology patients, some poisoning patients, will always be helpful not to forget any important issue. That is the second requirement. Third thing is, we must take all abnormal behavior patients as toxic patients, and we must initiate emergency. If you think that it is okay, after 2 hours we are discharging the patient home. After 4 days, he may develop the complications and you are liable for legal action. So always you have to take every poisoning case or suspected poisoning case as MLC. Make it MLC, there is nothing wrong. If it turns out to be good, that's fine. It may take a little more extra time for you to inform the police. Police will come and take a statement from the patient, that's okay. But that will at least safeguard your interests. These are the important things. And one more thing I would like to share here is, never forget supportive care. Sometimes you don't know the poison, but patient is deteriorating. Treat the patient and don't look for the antidotes. As sir clearly told today morning, there are thousands of poisons and only there are few, 30 or 50 antidotes, definitely known antidotes. So most of the cases we don't know the antidote. I will give you a small example. In the army I was serving as Colonel for a long time, for 22 years I was in Indian Army. Sometimes what happens, the soldiers ask for leave and commanding officer is helpless because already particular portion of the people are already on leave. There is some emergency comes at home from another soldier and he wants to leave urgently, somebody died and somebody serious. And he cannot exceed that leave percentage of the battalion. So he says, sorry, you'll have to wait for 5 days. The other person will come and he will send you. The minimum requirement of soldiers will be there in the border. That is the compulsion of the commanding officer. As a doctor, I was with them and my experience is very funny. And one soldier came with liquid boot polish, which is readily available to every soldier. He drank it 50 ml. Boot polish liquid. And he became unconscious, he was brought to me. And nobody told what he took. Then I was in a big dilemma because that's almost in a border area. Nearest hospital is 100 kilometers away. So I checked the pulse, there was little bradycardia around 50 heart rate, and blindly I gave atropine. Let me try my best, something may be beneficial to him. And started a broad gauge needle and hydrated him. And after some time, something told me that he is breathing heavy and there was no ABG nowadays. So I started soda bicarbonate solution slowly. So I was with the patient. I was recording the temperature, BP every 15 minutes. Fortunately, after 3 hours, he became conscious, opened his eyes. I asked him, what did you take? He said, good polish liquid, sir. Then by the time it was 1 hour plus time or 2 hours. Then somehow I gave him a stomach wash with a big thick tube. And something came out smelling kerosene-like smell. And I thought that pulmonary node will be there. So I was with the patient for 24 hours, took him to the nearest military hospital, Jammu. There his X-ray was taken, X-ray showed aspiration. Then I admitted him in the hospital, I was with the patient, taking the permission from the commanding officer. So after 2 days, gradually he improved. He improved because of his physical fitness. He is very strong like a horse. So then he was given sick leave for 6 weeks. And we went home and did that. So sometimes the surprises will come. You will be clear about supportive treatment and try to save the patient by some method or other. That's my personal experience I wanted to share with you.
I want to add one more thing. So every poison patient, so they may be consuming it suicidal or anything. So they at the weakest point of their psychological. So to induce some pressures on this thing like your leave or whatever, even children also to tackle in the family issues and in the family members also. So after successful treating at least, so he must be referred to psychiatrist.
Yes, Yes.
So one poisoning, if you are with a lot of insights and then poisoning is not known and empirical treatment succeeded, but if the original motive and cause is not known, then it may often repeat. So as per the documentation point of view, documentation only saves you from any legal action for any the errors of commission or omission. So you document it at that point of time, these were the things. So that will help you, and as Sir said, because some delayed effects may be seen after this thing. So every poison or suspected poison you admit. So admit, so if he is feeling good, so either he will abscond. So then we don't have any this thing. Go against Lama also we can't send them. Abscond is the only way. But legally we are very absconded. Yes. So that is one. So everything must be documented, and at the time of successful discharge also refer to psychiatrist. So that point will help. Thank you.
Thank you. So regarding documentation, every known, unknown, doubtful poison is an MLC. And sir, in closing, my question is for you, Chandrasekhar sir.
One minute.
Yes.
In rural area, never forget crate bite. Crate bite is not visible. That include your DD. Crate bite is always a possibility in rural area, and it will not leave any bite marks.
Yes. So Chandrasekhar sir, if today for our audience, for all the young doctors here, if there is one single takeaway message that you would like to give when you approach an unknown poison, when you don't know what the person has consumed, what would it be? Just one thing.
So summary of today's entire sessions, very good question. I'll try to tell this, but other panelists may also come to my help whether this is right or wrong. So thing is that all our seniors and who has a vast experience, particularly in the emergency department, in the toxicology itself, so with army discipline. So whenever the patient comes with the poisoning, whether it is known also, you think that it is unknown for the reason, so history may go wrong. Sometimes somebody, one speaker has told, so in one package, other thing may be there. And there may be cocktail of poisons. So that is the reason why. So it is not the diagnosis that matters. So it is, as Sir said, treat the patient. Support it. Treat the patient as a whole. Support and what system is going wrong, what problem is there, biological, physiological, and ABCs will be there and everything will be there. But you treat the patient as a whole. In the background, some poisoning is there, whether known or unknown or mixed or whatever it is. So treat as per the guidelines which are available. Antidotes are very not sufficient for everything. So in that case, you try to save the patient. So any poison, it will come and enter into the circulation. You dilute it, prevent to volume distribution, and try to improve the elimination, whatever it is. It has to go out of the body. So these are the some points where you can focus on. You don't know anything what is there inside. So you dilute it, prevent the volume distribution, and try to eliminate from the body. And the supportive system is there. That initial slide I remembered, RR, SI, dead or something like that. So yeah, so that mnemonic will help. So I think I am
that's
just
perfectly put, sir. Don't chase the poison, but chase the physiology.
Yes, save the physiology.
Save the physiology.
So hope Venkat sir and Ashima madam Ashok agree with me, because the last question is a very bigger question you asked me.
Well, thank you so much, sir. Thank you. And with this, I think we have come to the end of our panel discussion, and I think this is one message that we would like to leave, that behind every poisoning is a story that we do not know. It might be a part of, it may come from the victim's curiosity, access, impulse, despair, or simply accident. And our job is not to just treat the toxin. Being in the privileged place that we are, interacting with patients and families and the community. I think our job is more to treat the person, protect, counsel the community, and if we are good at what we do and if we're lucky, we can make sure that this story doesn't repeat. And with that, I would like to thank our panelists once again for a great discussion, and thank you all once again. Thank you for this opportunity. Thank you.
Photograph. I request, after the photograph, I request Chandrasekhar sir and Kotamraju sir to throw in enlightenment on fellowship on toxicology, because passes stay back for 5 more minutes, and so that our formal finishing of the session also will happen, and after the insightful fellowship message from Chandrasekhar sir and Kotam sir, so we'll start the quiz, the most awaited thing.
I need to thank, we all need to thank Dr. Vidya.
Sir, please on the stage, make it, sir. Sir, please be on the stage.
Excellent moderation she does.
On the
Always
stage.
makes us
We have the panel prize also here.
For the want of time, we will make it very quick. So thing is that this is about the fellowship in toxicology. So there are many associations or bodies, and not many universities are giving this fellowship course, whether it is really necessary or not. So that is one is the question. So I will run through certain slides. So of course, followed by me, Dr. Venkat sir will tell about international scenario. It's not moving. It's not moving.
Remote that side walls or
Yeah, the reasons could be like it is a silent epidemic. It is not, if not one continuously one poison, one or other, so it is keep on increasing. So this is one picture that what is 3,46,000 deaths globally per annum. So 91% occur in the countries like India, low middle income group, this thing, and there is a knowledge gap. So knowledge gap, like in the standard MBBS MD curriculums, you take MD, general medicine particularly. So often cover toxicology only superficially. In MBBS we will see only in the forensic medicine. Lack the depth required acute clinical management in the ER. So that was lacking. And resource scarcity is also there. Lack of the specialized training leads to delayed identification of the toxidromes. So toxidromes is a passion in any conference is because we are not being taught from the beginning, and limited knowledge of the novel antidotes. And this question was there. No, the gap is that there are so many thousands of poisons and antidotes were less. So why antidotes are not being invented? So in this scenario, suboptimal critical care for the poison patients. So the bridging the gap between theory and life-saving practices must be there. So for this, of course, research also has to come. And what is a toxicology fellowship? A fellowship is creates a specialist capable of the moving beyond the basic gastric lavage. So in India, what I believe, and now it was there 25 years when I was entered into the clinical practice. It was the only thing, poisoning, just stomach wash and go, and if you are survived, you are lucky, and then it was the situation. And India in particular, the combined AB, now Warangal is the one. So with the highest number of documented poisoning cases, particularly these pesticidal poisoning cases there. So in this scenario, that it involves the mastering of the antidote administration, this one extracorporeal elimination, the dialysis part. So dialysis part is now picking up because the nephrologists are also involved into this poisoning management. So, and of course, the critical care physicians and all has to deal definitely with the multi-organ failure. So, poisoning is not just elimination and giving some antidote. So, beyond that, so the rapid elimination, new methods of elimination, and managing effectively that multi-organ failure. The goal is to produce the practitioners who can lead the poisoning centers. Ashma Madam was telling that we have to develop a poisoning centers. Each medical college or each medical center should have their own poisoning center and definitely make use of the National Poison Information Centers, AEMS Delhi or CMC Vellore. So wherever it is 24 underutilized, and take them and make your own center, and you may be resource to the other situations. So what are there are specialized post-MD programs, very few are there. So the focusing more on the poisoning, chemical exposures, antidote-based care. Other time the sir was telling it is only the climate change, because the new areas of this poisoning and intoxication will come. These what is called the blasts and these smoke. All these things are happening. So even fire accidents, because the smoke will come, it's a different kind of poisoning. So from one factory fails, no, it's a mass casualties also can happen. So the bridge between, so other day it is almost summary what I believe, the bridge between emergency medicine, critical care and poison control. So need, yes, rising incidence is the one reason. So pharma related pesticidal poisonings is another, this is very relevant in India. Urban drug overdoses, but now the people, young people, youth, they are living in a different kind of society, so they are easily available. Narcotics or banned drugs, so all rave parties and all those things are there. You cannot trust anyone. So all these can, it was a like it can happen in India like situation. Now it is happening. So for that reason also, the number of toxicology trained people are needed. Need for clinical expertise, rapid decision making, supports the emergency and critical care. So the core curriculum could be clinical toxicology, that is toxidrome recognition, stabilization. So if you don't know anything, stabilization. What is stabilization? You learn that is sufficient, and supportive care for unknown poisonings. This was we are discussing. Analytical interpretation of the drug screens. There are so much of toxicology screens. So if the allergy screening is there, because which allergen is causing this thing, like which poisoning. So you can develop, at least if it is not at all available. So you can develop. So it can create the lab data to guide the therapeutic decisions, and environmental also. The management of the occupational hazards, heavy metals and envenomations. So all these things will be a core curriculum in India. So the key skills to taught is the poison management protocols, and if the protocols are not there, should be developed, and antidote use and indications has to be understood very well, and laboratory toxicology, interpretation of the EEG, ECG, radiology. So what were taught now, and critical care support in poisoning, because ultimately you have to save the organs and then save the person, and coordination with the poison information center. So with this attitude, so one has to do a fellowship program, and what is the impact, what is the use? Yes, definitely it will reduce the mortality, timely antidote administration saves the lives, and faster diagnosis will prevent so much of the morbidity, quick administration of the unknown toxins. So like optimization of the ICU use, better triage and resource allocation will come. So this is very, very high impact on the critical care medicine. So same thing I have told. So, and next future scope, advanced developing the new antidotes and protocols for specific to Indian toxins, that is necessary, which is lacking. So if anybody is interested in this line, take a fellowship and progress yourself, and in future maybe specialty, super specialty courses will come. Education integrating the toxicology into the core residency curriculum. In the residency, and unfortunately all our surgeons are not completing their internship in the hospitals, for which, so from the anatomy days they will read for the PG NEET, and for in the MD they will read for all those things, and they are not learning the practical points. This is a very special situation in India, and establishing these more poison information centers in every state. So I think Ashima Madam will start one center for Telangana. So it is our responsibility to produce that also. So this is like a 1-year fellowship. It is available, but accreditation pathways, faculty requirements, these are the big logistic challenges, and infrastructure, emergency department, you have to in align with the poisoning, ICU support system, toxicology labs. So many EDs doesn't have toxicology screening protocols and labs, and there is no tie-up with the poison information center, even if they are available freely. So curriculum, usually the foundations, clinical rotations, advanced toxicology, and 10 and 12 months, last 2 months research and public health modules. Ultimately, we are working for the healthy, poisonless society for our India. So module, core, skill and research modules all will be there, antidote training, toxidrome recognition, simulation based toxicology workshops and all. So formative, summative at the end. What is the path forward? Integrated training, advocate for including the mandatory clinical toxicology, rotations in emergency medicine. Actually, I differ here. If the general medicine person is there, so he may need additional information about the toxicology. But emergency medicine will have definitely a clinical toxicology rotations, so that it will be a part of his curriculum, and critical care residency programs also, and expanded fellowships, like encourage more institutions to adopt the. So some private institutions like Indian Society of Toxicology or International Society of Toxicology, so many models also. Whatever is the good which is adopted by some other institution or any university or any country, that can be imbibed. So I think this association can develop one of the fellowship pathway for the same this thing. So probably all stakeholders has to come, and other is the clear track. So this one is there. What is academic and institutional? So DM in medical toxicology. So that is what I am telling you. 3 years for super specialty may be recognized by NMC after select premier institutes, and institutional training centers like AEMS New Delhi, Jodhpur, and AEMS Rishikesh, and Kochi and Kochi PGMR. So short-term training also, specialized internships like Tech India and some other NGOs are doing. So like key institutions offering these programs are All India Institute of Medical Sciences Rishikesh is offering 1-year postdoctoral certificate course, and so on Tamil Nadu, MGR Medical University in Chennai. So associate hospitals like Dhanvantari Hospital. So same sort of thing with premier institution like NIMS can have one kind of thing. So other professional bodies also like Indian College of Emergency Medicine are there. So but our own this thing. So some of the few examples only I am telling, but what I strongly believe, so these kind of program knowledge in the form of certificate, in the form of degree, either university accredited or some good accreditation societies can give, it will help in the betterment of this thing. So these are the already given, Dr. Nitya has given these vital centers. And conclusion, toxicology fellowships strengthen the emergency and critical care. India needs more trained specialists. National training programs will greatly improve the patient outcomes. Thank you very much. The dose makes the poison, but the right expertise makes the cure. So the dose, Sarva said, everything is poison, but dose makes. So if it is in the poisonous dose, can be made it as a drug by the experts, for which they have to take the fellowship. And I invite you for what is the international lookout on this fellowship. Thank you very much.
Sir, or one of the faculty panelists should leave to Hyderabad. She has a night duty to catch. So I request our HOD sir, Mahendra sir, to give the mementos to the panelists and moderator. I request all the panelists to come onto the stage, including the moderator. She has just had 2 days time, which she prepared everything. So great thanks. Now I request Mahendra Kumar sir to give the comment to the moderator. Moderator of India, madam.
Sir, ఇక్కడ కొంచెం క్లోజ్లో ఉంటారు సార్ దగ్గర ఓకే సార్ ఇక్కడ
Now I request Krishna Sumar sir to give the moderator Ashma madam.
She went from Nizams. She was with us as non-acad chair. So Nitya is an example that if you are passionate for emergency medicine, this girl already when she came as non-acad chair already had her a UK thing in her. And after MBBS, okay, they will understand. So, but she wanted to do more. She said, no, okay, I will go once I have a degree. So every step she has given academic staff priority, and that is why we are very proud of her. And not only today she proved her mettle, times again and again, she always proves her mettle. And this was on a very short notice. I should share with, they are all your peers and your colleagues out here. So it was just day before yesterday, that too in the evening hours, when I told her that you moderate because I was not able to do. And then I just reminded her, if it would not have been you, I would not have done we did one CME at Nizam. She was not at Nizam. I got her to work from NIG and told her to moderate at Nizam. I said, when I can do then why do you even feel that you will not? So, and I'm sure all of us, 4 of us, how gently, academically, with content, with respect, she moderated the session. And the result is all online and everything. Thank you, Nitya. All this.
Madam, I request everyone to come to the NIMS so that get impressed and become like Nitya and future doctors. So I was, madam, from 2011 to 17 I was there in Somajigoda but never went to NIMS. So I could have, otherwise I would become the second Nitya.
You are much ahead of Nitya. Yeah, I already said your passion. I will not say no. I was worried at a point of time. You were never. So thank you. This all thought process of doing something beyond our boundaries is for patient's sake. Otherwise, all of us are super busy. All of us.
No, it is not for the patients. It is for this, like students like Sharat, students like her. Will impress the next generation of the students to become like that.
Everyone. All of them are doing so good work. They are doing absolutely fantastic work. And then on that top, if they don't show it out, if Telangana does not show it out that yes, we have talent, then it is waste of time. And Dr. Shruti is here.
Yes.
So they all are doing so excellent.
She is one of the first students from Khammam in LB Nagar and probably student of
long back and pleasantly surprised and feel so happy again. Proud. Her slides were absolutely great. Yes.
Returning back to Organophosphate, they are coming and serving back Mamatas.
Definitely.
Now I request Krishna Sumar sir to give the moment to Ashma madam.
Before that, I want to add one more sentence that Dr. Ranjit Ravel, who was talked about the Paraquat today, has got his fellowship. He has claimed it in his this thing also. From the institute I mentioned in my slides. No. AEMS Kochi. Amrita, sorry. Other than AEMS and Amrita Institute of Medical Sciences. AEMS means not that. Amrita Institute of Amrita Kochi. But Sir is asking why you are quoting other this thing. But thing is that there is a scarcity, sir. AEME should, now you have to promise that India with a very, what is called a confident institution should start a fellowship program. Madam is there, myself is there, Ashok sir is there, everyone is here. So that is, if you do that, I will remove those lines which you didn't like. Thank you.
Can a 66-year-old man can join fellowship, sir?
Why not? You told me something in lunch which we have always echoed. The day we stop learning and teaching is our last day. We are 6 inches into the grave. So learning and teaching is a continuous process, and this is something we have been blessed with. So it is no part. Your only age is a number, but you are still young at heart. and your airways are still very patent.
And I would just add on to it that this year, just 15 days back, I was an examiner for DM Medical Toxicology, the only DM in India at run at AEMS Raipur. And when I got invited, I was so worried. I thought, how will you pull it, Ashima? So I bought a book. I read it because then I opened my, I always had gold franc, but I thought I can carry it in my purse. So you saw that I was carrying a small book. Then I bought Dr. Bibi Pillai book as well. And I read it. I think so for 1 full month, I revised almost everything before I could go as an examiner. And it was so pleasant that the head of department over there, Dr. Shavali, his sister lives next to Mamata Medical College. And he said, would it not have been such a short notice and he had some family pre-commitment, I would have been here to support this initiative. So he runs the only DM program, and if I tell you the thesis content of his students, so they are presently working, because they are working with forensic also, so they are working on the autopsy samples from the adrenal gland in Paraquat poisoning. They are working on gas chromatography for another poison. So this is serious toxicology, which is happening, and it was a well spent 1.5 days where I learned. Not every place you feel that you learn, but I learned that day, those 1.5 days, how people are doing toxicology. And just for information, people think that it is only open for forensic medicine. No, it is open for emergency medicine, MD students, and the DMD students also. So if anyone is interested, emergency medicine, internal medicine, forensic medicine, these all 3 branches can go ahead and do DM. Presently, they have 1 seat every 6 months, but obviously when the need grows, the demand grows, the supply grows accordingly. Thank you.
So talent is there in India. Please make a get-together of all the talent at one place so that it will grow. So I forgot to mention that AEMS Raipur is also one center where DM is available.
Now I request our HOD sir to give momentum to Venkat Kotamaraj sir for coming all the way to UK and guiding us. Now I request Krishna Suman sir to give momentum to Colonel Ashok sir. Sir has travelled 4 a.m. from sir's place to the railway station. Sir has got up at 2 o'clock, so the all night we were.
It was my pleasure, sir.
And I observed sir is writing everything on all sessions. So sir is a great example. At this age, sir can do, at our age we can do much more.
So many new things, sir.
Yes,
So
sir.
I had to write down.
Yes, sir. Thank you, sir. So, Chandrasekhar sir. Now I request HOD sir to give momentum to Chandrasekhar sir.
Sir. Sir, could you look, sorry? Sir.
So, meanwhile, we arrange for the quiz. Let Venkat sir to give international perspective of it. So, we will form the teams and we'll arrange the stage. So, now I give the dais to the, we'll make it the teams now. I will give the mic to sir. So, let them will arrange by then.
Thank you very much. I think we've spoken extensively about toxicology all day. We've talked about it being patients who present unknown, undiagnosed, unwitnessed. Whether you go from Dubai to Delhi or from Durham to Dallas, the sickest patients are toxicology patients. And really toxicology is an interface that is underrepresented, and we join hands with critical care colleagues, acute physicians, public health people. So we have the honor to be able to shape the future of this. I started my toxicology fellowship journey nearly 20 years ago after witnessing cases of paracetamol poisoning being treated badly. That's what fueled my passion, and my passion continues now. And this has led to a place where I've requested Madam under the aegis of AEME that we start a fellowship. And you as young emergency medicine budding physicians, this is something you must consider. Because once you grow into your career and reach a point where I am now, 25 plus years of practicing emergency medicine in a westernized country, you will find that you need to have your niche. Is your niche in toxicology, medical education, critical care, pediatric emergency medicine, pre-hospital, ultrasound, leadership, communication. And this niche has to be something where you're passionate about. And only your clinical expertise that you gain over the years will fuel your passion. Because poison doesn't differentiate whether you're rich or poor, young or old, living in urban and rural. We have low and middle income countries like India, Sri Lanka, the Arab Emirates, which witness poison like industrial chemicals, corrosive snake bites, pesticides. In the Western society, we won't find this, but we find novel fentanyl analogs, polypharmacy, adulterants, novel psychoactive substances. So there is a big global burden of toxins increasing. So what I would urge is, if you consider a fellowship in toxicology at a national or an international level and draw the collaboration, what it will help is you can fuel the next generation. You can improve patient outcomes, reduce their morbidity, mortality. You can become better clinicians. And which clinician can treat hypotension, dysrhythmias, multi-organ failure, tachycardias at the same time? It's only emergency medicine physicians. Not all people can do this. So really, we've talked about lots of toxicology today, and this should fuel your passion. And what has really got me thinking and encouraging is the amount of effort the young physicians have put into delivering the lectures, in arranging the sessions, in moderating the panel. Of course, we are at the fag end of our careers, but we still are passionate because we want to pass this on to the next generation. You are the next generation. You have to fuel the change. Be the change that you want to be in the world. That's what Mahatma Gandhi said. Be the change that you want to be in the world. So if you light a candle, the candle does not harm itself. What does the candle do is it only spreads light. So you should be that little candle which sparks the fire in the forest, because a single matchstick can spark a fire in the whole forest. In the same way, lighting a single candle, shaping a single person's future, fueling somebody. And the best way to learn is to teach. The best way to learn is to teach. So fuel this passion, teach your colleagues, teach your friends, and probably this might be a good opportunity for us to fuel this discussion forward, madam, with AEME as the center of, the epicenter for starting this, initiating these discussions at a national and an international level, and many other medical colleges and young physicians to consider this. And it's a beautiful specialty because you will really make difference into the lives of patients who present unwitnessed, unknown, and undiagnosed. It's easy to treat patients who come in with MI, who come in with a stroke, who come in with polytrauma, because they show you the signs in front of you in one way or the other. But patients who are coming with some toxicological problem, they really prove the challenge. And this is up to you to be able to live up to the challenge and act as toxicology champions for your departments, for your college, and to fuel it and do a lot of research and publications. So please consider this. I'm the international editor for the American Journal of Emergency Medicine, and as well as the section editor for toxicology section. So if you have some research interest in interest to publish cases and case reports, please do consider that as well. So thank you very much to each one of you for staying so long and being very passionate in everything that you do. All I can say is God bless you and continue the great work that you do. Thank you very much.
Thank you so much, sir. The words are so inspiring, and everyone connects to your words, your what you deliver is up top, right, coming right from the heart, and this is what is important. You have managed cases, and therefore you know how important it is to manage them right, how important it is to know how to manage them in the right frame, in the right time. And we are not only here to empower the doctors, we are also here to empower the healthcare, the nurses, the young doctors, because most of the places they are not doing the knowing, they are the ones who are running the casualty yet. So everyone is part of the system, everyone would be helped, and it would be, I should not say it like this, but it would be very pocket friendly, because we are not, none of us are after the money, it is the education which is important. So thank you so much, and with that, we have done next 15 minutes to be our little, on the tenterhooks, because we'll do a quiz and we'll find out few teams who would perform a little better than the other team, although I know all of them are winners. I put round of applause for all of them who are in the first row because they chose emergency medicine. So all of them are winners. So can I have someone with him? So we can always have a combined thing. It is basically EM which we are representing. This chair, number 4 is free. Bhavani, come. Come. You also come. Yeah, and one of you join him. He wants to do it. So he needs a partner. Partner is needed. Come. Yeah, Rahul, come. So we had those boys. You are not not doing. Okay, so sir, so these two. Oh, so we have now 6. Oh my God. Okay, stay there. So now we have 6. Okay, so I am not very sure because I was told 5. So I have put 5 each. So let us, first round, who is the least scorer? We'll try to leave that person out. Who will help me in noting down the marks? Hello, thank you, Shruti. Please help me in noting down 1, 2, 3, 4. We start. I just call them saying 1 so that they come forward. Please help me by noting down the marks. Correct answer 10 marks. Only one answer. Don't do that. Just give one answer because and give it understanding that someone is more than 50 years, so a little hard of hearing. Okay. Wrong answer -5. Pass on is allowed, but only one answer again. So team 1, and the time is only 30 seconds. So who is timing, please? 30 seconds. And the decision of Shruti ma'am is final. If she says 30 seconds over, it is over. Okay? So please don't say no, in my watch it is just 10 seconds more. So team 1, name the anti-epileptic presenting with QRS widening due to fast sodium channel blockade on overdose. Carbamazepine is the correct answer. Good. So you were listening because it was discussed. Good. Team 2. Name the common neurological emergency with alpha blockers ingestion.
Your time starts now. Alpha blockers.
What did you say? We give a, you want to have a try? No. Team 3 doesn't want to have a try. Team 4? Acute urinary retention wrong, but it's okay. Huh? Urinary? Urinary incontinence, no? Huh, yeah? Guys? Alpha blockers, what does it cause? Back to pharmacology. Huh? Urological emergency, it's an emergency. No? Yeah, huh? Yeah, you people use it, yeah. So, good, thank you. So we got this, we got a spider bite also, patient also who had business, and this was asked in DNP as well. And I had only given that question, so I remember that question. Okay, so team 3 please. Name the antidote for isolated benzodiazepine poisoning. Correct answer. Thank you. Team 4. Yeah, please. Name the opioid which causes QT prolongation on overdose. Opioid. No, it is not tramadol. No. Huh? Which one? Negative marking is not there. Once passed out, only positive marking. No, morphine is not there. Very good answer. Very good answer. Super. Yes. Very good answer. Because this is not common. And then the girl. So we move to Bhavani. No, this not yours. Yours, please. Name the drug for treating methylglobalinemia. We were listening to it since morning. Huh? Time is up.
13 seconds.
Okay.
11 seconds. 10, 9, 8, 7, 6, 5, 4, 3, 2,
Pass.
For toxicology, you have to look clues around the bond.
That's what I did in the Very good. Thank you. So now your direct question, which is actually it was for delegates because I did not know, but for you. CSF is to be preserved on autopsy of a dead poison victim for which most common overdose? Any guesses? Because analytical toxicology, forensic toxicology is very important. So it is very commonly coming. It's
that crosses PPP.
Blood-brain barrier would be seen in CSF. So that also you have told. No? Perfect. Any idea here? Alcohols, yes. Any other drug which you have? Alcohol is the right answer. Oh, because they saw recently we were doing a thesis work. So it's the right answer, but there are other drugs also. Would you like to take a try on it? Very good. Perfect. This also, please give them 5 marks. Would you like to take a try on it?
We have discussed.
That is why I am moving like this, because Madam discussed this.
One they have told.
One she has told. Carbon monoxide. Correct. Shruti ma'am was telling one more. Anyone? No. So we move to the. So can you tell us the score?
So for team 1 is Minoman. They have scored 20 points. The original question is plus 10 plus pass on question 2 they have answered, so it's plus 5 for me. age. So 22nd is team 2 with 10 points, and team 3 as well with the 10 points. Just all teams in score.
Okay, so team 6, we will, because we have 5 this, because team 6 did not score, so we are putting team 6 at to the not participating further, and we just go to local events. Now think of local events. What is happening around you? What you are seeing? Keep that eye. Think of that. Okay? We'll start from 5 to 1 this time. Okay? Okay? Each step, the first step, every time you get 10 marks if you solve. Okay? So your first local event. This overdose killed many children recently. It was also called in newspaper as 48.6% tragedy.
Next one, it's not your turn. It's their turn.
Okay, so let us do. Oh my God. So should we do I have permission of everyone that let us continue with them on this, or yeah, because they are students. She was excited.
So spontaneously they go down.
Yeah, so next we'll do one with her and then I'll come to this with everyone's permission. Plus 10 for team 4. Very good. The child presented with mostly cholinergic features. The skin was flushed, warm and dry. What was the actually the first one was antihistaminics and the second was dextromethorphan. So this, you get the answer, right answer for this one. And the third is antidote of choice.
Same team must answer.
Your time starts now.
That also came in papers.
So this is not passing to anyone. So we will, once the time is up, we will.
10 more seconds. Please pick
Antidote of choice. And this was talked today. It was told. Time is up. It is physostigmine. Yeah. So now Bhavani, control your excitement because it is their turn. Okay? So many lose their lives to this addiction and overdose. They are known as huge tragedies.
Madam, this is GK question. You must answer. It's a general knowledge.
So next time onwards, you only. This time, right?
You want to put it as a party shop?
has given a clue as well.
I'll say the local events.
Local.
Adulterated alcohol. Can you come up with something more? Toxic alcohol. Toxic alcohol. We will accept it with +5 or +10. Okay. Let's see the next. Early in the poisoning, they present with vertigo, and soon they get snowstorm vision. And then they develop this syndrome of hypouricemia, hypophosphatemia, glycosuria, some metabolic acidosis. Name this syndrome.
Team 3. Your time starts now.
No, this team only. This team. They are only taking care of this patient.
Okay.
Yeah.
Syndrome.
This also has been discussed.
Today this all was discussed. So this is Fanconi syndrome of methanol by methanol poisoning. Now the third question, you still have 10 marks. Fomepizole, thank you, +10. Now we move to team 3. Ingestion in the wild makes us sick. The anthill umbrellas are my home. Name the poison. Anthill umbrellas.
This is not discussed in the morning.
It is mushroom toxicity. Very good. Very good.
Why mushroom?
Okay, you have another 10 marks coming in. This patient was discharged on day 2, initially cholera, diarrhea, fluid resuscitated, comes back on day 3, totally shocked. Family says whatever she ate, this was properly cooked in the resort where she was staying. So which toxin of mushroom persists even after cooking and drying? What is the name of that toxin? Timer is with ma'am and she says we move. If you remember the scientific name, you will reach to that. What is the scientific name of mushroom?
Why is the girls with that name?
Time is up. Amanito toxin. Okay. Yeah. And then we have still. There are 2 antibiotics actually which could help in this treatment. You name one of it. No, it is not Oxy. And one attempt wrong with it. We don't. No negative marking, but we move forward. It is benzyl penicillin or cetirizine. Yes. We move to the next because time is this. Rotten fishes. The smell is so nauseating. Identify the poison. Rotten fishes.
Something else.
No, that's good. Thank you, sir. They need to be. They stayed here since morning.
We should make them tell them.
Rat poison, very good. 10 marks. They go for the next 10. Rodenticide. What additive to the poison makes it to be vomited out immediately? You know, there is an additive which is put to it. Anyone else has an idea? Anyone? Why it has become, that was added actually, we discussed it even when we were talking of Paraquat, that if you add this it gets the odor, but what gives that odor? No, aluminum phosphate it is. What is the cause? Okay, so we'll come back to the answer next, but first let them have their next 10 marks. Name the drug, this is the easiest, which will help to manage the cardiac arrhythmias associated with rodenticide poisoning. Very good, magnesium sulfate, very good answer. Team 1. Sir, exact, I will tell you which studies it is there in my, this, I will come back on that. No, it is not illegal. It is not baby cancer. I will come back. Burning buses and bitter elements. Identify the poison. Burning buses and bitter elements. Both together. No negative points. Cyanide poisoning, correct and mark. Please very worried. No negative points. No negative points. Negative points is there.
He's taking a risk, madam.
Okay. Hyperlipidemia distinguishes this poisoning from another one. That is also a possibility in same scenario: burning buses, burning houses, burning goods. Carbon monoxide poisoning. Correct. Another then. And this is a little tricky one, but this is LED kit. And if you haven't answered it because we had a class on it, am I right? Sodium nitrate.
remind us of the devil weed. D is dysarthria, D is dysphonia, these series of these, and this poisoning is devil weed.
Like it was discussed.
Yes.
Toxin, what is that weed?
Yes or no? Is the series of these defining the toxidrome of devil weed? Yes, correct answer. Paraquat is an alternative to treat ventricular irritability in digitalis toxicity. Yes or no? Paraquat is an alternative. If nothing is available, this one is wrong. No marks, no negative marking. Macular sign is characteristic of cocaine toxicity. If you have an idea of macular sign. Very good answer. Plus 10. Super answer, man. Very good. Not only you know it is not, you know what is the right answer as well. Blood alcohol level somewhere between 50 to 100 milligrams can make the victim stuporous. Stuporous. More than 100 makes it very good. Correct answer. Plus 10. So now, this is the last round, friends. We start from here. It is filling the blanks because completeness matters the most. You can, dash has been used as a performance enhancing drug by bodybuilders. Steroids, very good. Correct answer. Any other? Any other performance to build body?
What is the anabolic other drug?
Other than steroid. Because steroids they will find out in their urine and blood and all that stuff. So, what is the other drug which will not be found out? And it is a hormone again. Not growth hormone. Okay, so here we have one pass on. This was 10. We can give 5 because steroids is also correct partially. Can anyone tell which is the other? You are in bodybuilding, huh? No, not creatinine. No. Which one? Insulin-like growth factor. Correct. Yes, plus 5 to them as well. So this is Will-Rose, and if I am correct, or Will-Rose color of urine occurs when dash is used for iron poisoning. What is used for iron poisoning? That the urine turns rose in color. Correct? That's correct, Samir. Very correct. Super. We give plus 10. Double bubble sign in direct chest X-ray. She showed also. Is suggestive of which poisoning? Double bubble, not double coin. Double bubble. Somewhere it was shown today. Yours? But which poisoning can cause that? So that can be alkaline acidic entry, but what can cause something which is used as a fuel for homes where gas is not there? Kerosene, correct, perfect, and the active principle in ganja. THC, very correct. So it is 1 to 2%. And the last question of the day is, dash is used to block the enterohepatic circulation of thyroid hormone in case of overdose. Levothyroxine case which had come. Cholesterol, correct. Thank you, friends. Okay. So can we have the marks now, please?
Combined with the round, all rounds, no?
This round is only for to decide if two people are of the same. Okay. Team 1 55.
Team 3 is 20.
Team 3 is 20.
Team 4 is 30.
Team 4 is 30.
Team 5 is 35.
Team 5 is 35. So we have, because we have 55, 40 and 35 a clear mandate. So this round was only to check if the mandate was equal in two teams. So we congratulate HOD sir. Where is HOD sir? Mahendra sir, you have to do the honors now. Team 1,
Team 1 followed by Team 2.
Team 2
followed by Team 5.
Team 5. Yourself, na? Correct. So Nizam's Kakatiya Medical College, ESI Medical College. Thank you so much, and everyone. Actually, thank you everyone for keeping up with me on this. This presentation is there. You can always check it out. It's perfect. Thank you.
Sir, ready, sir? Ready? Sir?
Now I request Dr. P. Khammam sir to give this moment to her second place. Please.
After close, you have given answer.
Madam. Sir, ma'am.